this is something sometimes that bothers my mind. But anyway, we just focus on the topic today with regards to our medical practice, because we choose this profession and we want to do it the best. So let's move on. Next slide. So I have a few topic that I want to discuss with you on this professionalism and ethics. And when we talk about professionalism, the component of leadership is very important, which I will describe as we go along, describing the term professionalism. Next. Next. So as we all agreed that the outcome of our educational journey as a medical student last time is that we at the end of the day, upon graduation, we have all the basic knowledge and enough skill to start our life as a doctor. It's only at the beginning, and that's supposed to be the professionalism that is expected of house officers. So for medical teachers at medical schools, their greatest challenge is to inculcate the right attitude and motivation in the minds of these would-be doctors. So, but that is not, we does not stop there. So when we become housemen, the consultants, the specialists, they also have, they also play the role as teachers. Although many of them did not realize that they are supposed to be teachers, because they are teaching their junior colleague to learn and practice medicine safely. So, but whatever it is, theoretically, when we embark on a journey to become a doctor, it is actually a journey of transformation. And we want to become a safe practitioners with good manners, with good adab. So that is our purpose of learning. At any time of learning, we must have that in our mind, that we want to change ourselves and change others whom we profess to serve them. Next. So in all medical curriculum, usually at the end of the expected educational outcome would be safe doctors who have basic competencies in professionalism, leadership, ethical decision, and many more, which we can add on to the list, such as some basic information about medical law, medical ethics, and then of course in our context of this university, the what you call that, the maqasid, the ethical decision from the Islamic perspective, Fiqh medicine. All these are part and parcels of the competencies that we need to help inculcate in the minds of our students. So the whole issue is to help people learn, help the student learn that at the end of the day, they are supposed to, all of us are supposed to manage our patients in the most professional manner. Next. So as senior colleagues, as medical teachers, we should play the role as mentor and role models of professionalism, of leadership, and so on, because we want to guide them to understand, internalize, and actualize of what the journey means at the end of the day. That means they are expected to function as a safe practitioners, as safe doctors. So for doctors, even trainees, like the majority of you are trained to to guide yourself, to tell yourself of your responsibility, that you want to practice medicine safely, and in the process you also need to help your colleague, your junior colleague, the students around you, the importance of transforming oneself to become safe practitioners. This is our obligation. Next. So to me, a safe doctor is being professional, meaning that we are well-trained, certified, and able to serve patients with confidence. As in this example, a safe doctor educating patient about a patient control analgesia for post-op pain relief, because the goal of care is that we want to get patients who are happy with the treatment. They're happy, they are pain-free, and they can recuperate in a better way and get discharged home as soon as possible. Because when we get admitted, you know, it is a different environment. We want to get the diagnosis, we want to get the treatment fast, and then be discharged as soon as possible. That's a normal person. You want to do that, and with that in mind, we want to help our patient to understand their whole journey to recovery. So that is part and parcel of being professional. Next. So let's go into the meaning of professionalism. Next. Professionalism is what patients describe about a doctor's performance and their first impression. So when patient comes, when we meet our patients the first time, so we we should be aware at the back of our mind that that the patients that our patients are actually looking at us, whether with confidence or with some reservation, because of the way we talk, the way we dress, maybe the way we answer them, the way we educate them. Because first and foremost, if we describe ourselves as a professional, that means it is our commitment, it is our pledge, our promise to give our best. So professio in Latin means to pledge, to commit. And ism is manner of action or behavior characteristic of a person. In our context is as a doctor, as a safe doctor. Next. Because we know that patients demand us or expect us to demonstrate high level of professionalism. Because the word professional is so common that we often hear in people's complaint over the internet, in the newspaper, things like that doctor is not professional, very rude, always in a hurry. So that defines the expectation of the people about our duty as doctor. We are in the era where we are practicing patient-centered service. So that means patient has got is identified and acknowledged as an important stakeholder. So that's why we need to have some practical definition of professionalism, which I describe it as 2 E's and 2 C's of professionalism. So the 2 E's are expertise, ethical, and the 2 C's are communication and compassion. What it means is that if we describe ourselves as a professional, we need to ensure that we have the necessary expertise, and we are able to deliver our duties as in the most ethical manner, and we are able to communicate with compassion in a way that patient can feel that we are caring. We have that caring attitude towards them, and we are interested in their problem and want to help them. Okay. So professionalism is the result of right education. So in medicine or in other profession also, we need the right teacher, the right mentor, the right environment. So and as we enter a profession, it should be a lifelong learning process. It is a process of transformation, and transformation means we are focused to what you want to be at the end of the day. So that's why when we teach our students, we bring that, we help them to visualize in their mind that at the end of the 5-year journey as medical student, they are supposed to change. So this is the importance of education. Education is supposed to bring about transformation, positive transformation. So if we train our junior colleague, our house officer, medical officer, that means our duty is to help them. I mean, at the end of training, while training all the time, that means our focus is to have a safe, safe practice and not causing harm to our patients. Next. So I would like to reiterate that professionalism is something that we must develop. At least we have this practical definition of being an expert, able to give our duty, our performance in the most ethical manner, able to communicate with compassion. And that is the outcome of education that we receive, at least. Why I choose to have only 4 attributes of professionalism? Because it's easy to remember. Because if we look at the literature, there are many definitions about professionalism, and most, of course, define the attributes of a safe practice. Some have 7, some have 9. I choose only 4 because it's easier to remember, and at least we should strive our best to develop these 4 attributes. That would be good enough, inshallah. Next. So ethics describe the behavior, our behavior during patient care that win the trust of patients. And when we are perceived as being a caring doctor, that means we are able to listen more, rather than listen attentively, have empathy and sympathy, and be able to communicate well, and then help them understand their problem, and help them to be with us in going through the management, so that at the end of the day they want to achieve recovery of their problem, rectify their problem. Next. So in short, a safe doctor should be one whom the patients perceive him as a professional. The impact of first impression is that they think that we are trustworthy, we are firm, and we can educate them in the best manner, and they feel that they would like to follow our advice because of our good leadership quality. We are sensitive to patients' other needs. For example, I mean, we need to be aware of patients' needs, such as their religious need, or their belief, their norms. All these things are something that is very important. And when we talk about good communication, the focus is about the goal of care. So we have many the framework of communication. Great communication is very important. Great framework of communication. What I mean to say is that something that we need to learn and make it our practice. Next. So the great framework is GREAT. What it means is that when we see a patient, we greet them, and we are clear in our mind about the goal of care that we want to offer to our patient. We call them by their names, and then to show respect in order to gain rapport, we explain, educate, and have empathy. And then we need to affirm our goal of care with them, make sure that they understand, and give time for them to ask questions. So because at the end of the day, patients need to take the action of what we want to help them. So once they agree, they understand, then we thank them. So this is some small framework that we can use when we see our patient to enhance our professionalism as we go along in our duty as a medical professional. Next. What about ethics? Moral and ethical in the Western context are often used interchangeably. Moral usually refers to an individual's personal values or principles as to what is right and wrong, what the community, what a nation believe. All these things is regarded as moral. Ethics refers to rules, principles, norms, and values that are external to the individual. Such as the medical profession, we have the code of ethics for doctors that we need to adhere to, and as a good doctor, we need to address all this issue, or else we may end up in trouble when we are perceived as not doing our duties in the best manner. Okay, so this is something that we need to improve, continuously improve as we go along our life, our career as a doctor. Next. The morality and ethics of a Muslim are not derived from what we believe, but we are guided by by the Islamic worldview, which is a product of sound faith in Allah SWT. So the spirituality aspect is divinely guided, especially when we talk about moral ethics. Is about the spiritual conviction that we want to practice in our life, and that would be reflected in the way we see our patient, we help them improve, we let them recover. So these are the things that we have to continuously improve in our life, inshallah. Next. The moral and ethical values of Islam are based on divine revelation, as I said earlier. Next. And when we talk about ethics, remember just now the two E's and two C's? Ethic is one of the attributes that we need to develop, and it is one of the attributes that of professionalism that we need to improve all the time. Because a trustworthy practitioner portrays professionalism, and then has good leadership quality, know how to respect our patients, pleasant first impression, have patience, and very passionate and to help patient. So this is something easier said than done, but we need to remember about all these things, because we are in this profession. We want to give the best to our patient, inshallah. Next. So in Islam, the term ethics is used synonymously with akhlaq, adab, or Islamic virtues. Ethical decisions are guided and or influenced by the universal ethical principles, the religious beliefs, customs, and law. So this is something that we need to be sensitive when we see our patients. Always be aware of their religious convictions, their norms, and of course we need to know the law of the country the place that we practice. So we have to be aware of all these things, because it helps us, it guides us in making some difficult decision for the patients. Next. Medical ethics is a decision-making process, and this is something that we need to learn. And it's not easy, especially when we teach medical students, because it is a process that means to really determine what is right or wrong, and to choose better option over a worse one is something that need to be learned and guided by those who are more experienced from us. So the difference between what can be done and what ought to be done is the reason for medical ethics. So medical ethics is about decision making, especially so when we are making a decision in a difficult situation, particularly that concern with life and death situation. Next. So what are the ethical principles? All of us need to know this, the ABCDE principles, which are autonomy, benefit, confidentiality, do no harm, equity or justice, or most people just apply these four principles, four universal principles of ethical decisions, which are autonomy, beneficence, non-beneficence, and justice. So these are the main guide when we talk about ethical decisions. Next. So respect for autonomy is important, acting in accordance to what the patient wants, okay? But of course, if patient wants something that is against our belief, say for example, if patients wants euthanasia, for example, euthanasia is not allowed in this country. Maybe in some country, Luxembourg, Holland, they allow it. And in some state in Australia also, they are working hard, fighting hard for it, not to to entertain the request of patients to perform euthanasia on them. So this is something that that is dynamic. Some country are fighting for it, and that's the that gives us dilemma as a doctor, whether or not to act in according to what the patient wants. Because we are, let's say, if we are against euthanasia, how can we respect their what the patient wants? So this is where the best practice, the law of the country needs to come in. That means the law, the policy maker, the lawmaker of the country. So this is has to be included when we want to embark on this, but not in Malaysia yet. So beneficent acting to benefit the patient. Confidentiality is respect, and then not to spread about their disease, and then to respect their wish as to whom that we need to disclose their prognosis, for example, whether to some close family member or to whoever. So we have to respect that. And of course, do no harm is basic for doctors. And all the time we would like to pay attention to justice, paying attention to fairness and the availability of the facilities available in the hospital, such as the ICU beds and so on. Next. So basically, ethical decision is professionalism in action, because to behave professionally in a situation of a dilemma, such as in life and death matters, we at the same time want to respect patients' autonomy, but at the same time, there are other things that we need to consider. So that means ethical decision become very difficult and can be very challenging. Bear in mind that patients' autonomy must be respected. And of course, it's to stay cool and control our anger. It may not be easy. And this is interesting. Non-beneficial medical treatment. Clinicians are not obliged to initiate or continue life support treatment. For example, this other example, because some patients, the family member, they can demand the doctor that they want the patient to be intubated, to be put on a life support machine when doctors think that the prognosis is not good. So sometimes this happen, and how to make them understand, that is not to the benefit of the patient. So this is where professionalism, the degree of professionalism is important. Okay, next. So when we have some code of ethics, some guiding principles from our professional body, it makes things quite easy. So for example, this MMA Code of Ethics 2001 states that where death is deemed to be imminent and where curative or life-prolonging treatment appears to be futile, ensure that death occurs with dignity and comfort. Such futile therapy could be withheld, withdrawn, or one may allow irreversible pathology to continue without active resuscitation. So this is where, if you all know, that that for ICU admission, there are certain criteria which patient, to be given the life support. There are the various categories. So because we need to be fair, because the availability of the life support machine is not many. So that means we need to have some admission criteria. Okay, so this is where ethical decision is important, and the presence of certain guidance, certain best practice guideline is important for us to make a good decision. Next. One should always take into consideration whether or not there are advance directives and the revisions of the family in this regard, whereby usually people are very sensitive and they may have false belief that when a patient is put on a life support machine, that means the patient may be safe, the life may be safe, but it's not the case at all. All the time. And this is where the family member, and of course it includes the general public, must need to be educated, because not every life support procedure could save life. Okay, so and they should be able to understand that if we withhold the life support machine, it is for the good of the patient. So this is something that is difficult to do, and we need a continuous a good system to continuously educate the public about this issue, about when to give the life support machine, or when we really would want to consider giving it, because we feel that the patient has high chance of recovery. Because there are patients, there are families who tell us that please do not do anything, because to them patient is very critical, but to the minds of the doctor, the patient is not critical yet, you see, and to convince them that the patient needs life support is not so easy. I have encountered such situation before, where patients family doesn't want us to put the patient on ventilator, and we told them that there is chance, and finally the patient improve and get discharged from home, from the ICU, and get better. Okay. Thanks. Next. So in making a good decision, ethical decision, it involves three parties. Mainly the patient, if the patient is conscious, the family member, who are the surrogate decision maker, and of course the health professionals, doctors, nurses, and all that. Okay, usually the doctors. Okay, next. So as for patients, because it is not yet common in this country for us, including us, because in this country, the awareness of the public with regards to advanced directives is very limited. Okay, we are trying to improve that. We means we do it through education, through the society, the professional society, that things like advanced directives, advanced medical directives is important. okay, which when we talk about advanced medical practice, we are talking about a document, legal document, stating the patient's wish. Should they become, what you call that? Should they become unable to make decision on their part, which they have, what you call that? Which they have expressed their wish earlier on. Okay. Next. Majority of patients requiring ICU admission will be unable to engage in discussions, and of course, that's where the wish need to be written or being expressed or discussed with relatives. Okay, and this is very important. But somehow we are still. This practice is still not common in the country. Next. Okay, when we talk about the end of life decision, for example, the surrogate decision maker, be the caretaker, usually the spouse, the children. To make them understand, to educate them about the best treatment, the best option for the patient is often not easy. So that's where the family conference in the ICU is important, where all the doctors, the primary unit that refer the patient, the intensivists, and sometimes we need to include the nurse also. It's very important for us, okay, to make the best decision. And the decision are shared medical decision made by clinician and agreed upon by family members. Next. Families need to have clear explanations of their relative's condition, the purpose and limitations of treatment. That's where, in our practice, the moment we decide to have patient to be connected to the life support machine, it's very important for us to identify which caretaker that we need to communicate all the time, right from the beginning. That means at the beginning, they must understand why we put the patient on the life support and what is the prognosis. And of course, we need to make them understand that there is always two possibilities. Either the patient is on way to recovery, full recovery, or otherwise that patient may just not improve and may deteriorate. So this is something that we need to have it clear in the minds of the surrogate decision maker. So that means a good communication with them, effective, frequent, and timely communication is very important. A show of respect to them, and it also increases satisfaction with care, and hopefully reduces anxiety in grief situation when the patient did not survive. Okay. Next. So it's important for clinicians to be able to elicit and respond to families' views and concern, especially with regards to matters of the meaning of life and death for that family, which is usually influenced by their religious viewpoint or this thing. So this is where we need to be sensitive. Okay. So quality of the discussion is very important. And the setting of the conference, family conference, in a good room, comfortable environment, which many hospitals did not have that ideal situation, and which need to be improved, because in a time of anxiety and grief, the family needs a good environment to talk to understand the patient's condition. All these things is important for them to be able to digest the whole issue, and can easily agree to the suggestion by the doctor that patient is is not improving, and doctors think that the best thing to do is to withdraw the life support, for example, and what to expect if we withdraw the life support. And at that time, they need to prepare their mind that patient is towards the end of their life. So this is the kind of discussion that we need to have with the patient's family member with regards to the decision to take, especially when we think that patient's condition is not going to improve, or in other words, is to be of no benefit. The prognosis is poor. Next. So basically, it's a shared decision making, and inconsistent message and non-collaborative interprofessional behavior usually results in family dissatisfaction. That means we should not, patient should not have a conflicting message from the anesthetist different, from the surgeon different, from the physician is different. Then it's not good. That means decision making, it has to be consistent, and then it involves a team with a clear and uniform concept, so that the message is consistent, and the family can take it easily, inshallah. Next. So if the patient is dying, then we need to give comfort, treat them with dignity, respect, and compassion, respect their privacy and confidentiality at all times. Next. So as I mentioned earlier, decision making on withdrawing of life support or forwarding the life support is not easy. It's a process, and communication is very important. And then and gaining trust between families and clinicians is really, really important, so that we can anticipate and be realistic to face the reality and the eventuality of dying. Next. So this is these are practical issues which I don't think I want to go into the details, but basically we need to have good communication. We understand the plan, and then we can educate the caretaker that when we want to withdraw the life support, there are procedures. Let them understand the procedures, what it means, and then we document all those things. What's happening, the event, and when death occurs, the notification of death is very important, and management of grief is very important. So it's a multidisciplinary approach that we need to consider, and we are doing that in our hospital. Only thing that we need to do is to further improve if there are issues, if there are if they need some improvement. Okay. Next. So in summary, end result of education is improving professionalism. Okay. And of course, at the end of the day, we want to be a professional doctor, a good doctor. And not only that, a safe doctor with good ethics, with good adab. Patients feel that we are good. They want to trust us, and they know that we are serious, we are very committed, we are caring. Next. So for our students, we have the Islamic Input Medical Program curriculum, which is the personal and professional development for them, so that at the end of the 5-year journey, they are able to start their journey as safe doctor. For all of us practicing doctors, we need to understand the core values of the hospitals that we work, meaning to say that we need to know our hospital's vision and mission. For Ministry of Health, they have this professionalism, teamwork, and caring as their core value. So this is something that we need to do as safe doctors. That means that is the professionalism that is required of us, expected of us. Okay. So we cannot just follow what we think. We need to adopt and understand the vision and mission of our hospitals, and be with the organization. Okay, next. So for all of us, especially for you as future specialists, it is your duty and it has to be your commitment to teach your junior colleague. Okay, so you must you should be able to impart good values. You should be able to become a role model for your juniors, because this profession is unique. This profession needs a committed person who understands the patient's need, who wants to help them, who wants the patients to have a good recovery from their illness, and be realistic at the same time. If the patient is not going to improve, so this is there's a lot of things to learn. So there is a continuous learning that we are practicing in this profession, because we can't afford to be lacking in professionalism, because patients need us, need our attention. If we become patient also, we need a good doctor to help us. I've been admitted at least 7 times in my whole lifetime. So I know what it means to be having good doctors who are attending to us, good nurses who knows our need and can be preemptive and help us in in undergoing our treatment, for example. So these are the things that need to be pondered all the time, especially when we see our patient. And when we see our patient, always think on our mind, what is my goal of care for this patient, and how do I want to help my patient to be better, get them discharged as soon as possible. Because being a patient, to be in a hospital is something that is boring. Even though you stay in first class ward or whatnot, it doesn't really matter. What matters most to you as a patient is you want to get out of the hospital as soon as possible. Wallahu a'lam. I think that's all. Thank you for listening. Assalamualaikum.
Waalaikumsalam. Thank you very much, Prof. Dato' Arif, for that wonderful sharing about ethics and professionalism. If I can repeat back the characters of professionalism I've mentioned just now by Prof is 2 E's and 2 C's, which is we need to be expert in our field, we need to be ethical in our character and also our behavior, we need to be good in communication skills and compassionate to our patients. I would like to open the session for question and answer to our beloved Prof. Any question from the participants, panels, as well as from our colleagues as well? If no question, I just would like to begin with one more question, Prof. Arif. Is that okay? When we're talking about family involvement and also confidentiality of the patient, like say patient disease and also condition, I know it's quite clear in terms of, let's say the patient have cancer, patient has a disease with stigma, STDs, and so on. So we need to maintain and protect the confidentiality of the patient. How's about a disease like chronic disease? Because sometimes we need to involve family members about the details of the disease so that family members can monitor and can involve in the compliance of patient towards treatment. So at what extent that we cannot actually tell the family members, or we need to get consent from patient to any details regardless of any disease, Prof?
So to answer the question, there is no one straight answer. It depends. It's always to be. We have to individualize to the patient's need, and of course we need to understand their family. The caretaker's belief also. So, but most important is from the patient's point of view, whether they agree or not that that their chronic disease is need to be shared with trusted family member who are there to help them go through their ailments. Chronic disease is something that is really chronic in your mind. So is you have to think about the patient's need all the time. As a good relative, you need to know also, you need to learn a lot about the patient's condition. Chronic disease, for example, on dialysis, for example, it's not easy. It's a lifelong treatment on dialysis, and then patients may need organ donation. So how to educate the patient's family, how to respond to their spiritual need, for example, and then not to forget their daily sustenance when they don't have income, they a lot of things. So that means the stress is upon the whole family. So that's where the spiritual support, the family support, the social support is very important. Sometimes the presence of the experience from other patients is also important. So that's where the community, the NGO is plays a role. So like in my case, handling the NGO for dialysis. So we also concerned with some of the issues that patients has with their family, and then they know that the dialysis is just there to help them survive, and it's not a cure. And then the family need to know that that is the situation, and how to go about throughout their life to help these patients for our treatment, and then the journey 1 hour to the center and 1 hour back. So it's a hassle to the family. But if the family member understands the patients also, give consent for whatever things that need to be done on them, then it's much easier. So that's where the creativity of the doctor is very important. So I hope I understand. I answer that.
Thank you very much, Prof. Dato. Any further question from any participants or panels? If there's no question, we were informed that this is actually the last few days of Prof. Dato Arif with IIUM. So we would like oh, this is the last day. Okay, Prof. So we would like to capture this moment and memory with Prof. So I think we need to take a picture together. Maybe I pass the session for a while to Dr. Adil. You guys can switch on your camera so that we can take a picture together with Prof.
So 25.
Okay, so if everyone can switch on your cam. Oh. Okay. Take for the first pin. 3, 2, 1. Okay, second pin. 3, 2, 1. And last pin. 3, 2, 1. Okay, thank you.
Thank you, Dr. Adi. Thank you very much, Prof. Dr. Arif, for spending your last day in your during our session. I think it's very historical for us. We pray that Allah bless you always and take care of your health, and inshallah we will interact as usual as possible. Thank you, Prof. Dr. Arif.
Okay, welcome. Thank you, everybody. Okay.
Now I would like to pass the session for group presentation to my colleagues, Dr. Harunisa from Department of Pathology and Laboratory Medicine. So she will be the moderator for the subsequent session until lunch. The session is yours, Dr. Harunisa. Thank you very much.
Assalamualaikum warahmatullahi wabarakatuh. Okay, so to make this short, just a few housekeeping announcements before we start the group presentation today. So we have 12 groups presenting for this morning session. So we have to really keep to the time allocation because we have a lot to cover today, inshallah. So please, each group, please keep your presentation within the first, within 10 to 12 minutes, as to allow about 5 minutes for the expert panel to comment and to open the session for Q&A for those who have burning questions to ask, inshallah. Dr. Salma Hanim from Rehab will help me as timekeeper. So she will ring a bell after at 10-minute mark. We hope that the presenter can conclude the session within 2 minutes. But if let's say you exceed the 12-minute mark, she will again remind the presenter to conclude the presentation. And during the group presentation, we hope that other group members that are not presenting can switch on their cameras so that we will know who's the group member, inshallah. I think without further ado, I would like to, before that, I would like to, I think the expert panels that are here with us today, I think from Kulliyyah of Medicine, we have Prof. Prof. Aminuddin from Orthopedic Department. Thank you, Prof, for joining this morning session. We also have our expert panels from Centris, Center of Islamization. We have Dr. Hasbullah, the Deputy Director of Centris, and we also have Dr. Ibrahim Adam Ahmad Shogar with us today as our expert panels. So, all right, without further ado, I would like to invite our first team for today that will be discussing on wakaf and the complementary contemporary issues on wakaf. I would like to invite this group.
Share my slide. Can all of you hear my voice?
Yes. Please begin. Time is running.
Everybody can see my slides.
Yes, yes, we can see slide. Can you switch on to the presentation mode?
Assalamualaikum warahmatullahi wabarakatuh. And good morning. So my name is Dr. Nusha Mimi. Actually, I am representative from my group together with Dr. Rehman Naidu, Dr. Vinoshni, and Dr. Sarah Masrin. We are going to present about wakaf, and our supervisor is Associate Professor Dr. Muhammad Iman. So these are our outline of presentation. We are going to discuss about definition of wakaf, importance and benefit of wakaf, and explain the role of wakaf in medical practice. And in the end of the discussion, we are going to discuss about two scenarios that we given to us previously. So, what the definition is? What is the definition of wakaf? Wakaf is actually originates from the Arabic word waqafa, meaning that means hold, confinement, or prohibition. As a term, it has not been specifically mentioned in Quran or Hadith, but follows interpretation made by fuqaha on sadaqah al-jariyah. In other words, wakaf actually is the permanent dedication by a person professing the Islam of any movable or immovable property for any purpose recognized by Muslim law as religious, pious, or charitable contribution. It typically involves donating a building, plot of land, or other assets for Muslim religious or charitable purposes with no intention of reclaiming the assets. A charitable trust may hold the donated asset. Wakaf is not only restricted to building mosques, reserving lands for burial grounds or graves, building schools, but broader, which includes education, financing, corporate work, and health. So wakaf actually consists of 4 elements. First is a donor, or we call as al-wakif. A donor must be willing, not forced, to contribute wakaf. It must be a Muslim who is independent, mature, or baligh, and mentally sound. It is according to the administration of Muslim law of act. Secondly, wakaf must consist of asset or al-mawquf. The asset that the donor intended to donate must be physical in the form of property or cash. It must be owned by the donor itself, perpetual, and can be used forever and permissible in Islamic law. The third is the declaration, al-sirah. The declaration can be verbal or written. it must be specific or general. For example, like for specific declaration, it is a clear pronouncement such as I intend to wakaf my house for the poor. For general declaration, stated that a general pronouncement such as my assets are for charity for the poor. And the fourth element is the beneficiaries or al-mawquf alive. The beneficiaries of the wakaf can be include a specific recipients such as and general groups such as orphans, mosque, madrasah, and the poor. And then wakaf actually can be further divided into three categories, which is family wakaf or public wakaf. So for family wakaf or wakaf khas is actually wakaf that dedicated for private individuals like family and relatives. Meanwhile, for public wakaf or wakaf,
May I interrupt? Some people are having problem with your audio. They cannot listen.
Hello, can you hear me now?
That's much better.
Okay. So I proceed. So for public wakaf or wakaf actually wakaf dedicated to the public large. It is generally for the welfare of the poor and the needy, colleges or hospitals. So importance and benefits of wakaf. Wakaf actually brings wakif or the donor continuous rewards as hasanah as Allah Subhanahu wa Ta'ala stated in Surah Al-Imran ayat 92. Never will you attempt the good reward until you spend in the way of Allah from that which you love, and whatever you spend, indeed Allah is knowing of it. So it is based on practice of Prophet Muhammad sallallahu alaihi wasallam and companions who were always striving to donate their properties to promote good faith. The companions strive to contribute to wakaf when they learn about the advantages to the donor. So therefore, when wakaf is well managed, it actually can enhance the social welfare. It increases security in the community. It can create self-sufficiency and financial independence for community assets such as educational institutions. So the role of wakaf in medical practice, wakaf actually is seen as a very important economic instrument in Islam. As we know, anybody whether rich, middle class or from poor backgrounds are not exempted from the leases. In addition, increasing healthcare costs does not take into consideration the factor of affordability, whether patients can afford to bear the medical cost or otherwise. Moreover, for the needy and poor people, the current cost of treatment is beyond their means, and so the alternative route for them are via health wakaf. Therefore, via wakaf, it actually can reduce health problems and increasing societal well-being. Socioeconomically, it plays a major role in providing services, including healthcare services. It is also act as alternative to hospital financing based on maslahah or the Islamic principle of public welfare. So moving to the case scenario, for the first case scenario, a medical doctor would like to use money from wakaf to begin a new service in the department clinic which requires some financial assistance. Example, men's clinic or diabetic clinic. So it is appropriate. So from our discussion, we think it is appropriate to use money from wakaf. This is because wakaf is a unique form of virtue within Islamic teaching, since it is a way of worship that incorporates spiritual aspects and material. Wakaf has also proven to be a strong instrument to reduce various burdens of life, both economically and socially. Healthcare wakaf consists of building of hospital, purchase of medical equipment and facilities. It can give benefits for those who are sick. Hence, wakaf can be the main source of healthcare services, especially for the poor and the needy. So we We can see that health wakaf has been implemented throughout the history. So it actually begins with Rasulullah sallallahu alaihi wasallam era for health wakaf during Battle of Khandaq in year 627. The health wakaf actually was practiced after Sa'id bin Mu'az was injured and treated in a separate tent. During that time, Umi Rufaidah binti Sa'ad, which was a first Muslim female nurse, was assigned to take care of patients during the war. Years later, under wakaf, there are 3 types of advanced medical facilities that were introduced. It consists of dispensaries, hospital buildings, and emergency treatment in centers. In addition, there are 4 successful Islamic healthcare institutions based on health wakaf, such as Bimaristan Al-Dudi, Bimaristan Al-Nuri, and Bimaristan Al-Mansuri, and also Dimnah Al-Qairah. So, for example, like Bimaristan Al-Dudi, it was the first wakaf hospital which built by Caliph Adhud Al-Dawlah during the time of Harun al-Rashid. So it has the best medical equipment, doctors, nurses, and health consultants, and the staff actually even got salary from the Caliph. So in fact, in Malaysia, health wakaf is actually being managed by Wakaf An-Nur Corporation Berhad, which comprises business and social units. It even owns 24 clinics, 26 hospitals from Malaysia, and 4 hospitals abroad, and only charge 5 ringgit during medicine.
2 more minutes, yeah.
Other example also like USIM Health Specialist Clinic on wakaf was mooted by former USIM Vice Chancellor. Health Specialist Clinic partly funded by the USIM Wakaf Al-Abrar fund, which was set up in March 2013, and the first public higher learning institution to establish healthcare wakaf in Malaysia. Moving to the scenario 2, a hospital that is running based on wakaf charge patients that require blood assessment at private center according to the charge that is set by center without giving any waiver of fee. Is it appropriate, and what is your opinion on this? For us, we think that it is appropriate. When we revise about health and wakaf, actually wakaf is actually Islam's unique instrument apart from zakat, infaq, and sadaqah. It has proven to be a strong instrument to reduce various burdens of life economically and socially. Many sick and poor people in various countries may have benefited from wakaf. Many wakaf institutions exist to solve health problems that lead to a better life for the poor. Meanwhile, for the health, it is actually institution that provide medical service, medicine, medical staff, insurance, everything related to patient health facilities. As we know, today treatment is a serious concern. It is expensive and we cannot fully depend on the government's assistance and subsidy. So there are one study from Sulistiawati, which listed 8 issues and challenges in the healthcare wakaf. One of it is a lack of funding or financial. So in her study, it stated that because of lack of funding and financial support, we limit the utilization of wakaf-based health resources. So currently, most of wakaf-based healthcare foundations such as hospitals, clinic, and non-permanent healthcare institutions from developing countries are facing financial crisis which hinders institution sustainability. This is because of due to mismatch of supply and demand of wakaf funds. So therefore, she proposes income variation to achieve financial independence. For example, like subsidiaries of wakaf-based healthcare institution can cooperate with pharmacy companies, coffee and mini markets, parking service providers. All kinds of wakaf and other Islamic social funds should synergize with other sources of social funds to limit wakaf to other healthcare service with the needy people. Wealthier patient, it means that wealthier patients paying for their treatment at the commercial market price. So it serves as wakaf investment. So however, we need a strong political will in the form of legislation or regulations as the legal basis of the initiative set up the health wakaf. In Malaysia, there are legal basis are enacted in order to improve Malaysia's wakaf system in the terms of administration management, such as Administrative of Islamic Law, Selangor Wakaf Enactment number 7 of 1999, Authority Act 1949, Act 200. So in conclusion, wakaf practice is a sunnah that is highly encouraged in Islam. History shows wakaf has helped Muslim a great deal since Rasulullah SAW era and in succeeding era of Islam. Healthcare wakaf is of utmost importance today, especially with the spread of critical illness, which need costly treatment that is beyond the financial means of world. Lastly, I would like to quote a hadith narrated from Abu Hurairah radhiyallahu anhu. Rasulullah sallallahu alaihi wasallam say, when a man dies, all his good deeds come to an end except 3: ongoing charity, which is sadaqah jariyah, beneficial knowledge, and a righteous son who prays for him. So with that, I end my presentation. Thank you.
Thank you very much, Dr. Nushamini. Yes, wakaf is very important. Is involved in fiqh muamalah and very important, plays an important role in especially in health and helping the needy in our community. I would like to invite our expert panel to comment. We have Prof. Amin, Aminuddin. If any comment, Prof.
Assalamualaikum. Thank you very much for a very good presentation. I'm not comment, but I'm to ask a question. Maybe our other expert panel, Dr. Hasbullah and Ustaz Rahman or Prof. Nazri or Dr. Prof. Ibrahim as well, maybe can respond. Wakaf in terms of a definition by what you are saying just now is mainly for the asset. How about the wakaf tunai, the cash wakaf? Okay, because most now I think a lot of foundation bank offering the wakaf tunai, and IIM recently come out with the wakaf time, in which you can give your time for volunteers, everything, and then you are. Your intention is for wakaf as well. So I'm not really sure about the banking is revealed from the sahih resources in terms of this one. Okay, that is my first comment actually. Thank you.
Thank you, Prof. Amin, for the question. May I invite Dr. Hasbullah comment?
Okay, Assalamualaikum warahmatullahi wabarakatuh. Okay, Alhamdulillah, a very interesting presentation. Okay, very good presentation actually. That we know that wakaf has a crucial function, okay, in Islam, and also to serve the ummah. And in terms of wakaf in Malaysia, still need to look forward lah, okay, to extend or to expand the concept of wakaf until we are really we will get a lot of benefit from wakaf, but need to what we call that collaborative contribution from all, okay, from especially from government, okay, from who are expert in that particular field. Maybe we can suggest to government in terms of medical in medicine, for instance, okay, what things that we can contribute, okay, in terms of wakaf. Okay, so this is actually very good idea, okay, as in presentation there is some idea, okay, to propose to set up or to establish the wakaf. Okay, like wakaf tunai as mentioned just now, wakaf time, and a lot of things lah. Okay, we can do that. I think for this we may go serious to think or to suggest to the government or to those who involved in wakaf, especially majlis agama Islam, who are the yang terlibat dengan as a pemegang amanah, trustee for the wakaf asset, for instance. So we need further discussion for that, inshallah. Okay, we will do better for the wakaf. Okay, in Malaysia we are very advanced in zakat. Okay, in zakat, but in wakaf still actually need more effort lah, to be in the best way as in Timur Tengah. Mereka itu agak advance in wakaf. Okay, jazakumullah khair.
See, I just comment a bit. I think for hospital practice and wakaf is still new, but the social worker, I think we are more familiar with the social welfare and social service when we need patients need any help, right? So for wakaf, I think we still not exposed to it, but usually wakaf is related to material. So in orthopedic, we ask patients to wakaf their external fixator. For example, in auto, wakaf Elizara frame or LRS frame. So that's what we do for the beginning. But I think the thing that we're liking is the management of the wakaf lah. Of course, people can donate something, but you need to maintain it and you need to document it so that it will be proper. So it's easy to wakaf your bicycle or something, right? But who want to manage to make sure that that thing is always in good condition and if we can replenish it when it's worn out. So I think management of wakaf also, I think is something we need to explore. I mean, we can learn from others also. Thank you.
Just echo to what Prof. Nazri mentioned just now. The problem is that is what we are already discussed in the hospital level. The problem with the wakaf, there is if everything go by wakaf, they're going to be burdened to the pemegang amanah, because we are the pemegang amanah. So you know, the ruling ataupun dia punya things that we have to do in terms of the wakaf, we need to maintain it until wherever, I mean until wherever time. So there is a problem because that's the reason kalau benda tu kecil-kecil apa semua macam wheelchair ke external fixator, it's better for them to donate it. It's still sedekah jariah, but the management part is going to be is much easier compared to we niat for zakah. That's the reason why in terms of managing the wakaf, we need is a proper documentation, and then we have to question back those who want to give wakaf, want to wakaf their things, everything. Make sure the niat is correct. Means that not only simply say that this is wakaf and then suddenly after 1 year the things is damaged, everything you cannot repair everything, then we become burden to the pemegang amanah to repair it whatsoever. So this is the things that we are actually dealing with. Then I'm sure there will be a lot more improvement. Then we have to form the task to involve to make sure that like macam Ustaz Abdullah beritahu tadi lah about wakaf tunai, wakaf times, everything yang kita buat need to be expand further in the condition of the definition, the scope of wakaf. Allahu alam.
Thank you very much to all the expert panels. Quite extensive discussion, inshallah. So I agree. So there will be, we need more discussions and research with regards to the benchmarking, the standard operation guideline for the managerial, for the administrative aspects, so that this will be more beneficial and inshallah sustainable over time. Thank you very much. I think
A very short comment.
yes,
Yeah,
Prof.
last moment.
Yeah,
Thank you very much. Bismillah. Alhamdulillah. Wassalatu wassalamu ala Rasulillah. I think the study of the waqf within medicine is very, very important because the topic is usually studied by the economist. Okay. So, but historically, this actually the waqf developed these two sectors, that is education and medicine. Hospitals are being established by waqf in Islamic history, and also schools. So these are the two sectors, sectors which being flourished by waqf. But as observed by the Dr. Prof. Aminuddin and Prof. Nazri and also Dr. Hasbullah, actually the idea of waqf is still in the very preliminary stage. And I hope that the researchers, especially the medical doctors and also educators, to propose or proposal project to study this historically, currently, and how it is being managed and where is the sectors to be benefited. The sectors which should be benefited, especially in the area of medicine. I think we have experience here as being presented by our doctors there, but still it is very preliminary one, not yet being developed. So there should be projects, there should be proposals to study comprehensively, not from economic perspective, but real application perspective, and maybe specifically in the medicine area. Okay, so that I believe will bring the issue more what you call comprehensively, and at the same time applicable to the thing, because we have a lot of people who are very rich. Only the government establishing the what you call hospitals and medical centers. But where is the private sector? Those who are rich people, they should establish these things. If you don't have enough, then you can establish, as Dr. Nazri gives the example, Prof. Nazri, you can donate something forever. Waqf means to be used forever until finished, exhausted. Okay, so you can actually do waqf to machine of anything or technology, whatever is it. So thank you very much.
Thank you very much, Prof. Ibrahim. It is a very good insight. Inshallah, we hope that we can see this thing going further, inshallah. Let's move on to the second group, which will be discussing on zakat. So I would like to invite the second group, Dr. Fatimah Nabila, Dr. Taran, Dr. Nizamuddin, and Dr. Farhan. Can you share your slide?
Right. Bismillahirrahmanirrahim. Alhamdulillah rabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajma'in. Can everyone hear my voice and see our slide?
Yes.
Okay, right. So our supervisor will be Dr. Baya and Dr. Ilya Ajmal. So our topic is about zakat, basically in medical practice. So a little bit of introduction regarding zakat. So basically, zakat is a means to purify, and also it's a fourth pillar in Islam. So basically, it's a paid on the surplus of wealth which is left over after the pass of the 1 year. So the aim of zakat is the spending of wealth for the sake of Allah to purify a man's love for material wealth, not merely a tax, but it's a form of worship. So affirmation of love to God and willingness to sacrifice. So the benefit of zakat can be divided into three based on the individual itself, the social, and also the economy. So based on the individual, religious obligation, willingness to sacrifice in the name of Allah, Socially, it's a sense of brotherhood, to helping others, and based on the economy, it's cotton help to the needy, enable them to be independent. It's as a social support. Okay, so and then based on our main topic is the usage of zakat regards to medical practice. Based on Surah At-Taubah ayat 60, there's 8 eligible people eligible for zakat. The first one is Al-Fuqara, the poor. Second one is Al-Masakin, the needy. Zakat administrator, which is the and also the fourth one is the Mu'alaf, our newly joined brothers and sisters. Those in bondage, debt-ridden, jihad fi sabilillah, and the last one is the wayfarer or the stranded traveler. So, based on Al-Kalim Al-Tayyib Fatwa Asy-Syariah taken from the Wilayah Persekutuan Dr. Zulkifli website, if he is unable to pay for the bills, then he is included under those who are recipient of zakat, which are needy and the poor, which is the number 1 and number 2 eligible people for zakat. So, based on zakat Selangor pages, so basically every Muslim has the right to receive zakat assistance, even though they are not poor. For example, in the case of medical debt, medical bills, and helping to further educations. So they are not included in the poor or the needy. So basically they are included in the name of asnaf fi sabilillah, asnaf gharimin, which is people in debt, or other appropriate asnaf. Okay, so based on hadith narrated by Abu Dawud, Ibn Majah, and Imam Ahmad, right upon this matter, Nabi Muhammad SAW says that zakat is not permitted for rich except for 5 groups, namely, the first one, the amil, the zakat administrator. Second, people who give zakat with their own wealth, the converts. People who fight in the way of Allah, jihad fi sabilillah, a person in debt, and the last one, a poor person who receives zakat from a rich person and then give it back to the rich person. So based on our jurists, Imam Shafi'i and Hanbali also stated that the agreement above allows this 5 wealthy group to receive zakat for the benefits. This is because they are not getting the zakat because they are due to poverty. It's because of they are basically to help to lighten their burden, to prevent them to becoming poor and destitute because of that. So basically, zakat is considered as debt-ridden and is also important for the poor and also the needy. So basically, in our medical practice, zakat is eligible for medical treatment, operational costs, and also medicine and implant equipment. So we move on to our first scenario. So basically, a patient will like to ask for help from a zakat assistant in order for the cost for his elective surgery. So he has a comorbid with hypertension and diabetes, and he has no stable job or monthly financial request. So how would you respond to his request? So basically, based on Lembaga Zakat Malaysia, so basically this patient is included in the 8 eligible people eligible for zakat, based on Surah At-Taubah ayat 60. So basically the distribution objective of zakat is included in the Lembaga Zakat Selangor, which is to reduce the poverty level. Even though the patient is not, can be the person is not poor, but he is needy and also he is in debt-ridden. So our approach will be, so the patient requires zakat for cost in elective surgery. It's a known case of comorbid and also no stable job. Did he fulfill the objective and also criteria for zakat application? Yes. Then the medical officer supposed to help in applying zakat due to the based on the approach. And then we have our second scenario, our last scenario. A patient would like to request for a zakat to help him with a cost in his cosmetic surgery. So how would you respond to the request? So basically, we need to differentiate between these two things: cosmetic surgery and plastic surgery. So basically, cosmetic surgery basically to enhance appearance, basically change something it's already normal and enhance it or to beautify it. Plastic surgery basically to repair defects or reconstruct a defect to become a normal function or appearance. Cosmetic surgery such as breast augmentation, facial rhinoplasty, for plastic surgery such as breast reconstruction in a patient post mastectomy in a breast CA, or in patient with a hand surgery or scar revision surgery. So basically, based on the Journal of British Islamic medical associations. So basically, Islam only permits the use of zakat to permit plastic surgery for the purpose of treating the disease or preserve a function of the body organs. So it's not permissible for cosmetic purposes such as to beautify or to improve one's appearance. So it only permissible to undergo cosmetic surgery when needed due to health issue or some type of deformity correction. And also based on the Islamic view, based on Sahih Bukhari, prophetic hadith says that God is beautiful and He likes beauty. Verse 4. And surely I will lead them astray, and surely I will send them desire. Surely I will also command them to cut the cattle's ear, and surely I will command them, and they will change Allah's creation. So basically, who choose Satan's patron instead of Allah is very like a loser, and his loss is manifest. So basically, someone who choose to change Allah's creations, alter something that already normal, is basically is dosa lah, is haram. So basically, the objective of Islamic law based on Al-Maqasid Asyariyah, we can conclude that there is a three objective: necessities, needed things, and also recommended. So basically, the necessities or al-daruriyah basically is essential for life, religion, and community. If hajiyat, which is the needed things, basically the things needed for the community and a person, but they can live without procuring them. And recommended is then needed by the society or the individuals, basically to make life more comfortable and more beautiful. All right. So basically, based on our second scenario, okay, is this patient eligible for zakat assistance for to help him in cosmetic surgery? So at first thing is we need to refer to respective team, which is referral to plastic and reconstructive surgery, and also the department or the specialist or the consultant will examine the patient and try to identify what is the indication for cosmetic surgery. Then if the cosmetic surgery is to beautify or to improve some things that already normal, then no, this is not eligible for zakat. But if it's indicated such as for plastic surgery, so for defects to repair the defect, or for reconstructive surgery, then it's yes, this patient is eligible for zakat appliances. Okay, with that, I thank you.
Thank you very much to Group 2. I would like to invite the expert panel to comment. Probably Dr. Prof. Ibrahim.
Yeah, the very interesting thing for me is the medicine doctor now giving fatwa also. Okay, of course, this is as far as in UIA, earlier our deputy director at that time, Siddiq Baba, he has very important statement. He said that as far as you are in UIA, then you should be ready for everything from Salatul Janaza up to whatever the people request, because when you go out, then the people trust in UIA, and then they invite you to be a leader in the religious matters in anything. So he suggesting that the person should be at least ready to be imam for the salah. And then he said that if salat asr and zuhur, just go front. But if salatul maghrib and isha, be careful, because you will read aloud and then the people know what you are saying. In all cases, we should be ready for that. And alhamdulillah, the presenters prove this. The fatwa they give here is based on the principles. So cosmetic issues, some of them alloyed according to Islam, and some of them disalloyed. So to support by waqf money should be the alloyed one. So this alloyed one is not there. But maybe the case could be critical. If somebody, what we call, make surgery, cosmetic surgery, but he is going to die. But he did something which is maybe not alloyed one to make beauty, for example, that's suddenly going to die because of this. So as a Muslim doctor, do you are able to support that kind of person to what we call rescue him, to pay from the zakat or from wakaf money to rescue such person or not? So these are the questions which arise, and we need to study and come up with fatwa, to come up with answer. Fatwa here is just the suitable answer to the situation according to the Islamic perspective. I yesterday giving some comments saying that as far as you giving answer to this kind of question, you should establish on principle or text or reference. And reference in the Islamic fatwa, you have Quran, you have Sunnah, you have Ijma, and also Ra'i or what we call as Ittihad. So many cases are Ittihad, more than it is from Quran and Sunnah, because we cannot find any text clearly indicating to the such cases. So I really encouraging these medical doctors to be involved in this kind of studies, and then develop knowledge and also experience. Thank you very much.
Thank you very much, Dr. Ibrahim. Any other comments from expert panels? Prof. Amin.
MashaAllah, it's a very good presentation. I think there is not much of comment, but I think Zaraf dia punya zakat actually is not that critical like wakaf just now. Zakat actually is we have a lot of like Dr. Abdullah beritahu tadi lah. We are quite advanced in zakat. Hospital, we are receiving duit zakat from the Baitul Mal as well. And then we have the things that the personal people that we give the zakat, which is we contribute to in the ihsan, tabung ihsan, together with the all other. This one is mainly for the patient, the needy patient. Then there will be a good channel in the hospital that they are by right, and they are not supposed to be anybody who are left without any payment or any need to settle the bill for the hospital, inshallah. Thank you.
Thank you very much, Prof. Aminuddin. To echo what Dr. Ibrahim said regarding inshallah, the group is presented very well. So that is, I think, the aim of some input medical practice, so that the graduating postgraduate students will be able to give input and when required, inshallah. So thank you very much, Group 2. I think let's move on to Group 3, which will discuss on doctor-patient relationship. So the group would be consist of Dr. Atira, Dr. Yim Pui Mun, Dr. Yuzaini, and Dr. Abdul Halim.
Okay, thank you very much. So good morning, everybody. Good morning to Prof. Aminuddin, Prof. Amin, Prof. Ibrahim, Prof. Nasri, Prof. Hasbullah, and also Ustaz Abdul Rahman, and to everyone present on the floor. Today, we are the first group to present about doctor-patient relationship and communication, and our supervisor will be Dr. Ilya. Okay, and then my colleagues who are involved will be Dr. Abdul Halim, Dr. Atira, myself, and Dr. Yuzaini. So without further ado, I shall start the presentation. So, hold on a second. Okay, so about the doctor-patient relationship, of course, we should treat the patient remembering our Hippocratic Oath. Okay, so generally there are a few steps in managing the patient. So first and foremost, we should respect the personal space, do not be provocative, establish verbal contact. And then also when we give information, we should be concise. We also should identify the wants and feelings of the patient, and also to listen closely whenever we talk to the patient. And also if let's say there are any disagreements, we should agree to disagree. And then we should, as professional, lay down the law and set the limits and offer choices and optimism to our patient, and to establish the trust. And also last but not least, debrief the patient and also the staff, so that all these so that we can establish a good rapport and also a trust between our patient and ourselves. Okay, so a little about the Islamic input on the medical communication. So in two papers, one which is an analysis and another one which is on a research. So it is found that Islam is a religion that encourages health. Islam is also have particular protocols and guidelines which we've already know, which is the Fiqh. Okay, and then also there are also identification that there are healing effects of the Quran when recitation of the Quran of the verse is done. Okay, so I shall go into the case scenario. The first one will be on a patient refusing blood transfusion, okay, because she is worried that there is a possibility of mixture of blood containing alcohol from other blood donors, possibly an alcohol drinker that she is not aware of. So how do we counsel on her misconception? So first and foremost, the concept of blood in Islam, blood is regarded as clean if it is still running in our body. But however, if it is outside our body, it is considered unclean and it's termed as najis. So aside from that, in terms of organ is actually a tool to support human life. So similarly, like in blood donation between a non-Muslim and a Muslim, there is actually no restriction because it's just a tool to support human life. And also Aqidah, which is the faith and belief of a person, is not determined by the organ or the blood itself. It's determined by the person from Allah. Okay, so aside from that, in transfusion, the sins and deed of the donor is not transfused to the patient, so it shouldn't we shouldn't stop the transfusion because of this. So we should reassure the patient and regarding the alcohol in the blood, because it will not affect us, and also the alcohol is metabolized. So in terms of the body is viewed as sacred. It is not from the essence of the pot or alcohol. However, it is from various kinds of nutrients from food or drinks. So it is decreed that the body of a non-Muslim, which includes his blood, is always to glorify and praise Allah and obey His command. So in terms of the procedure-wise, transfusion does not violate the body because it does not consist of cutting or tearing the body. In fact, it is just considering. It is just a simple puncture, okay, and it does not destroy the dignity and sanctity of a human body. Hence, blood transfusion is supposed to be not violatory. Okay, and in terms of Darurat and Maqasid Sharia, so in Darurat and Fiqh, there is a saying which is necessity makes prohibition lawful. So in order to save life, so hence blood transfusion is allowed even though blood is regarded as unclean. Furthermore, it is to save life, and Islam also viewed life as being sacred. So in terms of Maqasid Sharia also, we have to protect and also save a life, hence blood transfusion need to be done. So for the second case scenario, it is regarding a patient suddenly entering the room and angry scolding for a long waiting time. How do we settle the issue? So first and foremost, of course, as what we have mentioned just now, we should have a step-by-step approach to greet and also introduce yourself to the patient, confirm that it's a follow-up appointment for his illness, acknowledge the patient's disappointment with the delay in the waiting time, and allow patient to vent out the frustration. Aside from that, we should also explain the situation to the patient and hoping for their understanding. And last but not least, of course, we still have to proper examine and also assess the patient. And we should close the session by asking if the patient has any more inquiries or problem. Okay, so in terms of controlling anger in Islam, Quran in chapter 3, verse 134, it says that Allah loves those who do good, He also loves those who spend freely, whether in prosperity or in adversity, and those who restrain their anger and pardon men. Aside from that, Prophet Muhammad has also a few guides on anger management, which will be elaborated in the next picture. So, let's say if first and foremost, if we are angry, we should stay silent. Second of all, if we are in a standing position, we should sit down. Or if it still doesn't work, we should lay down. Aside from that, we should recite our prayers, okay, and then also say tawhid. Aside from that, since anger is viewed as fire demon, okay, we should put off the flames by taking an ablution, which is wudu, or take a shower. So that is regarding anger management in terms of Islam. Then next, the last but not least will be our last case scenario. A patient requests an antibiotic for his viral acute tonsillitis. You have informed the patient that it is not indicated. However, the patient still persists. How to resolve this issue? So first and foremost, we have to treat the patient as a human, and then also we have to acknowledge patient's expectation so that they will feel heard and also cared for. And then we should replace what they think with we should replace what they think they would get with other suggestions, which is more suited for the situation. So we should take our time to let the patient went, and also we should educate the patient about antibiotic stewardship. Okay. Aside from that, we should express our concern, and also when the patient is upset, we know that the patient is feeling unwell, and it might sometimes cause bad behavior. So we should try to remain calm and diffuse the anger and choose our words carefully whenever we are dealing with them. Okay, then aside from that, we should validate their symptoms and also provide symptomatic treatment recommendation, because even though it's just a viral infection, it doesn't mean that they aren't sick, and also it can be as painful as a bacterial infection. So we should be empathetic. Okay, so we should provide symptomatic treatment which will relieve them. So we should consider substitution and tell the patient that the patient might want something strong. However, there are other over-the-counter recommendations which might be prescribed so that to help. Okay, which is can be non-antibiotic prescription. And then last but not least, we should also respect our physician colleagues in the case where a patient is trying to say that the previous doctor always gave me an antibiotic whenever I feel this way and it always feels better. So we should take this opportunity again to educate the patient about the usual duration and also the cause of a viral illness, and then also tell the patient that maybe it's for a secondary bacterial infection. Okay, and then also usually it is for viral infection supposedly a symptomatic treatment, and also to educate once again about the antibiotic stewardship regarding antibiotic and resistance to antibiotic. And lastly, we should also tell the patient about guidelines like CDC, because usually they will respect scientific reputation of known organization. Yep. So that's all for the presentation. Are there any questions?
Thank you very much, Dr. Yi. Very concise and good presentation, inshallah. I would like to invite any comment, first comment from the expert panels, inshallah. We have Ustaz Abdul Rahman together with us. Abdul Rahman, here is Prof. Amin.
Maybe I start first. I think it's a good presentation. It's very concise, like you said just now. Thank you for highlighting a few things, which is I think is important now in the era of all the technology high. More people are talking to their phones rather than talking to the people. We are highlighting the most important part in terms of the relation between the doctor, patient, doctors, everybody, doctors and the family members. This is I think that I highlight in detail yesterday in my lecture, which is I think is important to emphasize, and not only to know it, but also to practice it. As a doctor, I think we have to be really humble in nature, rather than we feel that we are so great. You are cream of the cream whatsoever we thought we are, but actually we are supposed to be Khalifah as well as the slave, those people who are doing things according to the needs of Allah Subhanahu wa Taala. That is the nature, the passion that we have when we are treating the patient. Then this is not only in the hospital, but even in back home with our family also. We have to be humble, and then we have to be very informative, and then we have to be sincere and amanah as well. Okay, that is my comment. I think the presentation is quite good and highlight things that we need to do now. Okay, jazakallah.
Okay, thank you.
I think just to add, I think waiting time is, I think, a very important problem in any health clinic, because it's part of your quality service lah. You need to ensure that it's smooth. And then I think the other thing is it should be professional lah. I mean, you must be professional, like Kentucky Fried Chicken, very professional, right? They very quickly serve your food. So you need to actually try to improve your service so that patient is happy, so they don't get angry. I think prevention is the best treatment. Anyway, I think the other thing is waiting time is the opportunity for you to educate patient also, because they don't do anything, so they bring, maybe you can in your clinic you can teach them about antibiotic. You want to teach them by way of pamphlet or TV or something in your clinic, so that you don't have to explain to them, so that they have use that time wisely. So I think the other thing I want to promote is about, sometimes we have a survey, like what we are trying to do, like we want to have a ability prayer scale, for example, a survey to because in orthopedic, most patients have problem with their prayers. So by waiting for the doctors, then they can fill in the survey, the ability to pray, for example, and then you can have this information. Then by the time they see you, you have this data, so that maybe you can use it to improve your treatment on your patient also. Okay, thank you.
Thank you very much, Prof. Nazri. A good suggestion so that we approach the patient holistically instead of just the disease. Is there any other input from us? Yes, Prof. Ibrahim.
Yeah, yes, I think this topic is very sensitive in our time. Patient-doctor relationship is like any other relationship, and the people are different in their relationship in the daily life due to the nature of the person itself. Okay, some people are very friendly and very kindly from the very beginning, and the others are a little bit different, and so on. This nature will continue, but in the doctor-patient relationship, there is protocols, which is a medical protocols need to be followed. Yesterday, I think Prof. Wan mentioned one of the factors related to this, which is how the doctor need to create trust on the patient. And that will summarize everything, all the things which you try to follow come finally to the point of how you create the trust in your patient. One more thing which I have in mind for a long time is about the matter of payment made by the patient or by somebody, so that the doctor will carry on the duty. Especially if in the private clinic, for example, so somebody come to see the doctor, that he need to pay and so on. Of course, payment must be there, but this may also put the question of maybe self-interest here. If I am a medical doctor in a hospital, then I need maybe this person come and see me in private clinic. That will establish the point of self-interest also. So I was thinking that there should be deep research, at least from Islamic perspective, how we are able to address this matter today. Of course, free treatment is not possible, but also should be some kind of way to create the balance between the patient and doctor. There should not be the issue of payment, issue of making payment, because I'm just telling some of the students that the medical doctor is a malaika, do not care about the money, do not care about the nationality, ethnicity, religious matters. No, these are all behind. You deal with the patient as a human being. And the Prophet mentioned the hadith, or as the Quran itself. Quran said that if you rescue the life of one person, then you just like rescue all the humanity. So this is your slogan as a medical doctor. So I was thinking about this. I'm not sure, maybe I took long time, but these are the matters which is seemingly it is normal, but I also, because I'm talking outside of the medical area, I see abnormal. So maybe the medical doctors need to address this kind of the difficult topics. Thank you very much.
I want to add something, okay, regarding the case scenario one, in terms of blood donation, organ transplants, okay, that some, especially Muslim, they feel something, okay. Okay, so actually the Al-Quran has clearly mentioned about that. Okay, this is the conceptual, okay, knowledge on this thing. Okay, as mentioned in Surah Al-An'am, okay, verse 164. Wala taziru waziratun wizra ukhra. And no bearer of burden shall bear the burden of another. Okay, so this is very clear about that. Okay, so when donate organ or blood donation, okay, so this is not considered what happened previous, okay, but actually based on what we do in our life, okay, in our amal, okay, will be counted based on our amal, okay, not others. Okay, wallahu a'lam.
Thank you very much, Dr. Hasbullah. All right, let's continue with the next presentation. Thank you, Group 3. So we will continue with doctor-patient relationship with the second or the fourth group.
Thank you very much.
Thank you, Dr. Yi. So the next group would be Dr. Shukriya, Dr. Chong, Dr. Hesunatharan, and also Dr. Lee and Dr. Roland. Please continue.
Hello, good morning, everyone. Today, my group going to present about the doctor-patient relationship and communication. We have prepared a video for it, so I play the video, okay?
Assalamualaikum and good afternoon to all professors, doctors, and my fellow colleagues and friends. Our group topics is doctor-patient relationship and communication, and we are given two case scenarios regarding the doctor-patient relationship communication. These are our group members, and our supervisor is Dr. Salma Anim. From Islamic point of view, medical practice is considered as a sacred duty in Islam, and the physician is rewarded by God for their good work. Islamic scholars have agreed that the study and practice of medicine is an obligation that falls upon Muslims to have sufficient numbers of followers to practice, which is known as fardu kifayah. Building a fruitful doctor-patient relationship is a vital part of successful medical care. Doctor's manners. During history taking, the doctor must use this very opportunity to understand their patient as human being. This is also when patients begin to identify their doctor as a person and decide whether he is a caring and kind person or not. The physician is expected to be kind, humble, compassionate, honest, trustworthy, and respecting confidentiality. He must have the interests of the patient at their heart. He should avoid any wrongdoing, not abusing their status for monetary gain, and not misleading their patient. God does not love the liars and wrongdoers. As the Prophet said, those who have a perfect faith are those who have the best of character. Islam has enjoined three important points on which the doctor established a sound and healthy relationship with their patients. The first one is justice among his patients. The second one is ihsan. Ihsan means to be good, tolerant, sympathetic, forgiving, polite, cooperative, and so forth. As narrated by Al-Bukhari and Al-Muslim, ihsan is to worship God as you see him, and if you cannot see him, then indeed he sees you. The third one is good treatment of the patient relatives. This is also a part of ihsan. Al-Razi in his book Akhlaq al-Tabib, the physician duties to the patient, he says to treat the patient kindly, not to be rude or aggressive, but should be soft-spoken, compassionate, and behave modestly. The physician should inspire the patient, even those who have no hope for recovery, to treat the patient equally, regardless of their wealth or social status. The important aspect in doctor-patient relationship lies in several factors. The most important one is communication. Good communication leads to patient satisfaction and trust. When the patient trusts their doctors, this will increase their adherence to the treatment and the likelihood for the successful treatment is higher. The third one is the gender issue in the doctor-patient relationship, where in this case, if the patient is female and the doctor is male, there should be a presence of chaperone during the consultation and treatment. The fourth one is informed consent. This is a legal obligation for medical profession. Clear explanation of procedures, intended benefits, and possible potential risks and complications must be explained thoroughly to the patient. The fifth one is the role of family or companions in medical consultation if the patient brings their immediate family or relatives along. Sixth one is ethical issues in visual recording. Next is confidentiality. And last one is breaking bad news or disclosure. For the last one, the breaking bad news and disclosure is a nerve-wracking moment in doctor-patient relationship. If it done correctly, the patient will forever remembers the doctors, what the doctor did to them. And if it done very badly, patient and family will never forgive. Thus, this is very important. It is very important to have a good communication in between doctor and patient. Okay, this is our reference. So for our first case scenario, a 40-year-old man with left diabetic foot ulcer, Wagner 5, refused hospitalization and surgical intervention. How would you counsel him and convince him for the treatment? Now, we presented to you the videos for the case scenarios. Please enjoy.
Assalamualaikum. Waalaikumsalam. My name is Dr. Calvin. I'm the orthopedic doctor that is treating you. I would like to know if you have any idea what's going on with you, what we are going to do for you.
Yes, doctor. Previously, my doctor told my leg become very bad and they say I need surgery to cut off my leg. But I said I don't want. I'm very scared, doctor.
So what is your worry if your leg is being cut off? What are you afraid of?
Doctor, if my leg cut off, then I cannot walk. I will be handicapped.
Okay, so I'm going to tell you information about your medical condition and also what we're supposed to do for you. We'll also address your concerns and your expectations. Is that okay?
Okay, doctor. What do you want to tell me?
So, Hesudaran, what you're suffering from is actually extensive gangrene of your right foot. What has to be done for you is actually below knee amputation. The reason we want to do this is because if you have a dead part of your body and you keep it, first of all, there'll be localized infection. Alright, if you keep it long enough, this infection will attack your bloodstream and it will be life-threatening for you. Also, to answer your question regarding whether you can walk or not after this, with the advent of prosthesis, you'll be able to walk after this. Maybe you cannot walk like how you used to walk before this, but you can still carry out your activities of daily living. That's fine.
Oh, doctor, you mean after amputation, I still can walk? That's a very good news, doctor. I think I would want to agree for the surgery. I don't want this. My foot wound become worse and threaten my life.
Okay, Hesudaran, I'm glad that you actually understand your condition and also what we're going to do for you. Since you agree, do you need some time to discuss with your family members or anyone? Or we can arrange an admission for you and proceed with the operation at the nearest available OT.
I think okay, doctor. I would like to do the surgery as soon as possible so that I can save my life. Thank you, doctor.
Good morning everyone, I am Roland and the second scenario will be a 70-year-old woman dissatisfied with your surgical intervention of a left distal radius fracture. You have managed her fracture previously with open reduction and internal fixation but currently complicated with malunion. How will you respond and explain to her? So, before proceed to answering the question, I would like to mention regarding the SPICE protocol, which is the most widely recommended approach to deliver bad news to patients. Here are the key components. S for setting, P for perception, I for invitation, K for knowledge, E for emotion, empathy, and S for strategy and summary. So the first component will be setting up. So we need to arrange the place that can provide privacy to patient. For instance, in clinic room without other patient in the same room. And greeting to patient and introduce ourselves to start building rapport with patient. Maintain a good eye contact, arrange the seat that next to the table and same level with patient and ask patient wish to have anyone else in the same room prior we proceed with the explanation of their current situation. The second component, perception. We need to identify how the patient perceives with her condition now. What was their expectation prior to operation? Is her daily activity get affected post-operation? Is the pain tolerable and didn't require the frequent analgesic to counter the pain? So the third component will be invitation. We need to ask the patient and their family if they want to know regarding the bad news. So for instance, in the first scenario, the bad news will probably be the suggestion for the surgical intervention in view of their infected wound condition. And for the second patient, which will be the malunited fracture post-operation. If they do not wish to know, we need to respect their wish. The next component will be knowledge. We need to explain to patient clearly with their current condition. For instance, the first scenario, we need to explain to patient regarding their infected DFU, diabetic foot ulcer, for which requires surgical intervention and hospitalization. And for the second patient will be the mild united fracture post-operation, and we need to show the patient the latest X-ray available. So for instance, in the first scenario, we show the patient with the X-ray and possibly the presence of the gas shadow, and second patient will be the mild united fracture. We need to explain to patient in simple and easy way to patient instead of using medical terms. And we also need to check the patient understanding regarding the condition and get the information from the patient whether any severe or difficulty in their daily activities. The next component will be emotion empathy. We need to acknowledge the emotion and the concern from the patient regarding their situation, showing our empathy to their situation currently, and give the patient encouragement and some optimistic views regarding their condition. So the last component will be strategy. So we need to offer patient for strategy to reduce the complication of their current condition. So for instance, in the first patient, we can offer the wound debridement for the infected diabetic foot ulcer condition, and for the second patient, we might counsel them for the referral to the physiotherapist or occupational therapist to regain the most function of their upper limb. And we also need to encourage their family to give more support to patient. Inform to patient that their condition will be followed up closely, and lastly, confirm with the patient whether any other concern or question that they wanted to raise. So in conclusion, the SPICE protocol will be a most recommended approach and effective way for us to communicate with patients, especially when we wanted to inform them some bad news. And next, our group will be proceed with video clip presentation regarding the scenario that given to us. Thank you.
Assalamualaikum, Makcik. How are you?
Waalaikumsalam, doctor. My left hand. Operation 6 months already. Now this one can move like that. This one can move so good. Help! Help! I'm not happy.
Oh, Makcik, I'm sorry to hear that. May I know if you are still working, and if you're at home, what are the things that you do that is actually bothering you? What do you find difficult to do at home?
Doctor, listen to me. My left hand, when I carry heavy things, is not strong. Cannot breathe well. When I cook, this hand also very difficult to move. Very difficult, doctor.
Oh, Makcik, I understand. From your notes, actually, I read that your right hand dominant, right? Means your right hand is a stronger one. So I hope that doesn't affect your activities too much. But anyway, I would like to explain to you what's going on and why you're actually experiencing this. From your x-ray today that we took for you, found out that your radius fracture that we fixed for you, it's united, but it's not at the position that is satisfactory. It is slightly bent. It has united like this with the plate there.
Doctor, why? Why this happened?
Oh, Makcik, I'm so sorry to hear that. Do you need some time? Do you need some tissue paper? Are you alright? Makcik, let me explain to you. I'm sorry, actually, this complication has happened to you. But I think Makcik would have known that before the operation, we would have counseled you that this is one of the possible complications from this operation. And now, since it has happened, I will tell you why. It's because initially, when you had the injury, your fracture is very bad. It's very comminuted. We call it a lot of pieces, a lot of serpihan. The operation was complicated and it took quite some time as well. If it's a bad injury like this, the risk of getting this bone uniting in a different manner is higher.
Okay, doctor. Remember, doctor, last time told me before surgery got this complication. But I'm very worried. Will it worsen or not?
Okay, Makcik. From the x-ray, like I explained earlier, the angulation is actually quite minimal. This minimal angulation is why you're experiencing difficulty in doing when you are carrying all these heavy objects and all that. First of all, this thing will not worsen because it's already united. Secondly, the things that you find difficult, we'll refer you to physiotherapy, and it might give you a bit of improved function when you do all these activities. The good thing is, most of the daily activities that you do, for example, when you wear your clothes, carry light items, this won't be an issue for you. Do you understand, Makcik?
Doctor, thankfully you said it will not worsen. I'm very happy. Now I have some hope. Thank you, doctor. Thank you for your explanation.
Okay, Makcik, actually I'm glad that you understood and then we tackle all your worries. So in that case, I'll refer you to physiotherapy. We'll see you back in 6 weeks time to see your progress after physiotherapy. Hopefully there will be some improvement. Alright, thank you. Good morning, Sutaran. How are you? Let's take a look at your leg, huh? Doctor, you cut my wrong leg.
Doctor, don't faint first. My machi want to see you.
Doctor, what's going on?
Yeah, machi.
MashaAllah. What an interesting, very interesting, subhanAllah. Can we have, thank you to the group presentation. Well, can we have some expert panel to comment? And anyone?
Okay, I will start first.
Okay, yes, Prof. Amin.
Okay, I think it's I'm sure that everybody enjoy the scene, the scene, and then the acting of the participant. I think it's very good. Your message actually is reach us. I feel like if everybody have that kind of when you talk to the patient like the doctors talking just now, I think it's going to be good. Commonly, when we have a consultation with the doctors, everything, we don't have that convincing apparatus. One. Second is we don't have a conclusion. We let the patient or the relative jungle with a lot of questions without actually conclude, give the counsel back whatever we have discussed with the patient as a conclusion. That is things which is I think is not commonly is a practice among the doctors. Okay. Other than that, I think that is well done, and then well said in terms of this one. The only thing I just want to emphasize to everybody, especially the participants and then all the doctors, consultants, the skills for the breaking the news, the skill for the and preparing for the anger crisis, because they can come very sudden. And then you have to respond in the calm manners, proper ways, and not to worsen the condition. And then another thing is a skill for handling end of life care. This is not common in our design. Most of the time we are expecting the ustaz, somebody has come to help us in this one. Even the doctors have also need to prime the relatives, everything in terms of end of life care, which is I think is important. And then handling the family conference is another thing that we have. We need to get a good counseling skill as well as a helping attitude when is dealing with the patient. I think that is the thing that I want to add in terms of this presentation. Thank you very much. Assalamualaikum.
Thank you very much, Prof. Amin. Again, thank you to the Prof. Nazri. Yes.
I think you need patient needs some time to make decision. Like you want to buy your shoes also, you look for a few shoes, right, to decide which one. So I think patient also need some time to consider their options. And then of course they need to have some inform. Inform means they have knowledge about it. And I think the other thing, you always open your hospital door to they can come anytime they want if they have. So don't let them discharge and then they say they don't want to come, takut malu lah, takut ni lah. So always make sure that tell them we are always open to you if you have any problems, and you can always come and you can always ask me any question if you want to ask it out. So I think that's important because that's very important decision in their life. It's like you want to choose university also, you take some time, right, to choose which one. So similar to patients, so they have a lot of things to consider. So give them a bit more time to decide.
Thank you very much, Prof. Nazri. Yes, to extend invite them to ask questions. They will be very thankful for that, inshallah. So thank you again for Group 4 for the interesting presentation. We shall take
just a bit more.
Yes.
And I mentioned about I'm very interested in the concept of justice has been presented just now. Okay, that in Islam put the standard. Okay, where Islam has traditional KPI lah. Okay, So there are 3 KPI in Islam. Okay, first is zulmun, injustice. This is fail. Okay, and standard is adil, justice, and the goal, the highest level is ihsan. Okay, so Islam put we have to achieve the highest level, ihsan. Okay, and at the same time, Islam put the standard. Okay, justice. Okay, justice in dealing with passion, as mentioned just now. Okay, so we try to do the best. Okay, towards perfection, towards ihsan. That's why, okay, doctor, in treating patient, okay, put the best thing, and inshallah, okay, everything will be okay, and okay, will be better, inshallah. Okay, wallah.
Thank you very much, Dr. Asbullah. It's a good addition to this. We shall take a 5-minute break before we resume the group presentation after this, inshallah. So, right, I'll see you in 5 minutes, inshallah.
صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه.
Okay, welcome back everyone. I hope everyone is now settled back to your seats. So inshallah, we have listened to 4 group presentations. We have 8 more to go. We will inshallah to make sure that the event running smoothly, we will try to limit to 2 expert panels to comment. I think very useful discussions are going on, but to help to make sure that we finish on time and be able to cover all topics, we shall proceed with that, inshallah. So all right, so now let us move to the 5th presentation by the 5th group. I'll invite Dr. Izian, Dr. Shafiq, Dr. Anis, Dr. Tong, and Dr. Faris on communication.
Assalamualaikum warahmatullahi ta'ala wabarakatuh. Can you see my slide and hear me clearly? Hello?
Yes, Dr. Faris, we can hear and see your presentation.
Okay, so Alhamdulillah Rabbil Alamin, wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. Thank you for the introduction to the moderator in charge of today's session, Dr. Faruza. First of all, I would like to say my gratitude towards the chairperson of the committee for the program, Dr. Shaiful, and to welcome our dear expert panels for giving us their input. So my name is Faris. I will be presenting my colleagues, my dear colleagues, for the topics given to us regarding communication. And to be more specifically, it's towards the healthcare workers. So together with me is Muhammad Shafiq from Surgical Department, Dr. Tong Soo Kian from the ONG, Anif Akila from Family Medicine, and Nurul Izian from the Anesthesia Department. So for outline of today's topic, I will be discussing more on definition of communication, the types of communication, who is our role model for the communication, and go on with the case scenario. So as an introduction, as we know, communication is a part of, essential part of our primary skill of life. Example of other primary skill of life is decision making or creative or critical thinking. So communication is a process. It's not an end result. So it's a process where you convey information through the exchange of thought, ideas, messages, or data. So from ancient time, we used to do all talks. Then as we progress, as we revolutionize, we are able to give out a medium to convey this communication, newspaper, internet services, and now we are doing Zoom. It's a part of communication. So Allah Subhanahu wa Ta'ala create man with a basic function to communicate. This is as be given in Al-Quran, chapter number 55, verse number 4, Al-Lamahul Bayan, and they taught them speech. So for my presentation, if other slides you don't remember, at least you remember this part only, effective way of communication. So in Sunnah, there are few things that if you do, you will get pahala. So keeping a smiling face, for example, where you wish peace by saying salam, as mentioned by Prof. Nazri yesterday, with wish peace to the other counterpart, it's like a dua to them. And we shake hands with them to gain this closeness. Then the way you balance your voice and tone, very important, because some colleague, they interpret different way if you give a different voice tone, for example. Then of course, asking about family members, avoid using your tongue for ill purposes. For example, talking vulgar words. Use a simple and precise word and try to avoid useless arguments. And if you start your conversation in a good way, try to finish it in a good way also. So as you know, for any thing that we do, we have to have a source. So to have a role model for communication to be effective, our role model is our own Prophet Nabi Muhammad, peace be upon him. So there was a book written by Michael H.R. in 1978, which he wrote about the 100 most influential people in history. And guess what? The number one is our Prophet Nabi Muhammad sallallahu alaihi wasallam. So the life of Prophet, peace be upon him, is full of examples, and as a role model for us as a Muslim and other individual as well. So from young, he has been nurtured, educated, protected by Allah Azza wa Jalla. So it's not surprised that the conduct and the manner of Prophet can be a guide and excellent example for us to continue to be a role model for humankind as eternity. So in the light of Islam of concept, Allah himself is a communicator and convey message to his through the Quran and through his messenger, which is our Prophet. So Nabi Muhammad sallallahu alaihi wasallam communicates with different group of people in order to preach Islam. It can be in many ways, and the way he do it charm everyone. Very pleasant behavior and outstanding personality. So despite all of this propaganda by his enemy last time, so still when people saw a prophet, they are convinced with his speech and the way he's presented himself, very mannerable and very ethic. So some even just listen by his Quran recitation, made them embrace Islam. So there was a book published by Muhammad Abdul Rahman Sadiqi 2015, described regarding communication style by our Prophet. So as you can see as an example, so Prophet always tell the truth. They never told a lie. So this can also be used together with our colleagues and also together with our patients. Never use vulgar words. So when someone giving a speech, never interrupt unless necessary, and forgive others, talk less and very wisely, and try to communicate with confidence. So brief definition of communication is a two-way process. It's not one way. It's not only you or it's not only him. So it requires a clear understanding of message from both the sender and the receiver, so that what you want to say is the meaning is intact. So it involves the way you talk, the way you write, for example, behavior and body movement. So all of these are based on, so from Islamic perspective, is based on Al-Quran and Hadith. So Islam has established a guideline, a principle for us to communicate interpersonally through greetings, giving a soft talk, using good words, speaking the truth and keeping promise. So types of communication can be verbal, can be non-verbal. Okay, so the non-verbal, for example, using Al-Quran, newspaper, signboard, book, and also a body language. Okay, so in order to achieve effective communication, you have to have trustworthiness. This was mentioned by Prof. Dr. Azman yesterday, where we have to develop a trust. So it's not only trust to the patient, it's trust between our colleagues, our inter-department relationship. And of course, we have to have active listening. Don't be judgmental, and you should have a value difference. So if you have a different argument, you don't talk back. Appreciate it. So no assumption and be authentic. So why is communication still important in our career? So it is important both in life and also in work. So you can learn new knowledge, new skills. So you can express your feeling and emotion more, build a good relationship between each other so that we can share experience and connect to each other. Because at the end of the day, our aim is for the sake of our patients' benefits. So communication will help us completed this work diligently, and this will increase productivity. So I move on to our case scenario. So the case is you realize that sometimes it's difficult to refer a case, especially from district hospital to a tertiary center, or even from one department to another. Some doctors might feel that they are more superior and they are looking down to other departments, and argument will always occur. So how can we improve this referral culture? So that we can be more harmonious and without any miscommunication. So the first step is to communicate in a structural manner. So one of the most important factors in determining our outcome of patient is communication between clinicians. So you have to have a good tool of effective communication. So we have identified ISBA. So I stands for identity. So when you present something to your colleague, make sure you present yourself first so that he and she know who you are talking to. So your name, position, and also the patient details that you want to present. So the situation summary of the situation and the background, is it for animation diagnosis or is it for other treatment and summary? And then assessment for good assessment to give to your colleague so that he know what he need to be done. And also the request, state what you want and what is your management advice. Okay, so the second part is in order to communicate effectively between each other, you have to have a positive attitude. So the way you speak, words you use, tone is all need to be good. Don't use a vulgar words. This is mentioned in Surah An-Nisa, verse number 148. Because Allah doesn't like public mention of evil and except by one who has been wrong, and ever is Allah His hearing and knowing. And use a nice word. If you like people to say nice word to you, you should say nice word to them also. So in Surah Al-Azab, verse number 70, or you have believed, fear Allah and speak words of appropriate justice. And there's a term called kaulan layina, means speak softly. So when you speak to others, you speak in a very good word. Don't use a pleasant tone, use soft words. Use soft words. So not only words can help, the way you project your body language. So this will make communication more comfortable and effective. For example, by showing a smiling face. So as we know, Prophet Muhammad SAW always expressed a cheerful facial expression, and when passing by other people, except for someone who do a wrongdoing. And also it was mentioned in hadith by Abdullah bin Harith, I never came across a person who smiled as much as Prophet Muhammad SAW. So the third thing to do is to instill a teamwork and cooperation. So as I mentioned earlier, our aim is always the best care of our patient. So we have to cooperate with, as I mentioned in Surah Al-Ibaadah, verse number 2, cooperate with one another in goodness and righteous. Don't cooperate in sin and transgression. So we do because of, for the patient's sake. And then ensure a mutual respect and honor between each other. This is mentioned in just now by Dr. Arif. Professionalism, one of the 2E, 2C, communication, professionalism. You are respecting your colleagues, not only to your patient, to your colleague also. And be courtesy, be polite, and be kind. And the way you to communicate effective is to be right on target. Use effective words, so that is easy to understand. And in order for communication to be right on target, your style of speech need to be in the same level or adjusted to the one you are communicating. So use a proper language. And of course, all knowledge is from God. So
Faris, please get ready to conclude.
okay. So receiving referral, basically sharing your knowledge and expertise. So be an active listener. For example, understanding the limitation in klinik kesihatan. So don't scold them. You help them. So the reason they are referring to you because you are expertise in that. They need your help. So be humble and be grateful. So in conclusion, have a mutual respect, be professionalism, and do a positive attitude toward your colleagues. Lead a better out because we want a better outcome for our patient. So the most important thing is to stay humble. The more you know, the more humble you should be, and try to avoid useless argument. Okay, thank you. This is my reference.
Thank you very much, Dr. Faris. Regarding communication, who else is a better role model for us than Prophet Muhammad Sallallahu Alaihi Wasallam? I would like to invite our experts to comment on the presentation, on the discussion.
Maybe I just give some.
Yes, perfect.
Topic is very interesting because communication is usually or classically being a topic of media, you know. So the other areas is not so much addressed about this topic. I think the presenters well done, and they collected a lot of data, and I believe also that huge data make them a little bit what you call, they put it the data in the way which is maybe combining between the or mixing between the public or communication general or specifically into the medical area. So if we just restricted the topic into the medical area, then the main question which should arise is how the medical person, or let us say doctor, can communicate. Of course, communication here may be for the doctor, I mean 3 parties mainly there, or 4 parties. Number 1, with the patient. Number 2, with his colleague or her colleagues. Number 3 is public general. Okay. So if we need to get the effective communication, of course, today, alhamdulillah, technology brings us a lot of ways to communicate, you know. So this will make easy our job. But the main question which arises is the message or the content which we communicate, we share. Okay. So this for the medical doctor, I believe the content or the what he or she sharing is always positive, not like media which is bringing false information to us. Okay. So if you focus on that context, I was thinking that actually there today we cannot see real message of the doctors in our mass media, for example. Okay. Even social media, we cannot see the voice of the doctors. Why not doctors tell us practically there is communication with a doctor? Maybe that is a message in TV, for example. TV Hijra give one session for the communication with a doctor. So give us advice, give us any message which the doctor give a specific time. So we cannot find this. Therefore, what I was thinking actually is the presenters, well done, but they also mix it with public communication, not focusing so much on the what you call medicine area. And also they bring a lot of data from the Islamic, and they put it here and there. So it is not so much clear for us. Of course, they use that is good. I consider this presentation is huge data which need to be studied, re-studied again and developed. Okay, and why? Because the data they collect is very useful and very good. So we thank them for this effort, and maybe they re-check again to put in more focus on the medical field and how the medical doctor could communicate and what kind of message he or she shares. Thank you very much.
Thank you, Dr. Ibrahim. I think because we can add in our future discussion, inshallah, regarding public communication with regards to medical. And is there one more? Probably Nazri, Prof. Nazri, if you want to add with regards to the discussion on doctor-doctor communications, referral, especially in to between doctors. Prof. Nazri.
Okay. Yeah, I think the best thing is you should go to district first before you join the hospital. Otherwise, you don't realize what are your limitation in the district, right? The second thing, of course, you don't ask them to do flap or ask them to do colostomy. I think ask them for expert opinion so that they don't feel like they are like your orang gaji suruh buat something. And so I think that is few things that you can advise you. Thank you.
Thank you, Prof. Nazri. It's all about communication skill, inshallah. Thank you to Group 5. We shall proceed to Group 6, which will be discussing on informing results and breaking bad news. I'll invite Dr. Un, Dr. Muhammad Mutaki, Dr. Muhammad Nazrul Mubin, and Dr. Kavi Varma.
Assalamualaikum everyone. Can you see my slides?
Yes.
Okay, right. So Assalamualaikum and a very good morning to the honorable speakers, moderators and fellow participants. My name is Muhammad Nazrul Mubin, together with Dr. Unzi Singh, Dr. Muhammad Mutaki and Dr. Kabiba Maharaj, and our supervisor is Dr. Taufiq. So today our group will be presenting about the theme of informing results. Okay. So the first question that is, list down your best steps and tips to inform results to patient effectively. So the most important thing is to communicate effectively is that you remain open and maintain a sense of respect for your patient. So in this case, we can apply the respect model. So respect model is whereby R is for rapport, where you establish rapport, connect on the social level, pay attention to patient's concern. E is for empathy, where we verbally acknowledge and legitimize patient's feelings. S is support, reassure the patient you are and will be available to help. P is partnership, stress that you are working together to address health problems. E is explanations, where you use verbal clarification techniques. Check often for understanding. C is cultural competence, where you respect the patient's cultural beliefs. And lastly is T, trust. Consciously work to establish trust and show respect and treat each patient with compassion and without judgment. Okay, so for our scenario number 1 is that a HPE result of a bone biopsy of a 40-year-old man is noted to be a left femur osteosarcoma. How would you counsel the patient about his results? So basically, this scenario is talking about how to break bad news. Okay, so bad news is defined as any piece of information that could potentially lead to negative alteration in the patient's expectations, beliefs, emotion, or attitudes. For example, when we are informing the patient of a life-threatening disease such as cancer. So breaking bad news is a skill that we need to have as a doctor. Okay, so there is a gap between the patient's expectation and the reality of patient's medical condition. So our job is to close that gap. Okay, so Muslims believe that a person facing unpleasant incidents is being watched by God and that they can use this opportunity for their transcendence and growth. Therefore, it is necessary for healthcare providers to take this into account and when delivering bad news to Muslims. So we can deliver bad news according to the SPICE protocol. Okay, so SPICE protocol have 6 aspects, which is the first one is S, which is setting, where we can arrange for some privacy in a quiet or private location. We involve significant others to be present, but with the patient's consent. Okay, we can ensure both patient and doctor are sitting down. We make connection and establish rapport with the patient, and we manage time constraints and interruptions. For example, by switching off our phone, so make sure there are no disturbances when we are talking to the patient. P is perception of condition and seriousness, whereby we determine what the patient knows about the medical condition or what they suspect. Okay, we listen to the patient's level of comprehension, and then we look for knowledge and emotional information while the patient is responding. Okay, we accept denial but do not confront at this stage. So, for example, what we can ask is that, tell me what you understand about your illness. I is for invitation from patient to give information, whereby we ask patient if they know the details of the medical condition or treatment. We accept the patient's right not to know, and we offer to answer questions later if they want. For example, we can ask, would it be okay for me to discuss the result with you now? Okay. K is knowledge, giving medical facts. So we use language which is intelligible to the patient. Do not use too many scientific words. We consider educational level, social cultural background, current emotional state. We give information in small chunks and check for understanding at each step. So we respond to the patient's question as they occur. And if possible, we give any positive aspects first. For example, we say that the cancer has not yet spread to lymph nodes, or whether that it is highly responsive to therapy, whether the treatment is available locally, and etc. And the most important aspect in SPIKES protocol is E, which is emotions and empathy. So in this aspect, we prepare to give an empathetic response. Okay, we identify emotion expressed by the patient, such as sadness, silence, shock, and then we identify the cause or source of emotion, and then we give the patient time to express his or feelings, then respond in a way that demonstrates empathy. Okay, do not give any false hopes or prognosis, and most importantly is we allow patient to grieve. Okay, so basically grief is a distressing condition. Okay, humans tend to remember God the most during distressing situations. Grieving process has been postulated to have led to growth experience in some individuals. Spiritual reflection during grief may bring one to the remembrance of Allah Subhanahu wa Ta'ala. So many examples from Quran and Hadith that give nasihat about hardships. For example, in Surah Al-Inshirah ayat 5 to 6, فَإِنَّمَا الْعُسْرِ يُسْرًا إِنَّمَا الْعُسْرِ يُسْرًا. For indeed, with hardship will be ease. Indeed, with hardship will be ease. Okay, so spiritual growth makes one understand that triumph is joined with endurance, relief with distress, and ease with hardship. Another example is from Surah Al-Baqarah, ayah 216. But perhaps you hate a thing and it is good for you, and perhaps you love a thing and it is bad for you, and Allah knows while you know not. Okay, this is a concept of Rada with Qada and Qadar. Whatever happened was decreed by Allah, and nothing you or someone else did or did not could have changed it. Okay, and another hadith from Sahih Muslim, Suhaib reported that Allah's Messenger, peace be upon him, strange are always of a believer, for there is good in every affair of his, and this is not the case with anyone else except in the case of a believer. For if he has an occasion to feel delight, he thanks God. Thus there is good for him in it. And if he gets into trouble and shows resignation and endures it patiently, there is good for him in it. Okay, so basically it is talking about gratitude. So gratitude is also an attitude during adversity. Although difficult to see, there are always blessings that accompany a difficult time. And last aspect of the SPIKES protocol is strategy and summary, where once emotions are all stable and patient is ready to move on, ask if they are ready to discuss next steps of treatment plan. Give clear options on treatment plan and choices. We encourage patients to participate in this decision making, and after that we summarize the main points and then set up a follow-up. Okay, so for scenario number 2, a 60-year-old man recently diagnosed with stage 3 osteosarcoma. The patient's daughter come to you asking you personally about the exact diagnosis of her father without the father's knowledge regarding his daughter's visit. Will you explain to the daughter about his father's disease, and how would you respond? So basically scenario number 2 is talking about confidentiality. So a stage 3 osteosarcoma is not a medical emergency, but it could cost the patient's life. In the meantime, the patient is sound and pose no threat to his or others' life. It is therefore prohibited to reveal the patient's disease to his daughter. Okay, getting the patient's consent first would be the best option before revealing his disease and condition to the doctor. And by this, we are not overstepping or neglecting any loss of confidentiality. So in the Malaysian MMC confidentiality guidelines, which they talk about sharing information with patient's spouse, partners, carers, relatives, or friends, they talk about that the practitioner shall establish with the patient what information they want to share with, to who with, and in what circumstance. Okay, this will be particularly important if the patient has fluctuating or diminished capacity, or is likely to lose capacity even temporarily. So early discussion of this nature can help to avoid disclosures that patient would object to, so that they can also help to avoid misunderstanding with or causing offense to anyone the patient would want information to be shared with. Okay, so in Islam, confidentiality is defined as not disclosing a secret. Okay, it is an important concept and it is a highly emphasized obligation. So no one is allowed to invade someone's privacy in Islam, and no one should disclose one's secret to third party without his consent. Okay, so confidentiality is about respecting others' privacy. Okay, so there are a few Quran verses that talk about the confidentiality in Surah number 17, ayat 34, and fulfill every covenant. Verily, the covenant will be questioned about. Surah number 4, ayat 58. Verily, Allah commands that you should render back the trust, amanah, to those to whom they are due. And from Surah number 8, ayat 27. O you who believe, do not betray the trust of Allah and the Messenger, and do not betray your mutual trust while you know. Okay, so basically the verses implies prohibition to disclose people's defects or amanah that has been given to us. But in some cases, it is acceptable if one discloses someone else's secret. For example, in the process of an investigation, when someone's life or well-being is in danger or for the sake of community health and safety, one is allowed to disclose a secret. Okay, it is important to disclose a secret to the right person, which according to the Holy Quran from Surah Al-Imran, ayat 118, O believers, do not associate closely with others who would not miss a chance to harm you. Their only desire is to see you suffer. The prejudice has become evident from what they say, and what their hearts hide is far worse. We have made our revelations clear to you, if only you understood. So as a conclusion, confidentiality is a secret of the patient, and physician is ethically obligated to maintain it. Failure to such is considered as a betrayal of the right to autonomy and privacy of the patient. Also, it can result in mistrust and lack of effective communication and intimacy between patients and their doctors. Okay, that's all from us. Thank you.
Thank you very much. I would like to invite our expert panel to comment, to give their comments. Maybe we can start with Prof. Aminuddin.
Assalamualaikum. I think there is well said regarding the confidentiality, which is this is a part of the things that why we are in organization, the institution, medical institution, we are really emphasized on this confidentiality, the integrity, and then in the Islam concept of amanah, physician. Whenever we are dealing with patient, after all, what we need actually is in terms of getting trust, this trust with the patient, so that the patient will be confident getting the treatment with the doctor. This is the principle that all the doctors should have. I think other part actually is another thing that maybe we need to emphasize is for the physician to be well versed with the ethics as well as the medical negligence part, because this is interrelated. And then when we make the survey in terms for the doctors, the junior doctors, consultants, and specialists regarding the medical act, actually is they have a lot of misconception of the medical act, which is they are supposed to be protecting the patient, not protecting the doctor. So this is the things that need to stumble up, maybe need to improve in terms of our knowledge, especially in the medical fraternity, our graduates, undergrad, postgrad, regarding the in terms of medical negligence and all. Thank you very much. Assalamualaikum.
Thank you very much, Prof. Amin. Maybe Dr. Hasbullah has something to add.
I think what has been mentioned by Dr. Amin is enough. Okay.
Thank you very much, Dr. Hasbullah. Thank you to the presenting group. Now let's continue with the next group, which also will be discussing on informing result and breaking bad news. I would like to invite Dr. Fikri, Dr. Khairi Akil, Dr. Shafiq, Dr. Muhammad Ikhwan, and Dr. Muhyiddin Arifin.
Assalamualaikum and a very good afternoon to everyone. Can everyone hear me?
Yes.
Can everyone see my slide?
Yes.
Okay. Assalamualaikum and a very good morning to everyone. I will be presenting on behalf of my group, consisting of me, myself, Muhammad Shafiq, Dr. Khairi Akil, and Dr. Muhammad Fikri from Department of Internal Medicine, Dr. Muhammad Ikhwan, Dr. Muhyiddin Arifin from Department of Surgery. Our supervisor is Assistant Prof. Dr. Iman.
Khairi, can you please put your presentation on presentation mode? Kat bawah sekali. Slideshow.
I'm using my friend's laptop.
Oh, okay. Bawah sekali. Boleh ke?
Okay.
Right.
Okay. So hopefully the slide is clear now. We are given topic similar topic like the previous groups, which is informing result. Please list down your best steps and tips to inform results to the patient effectively. And also breaking bad news. Please comment and answer based on the case scenario. The first scenario is a HPE result of liver biopsy of a 40-year-old woman noted to have fibrolamellar carcinoma. How would you counsel the patient about his condition? And somehow the second question and scenario is similar like previous group. Only different is the diagnosis, which is the stage 3 lung carcinoma. And the doctors also want to know about the diagnosis of her father without the father's knowledge regarding his daughter visit. How would we respond to that? My presentation would be almost 80% to 90% similar to the previous group. Never mind, but I try to answer this scenario as I can. So the breaking bad news, somehow there is nothing that travels faster than the speed of light, with the possible exception of a bad news, which obeys its own special laws. The quotation by Douglas Adams. So first, I would like to start my presentation with some definition. What is a bad news? It is any information which can adversely and seriously affect an individual's view of his or her future. By Bachman, 1992. When the patient listened about the bad news, they may subsequently instantaneously think what will happen to them in the future. And this kind of any information is any information that is not welcome, and it can be uncomfortable experience for both giver and also for the one that tell them, and also the receiver. So it can be a life-threatening illness like HIV, cancer, degenerative condition like Alzheimer or dementia, chronic illness that require chronic treatment like rheumatoid arthritis or SLE, or sometimes everyone want their child to be healthy. So children illness like Down syndrome and also cerebral palsy can be a very bad news to them. And it doesn't necessarily telling about the diagnosis, but it might also include the ineffectiveness of treatment or failure of treatment, maybe in the end stage of life. So why is important? Because this is necessary to facilitate open discussion among patients, relatives, and also the doctors. And by breaking the bad news, it can actually empower the patient by allowing them a greater say in their treatment, and to give them a better time and also psychological adjustment towards the diagnosis and also towards the bad news. And somehow withholding the bad news may actually deny them from the opportunity to face up to it and begin to make the necessary adjustment in their personal life. If they know about their bad condition early, then they can make a necessary adjustment earlier, so that they can cope with that better. In some situation, it can actually be hazardous to withhold bad news until a later stage. So it's important to know what does the patient want from us when we break a bad news. From the patient themselves, they may need more time to talk, and they may need to show or express their feelings. And from the doctor, they may need more information, more caring doctor, hopefulness, confidence in the knowledge and also the information. And some of them may prefer a familiar face. Sometimes they don't really require a subspecialty to see them. Maybe a junior can see them as long as the juniors already develop some rapport with them. So I think this already mentioned many times before. This is how we can approach to break a bad news by using the spikes mnemonic, setting, perception, invitation, knowledge, empathy, and also summary. It came from this study and first presented by Dr. Bachman in 1998 at the meeting of the American Society of Clinical Oncology, ESCO, and was published in 2000 under Dr. Bates' name. So spikes consist of setting, which means we need to provide a good setting when we try to break a bad news in terms of appearance, quiet and conducive environment, develop a rapport with the family and also the patient, and then to understand what does the patient perceive or the family member perceive regarding their illness, what do they understand about the current illness, what are their knowledge, and also it's important to listen what they want to know more about the knowledge, the disease, and also invitation, whether to get the permission if they want to know the details of their condition or family, and also the knowledge that the patient's right not to be informed. And K stands for knowledge, which means we need to try our best to share the knowledge in layman's term, be straightforward, and if possible avoid medical jargon. And then for emotion, we need to create a space to express the emotion, and also need to practice deep empathy, try to put ourselves in their shoes. And for the summary and strategy and the session with summarizing the information meeting, and also strategize what's the best next steps. Maybe offer them what are the available treatment options available that can be done. So in Namal Usri Yusra, verily with every hardship come ease. So for the first scenario, HPE results of a liver biopsy of a 40-year-old man noted to be fibrolamellar carcinoma. How would you counsel? So of course, it's important to approach the subject based on the spikes mnemonic that I mentioned earlier. And in doing so, it is important to have ample knowledge on the illness, prognosis, and also alternative. We may need to discuss with colleague first or multidisciplinary team first before we break the bad news, meaning we need to have ample and adequate knowledge and also what next to do, and be confident while we explain the bad news to the patient. And while doing this, it is also important to develop rapport with the patient. And while we explain to them, pay attention to their patient's body language, whether they are afraid, they are stressed, or maybe they are actually at ease. And while doing so, we can try to gradually break the bad news. And however, for a certain condition, they may be appropriate for another doctor to break bad news. For example, like in breaking bad news, it may require some time for them to absorb the news. Therefore, it might not be suitable for a doctor who is nearing their end of office hour to break such news. Maybe give ample time to the other doctors to explain to them. Or maybe we can ask for superior colleague to explain to them if they have a better knowledge. And then we can also provide information pamphlets, or can suggest to them where they can further search more regarding the condition. And also we need to have a systematic method to deliver, which is using the spike approach. And we need also to consider their cultural difference. For the patient with a strong religious views, we can use this opportunity to stress on the positive and optimistic religious statement. For example, like Allah knows better and inshallah and so on. So I think I can skip this one. In terms of cultural difference in breaking bad news, in different society needs call for special attention. We can consider his view of spirituality, and if necessarily, we can use such views to deliver the bad news. For example, according to Islam, unpleasant life events or disease may offer solution and path for human transcendence. So according to hadis dari Abu Sa'id Al-Khudri dan dari Abu Hurairah radhiyallahu anhu, Nabi bersabda, ma yusibul muslim min nasabin wala wasabin wala hamin wala huznin wala azan wala ghammin hatta syaukati yushakuha illa kafarallahu biha min khotoyahu. Dan tidaklah seseorang muslim tertimpa sesuatu kelelahan atau penyakit atau kekhawatiran atau kesedihan atau gangguan, bahkan duri yang melekainya sekalipun, malaikat Allah akan menghapuskan kesalahan-kesalahannya kerananya. So another hadis dari Abdullah bin Mas'ud radhiyallahu anhu, dia berkata, aku pernah menjenguk Nabi ketika sakit. Sepertinya beliau sedang merasakan rasa sakit yang parah, maka aku berkata, innaka la tu'aka wa'kan syadidan, qultu inna zalik bi anna laka ajrain, qala ajla ma min muslim yusibuhu azad illa hatta Allahu anhu khotoyahu kama tahatu waraqus syajar. Sepertinya anda sedang merasakan rasa sakit yang amat berat. Oleh kerana itu, adakah anda mendapat pahala 2 kali? Baginda menjawab, benar. Tidaklah seseorang muslim yang terkena gangguan, melainkan Allah akan menggugurkan kesalahan-kesalahannya sebagaimana gugurnya daun-daun di pepohonan. So as we all can see, for patient with a religious view, we can use such religious knowledge to remind them that this might actually transcend their status in the eyes of Allah. So for the second scenario, similar to the previous group, but the difference is in terms of the diagnosis. A 60-year-old man recently diagnosed with stage 3 lung cancer. The patient's daughter came to you asking personally
Dr.
about
Khairi,
the...
can you summarize because you are out of time?
Oh, all right. So basically, having surveyed the condition, it's obvious that we need to keep the patient interest and to keep the matter a secret. So what we can do is actually, first we need to explain thoroughly to the patient fathers first, and then use the spike and then make sure the patient understand what is his condition. And after that, we can emphasize that the family may actually needs to know before we can arrange a meeting with both of them once they are ready. So the solution is first to get the patient himself ready first, and to arrange a meeting with both of them once they are ready. I think that's all for my presentation.
Thank you very much, Dr. Khairi. May I have Ustaz Abdul Rahman to give his opinion or comments on the case scenario.
Assalamualaikum warahmatullahi wabarakatuh. I think I have no comment, but for the breaking bad news and so on, the first one we need to know about the what are the perception or what the, because daughters or fathers because usually they have their own impian and so on. So we need to know first before we consult. Kadang-kadang sometimes we give another way, they think another way. So I can membukakan keadaan lah. That's all from me.
Thank you very much, Ustaz Abdul Rahman. I just have one, not question, but I've been thinking about the presentation just now. You were talking about this having illness is a part, a way of expiation of sin. But again, not everyone views as such. So how and when is the right time for you to say to that patient? Because sometimes patient will get insulted, macam as if, am I so sinful that Allah wants to give me disease? I know, to be very defensive on their side. So if anyone can give a comment on that, maybe Dr. Hasbullah, if you have input.
Assalamualaikum warahmatullahi. The word Allah knows the best. It is very okay, very proper for this case, which is in line with the concept of takdir. So in describing the bad news, actually we have to connect with the concept of takdir. Okay, that Allah Subhanahu wa Taala tests with different ways. But Allah Subhanahu wa Taala, but the result is actually based on what we do in our amal. Okay, not based on result. Okay, not based on the result. Okay, meaning that if the result is bad, okay, something is bad. Okay, but Allah Subhanahu wa Taala will give us when we have to face a lot of obstacles, and Allah Subhanahu wa Taala will do a lot of reward. Okay. So anything come from Allah Subhanahu wa Taala, okay, which means Allah Subhanahu wa Taala will give us reward, which is what we call that more than others due to problem that we have. Okay, so we have to think positively that Allah give kita kata test, and Allah will give a lot of reward, okay, as more than the test given to us. So this make us, Allah Subhanahu wa Taala not punish us, okay, but this is a test. Even though the problem come from us because of our effort, okay, tetapi reward, tapi Allah Subhanahu wa Taala don't care about that. Okay, Allah Subhanahu wa Taala will give based on what problem we have. Okay, like the hadis lah kan, mayusibul muslim, meaning that Allah Subhanahu wa Taala tak kira maybe problem itu daripada kelalaian kita, but Allah akan give us reward based on anything happen to us. So this is rahmat from Allah Subhanahu wa Taala. So that thing should be kita kata mention, okay, to patient, okay, in order to motivate them, okay, to accept, okay, as a takdir, as a redha, okay, with the efforts ataupun usaha yang mereka boleh ikhtiar, tetapi itu adalah something yang datang daripada Allah Subhanahu wa Taala, dan Allah akan give us a lot of reward because of that. Wallahu a'lam.
Dr. Khairunisa, can I add some point?
Yes, Ustaz.
Okay, regarding on your question, I think we can answer, or we can reply to for those who ask about this are we sinful because test. First, Allah know that Allah love you because our prophet is the most tested person. Our Nabi Ayub and our prophet, the prophet Ulul Azmi, the most tested person, and Allah love them. Allah love them. This is the first point. Second point, Allah know that you can cope with that problem because Allah said, "La yukallifullah nafsan illa wus'aha." Allah will give the test or give the burden for those who Allah know they can cope with that problem. I think we can answer with the positive side, and we can give the example of our prophet. Can give them a more positive way of thinking. Thank you.
Thank you very much, Ustaz, for the input. Okay, thank you for the group. Looking at the time now, we have about 1 more hour to go. So we shall see how the progress is. Inshallah, probably the last 2 group on vaccine refusal, vaccine refusal and medical leave, we shall bring back to the afternoon session. Okay, So for now, let's continue with the 8th group that will be discussing on the decision making with regards to DIL, DNR, and advanced directive. I would like to invite Dr. Ashraf, Dr. Nur Diana, Dr. Archana, and Dr. Rina. Also Dr. Nurzila.
Assalamualaikum warahmatullahi wabarakatuh. Can you guys hear me?
Yes.
Okay. Assalamualaikum warahmatullahi wabarakatuh to the moderator and also the rest of expert panels and also the rest of the participants. My name is Cik Agnes Hamidi Ismail. I'll be presenting on the decision making and our facilitator is Dr. Iqbal. The rest of our members, Muhammad Ashraf from orthopedic, the rest of us are from anesthesiology, Diana, Archana, Rina, and me. Actually, I'm replacing Nurzila since she cannot make it, so I'll be replacing her. So we were given task on decision making. The questions given were, number one, explain in brief regarding DIL, DNR, and also advanced medical directive. And second, we were also given scenarios, 2 scenarios. The first scenario is based on your medical judgment. You realize that a patient's condition had poor prognosis, that even effective CPR is unlikely to be successful. So how would you counsel the family members regarding the DNR advice? And the second scenarios given to us were a patient with underlying stage 4 osteosarcoma request for DNR if the patient is deteriorating requiring admission. So would you follow the DNR order? So we will go one by one. So what is DIL? We frequently heard DIL in our daily practice, especially those working in ICU. Patients came in deteriorating and become worsened, and we know that the patient won't last long. The patients may die anytime soon. So we said DIL to the family members. What is DIL? DIL means that the patient's death in line. It is a process of informing the family members that the patient is going away, going to die soon. And this is very important to inform the family members as it will enable the family members to prepare for the worst. The ones that are dying is usually their parents, their loved ones. So when they receive this news, they have to basically be primed about the condition so that when they receive the bad news, the patient died, so that they won't be much of a shock, so that they will be prepared mentally for that worst situations. And usually, when we inform the process of the DIL, we also ask them about their expectations. What do they expect out of this? And also, we do ask them, when the patient collapse, assistant and staff, do they want active resuscitation or not, as in, intubating, as in CPR on patients. So we also ask them about their expectations and what do they want out of this. And then what is DNR? DNR is also usually, we usually use this term. It is stands for do not resuscitate. It is actually an order so that we will not provide active resuscitations to persons which resuscitation is not warranted. This usually occurs to the patients who specifically requesting that they don't want any resuscitative measures, or ones that we think that they won't be benefit from having active resuscitation. For example, those who came to us with a stage 4 terminal stage of a certain illnesses. So we know that even we resuscitating the patient, it won't be any good. Instead, we might prolong the suffering of the patient. So sometimes we do DNR towards this patient. And what is advanced medical directive? Advanced medical directive is actually a legal document that a patient or patient's relative sign in advance to inform the doctor that if the patients become deteriorated, become unconscious, say a stroke retreat, for instance, and they don't want any extraordinary life-sustaining treatment used to prolong this life. Basically, it's patient's wish prior to they become deteriorated. Patient's wish, basically, but it's in form of a legal document. So back to our scenarios given to us, based on your medical judgment, you realize that the patient's condition is so bad, had a very poor prognosis, grave prognosis, that even effective CPR won't be successful. So of course, in these situations, usually we do a DNR because we know he won't benefit from active resuscitations. So how would you advise the family members regarding these situations? So when we do informing this to family members, usually we do it in a family counseling session. So in many countries, actually, they getting more aware about having the importance of having advanced medical directive, meaning to say that when they were diagnosed with a certain illnesses, in subsequent follow-up, they will ask by their doctor that what do they expect if they become deteriorated, whether they want active resuscitation, they want ICU admissions, they want, you know, certain conditions that they want to be fulfilled as. But in Malaysia, sadly, we don't have much such awareness about these things. So when the patient become diagnosed, eventually deteriorated, when the patient collapse, only then the family members start to think what they expect from out of this situation. So it won't be good. It will be better if the patients have their own wish before they collapse, so that we can actually grant this patient's wish. And when the patients already become worsened and collapse and won't be able to make decisions, so they will be family members, usually their son, their spouse, to become this surrogate decision maker that will have the responsibility to honor the patients and make the decision for the best patient's best interest. So in the situations, the patient have poor prognosis. This poor prognosis is bad news. So probably I'll be talking about spikes, and probably this is the 5th spikes that you'll be hearing today. So I won't be talking much about it, but I will be probably focusing on the situations that we were given. So as stating, so when the patient's ill, we know already poor prognosis. This is bad news, and we want to inform the family members. So how? Usually in ward and in ICU, we do have a room. We do have a room that, for doctors and also family members to meet and inform regarding the whole bad situation. So we have to set the stage right. And when all family members and doctors in the room, we start to introduce ourselves well. So for example, Dr. X, he is a specialist in this case, so inform the family members, I am Dr. X, I am specialist in charge of Mr. Ahmad, and this is my medical officers. We have been treating him for the past 8 days for such instances, so that their family members knows that who they are talking to and what are the rules in treating the patients. Followed by, after setting, followed by perception. So we ask about their understanding, the family members' understanding of the illnesses. Ask them, for example, Puan Sarah, apa yang Puan tahu mengenai ayah? Apa yang Puan tahu setakat ni? Apa yang Puan tahu mengenai ayah? So that we know actually to which levels that they understand about the illnesses of their loved ones. So when they know about this, we have when they explain back to us, usually you started with an open-ended question, and then when they explain back to us, so we know that whether their understanding is correct or they might misunderstand certain things. So after that, we inform. So basically we inform what's right. For example, we said, okay, betul apa yang Dr. Puan Sarah tahu mengenai ayah tu betul. But if there is any misunderstanding on their part, we have to explain carefully, preferably do in chronological way, so that they will be easier for them to understand. It's very important also to use languages that is easier for them to digest the information. Do not use medical jargon. Use something that's easy and simple, so that we'll be taking on the same level, so that the message conveyed very well. Sometimes we can use medical jargon. For example, they want certain diagnosis in English, in medical terms. Sometimes they want to, Googling the diagnosis so that they know better. It's okay, you can tell them, but also simplify and use translating it to them so that they won't misunderstand about all those things. So that basically same level of communication. After that, we allow go to K, knowledge. We allow patients and allow relatives to actually react with the information. Sometimes they become sad. Sometimes they, of course, they will go into grief situations, grief from denial, eventually reach the acceptance phase. Allow that to sink in, allow the information to sink in, and allow them to react with the informations. After that, we validate their emotions, saying that it's understandable that they are in shock for, suddenly their father collapsed and such stuff. Validate their emotions, because family members are also human beings. They're prone to become shocked, and they're prone to become grief situations also, apart from the patients itself. Okay, afterwards we conclude conclude the whole thing, and then ask them again, ensure that they don't have any more questions arise. And if they have any more questions, you can tell them that you can ask any questions after this, in case they have any more questions arrive afterwards. And this is very important. Avoid showing physician guilt for the loss of poor prognosis. Don't mention things like, if only I do this, patients might become better. Don't say such controversial statements, or do something that is, saying like, if other teams do this, the patient might survive. That is not good, because it's as if showing the physician guilt. This is very controversial, not good. So avoid saying all those things. Okay, so while seeking remedy in Islam is mandatory, when we become sick, it's mandatory for us to get treatment. But if the treatment is only to prolong the final stage of life, meaning to say that patients only prolong the suffering of the patients, many scholars do not advocate treatment, so that we allow withdrawal of pointless treatment, withdrawal of futile treatment, including life support, from those with terminally ill patients, so that the death will take its natural course. So actually, the word "do not resuscitate" is actually allowed, permitted in Islamic law. And the Permanent Committee of Islamic Research and Issuing Fatwa in Saudi Arabia said that if 3 physicians have decided that it is appropriate to resuscitate a patient who is suffering from serious, irreversible disease, that her death is almost certain, there is no need to use resuscitative measures. So basically, if the treatment is pointless, irreversible, no need to resusc. And even though, for example, patient came with the stage 4 CA, we know it's purely irreversible. There is no other reversible cause such as infection and stuff. So purely irreversible, just progression of the illnesses. A patient about to die soon because of progression of the illnesses. We know that CPR won't be good on the patients, but the family members requesting, can I CPR on the patient instead? Can do CPR 60 minutes on the patient instead, because we're still having hope on this patient. Should we follow them? So basically, the opinion of patients or relatives should not be considered, because in such situations, it is not within their capacity to make decisions, but it is within our capacity, because we know the nature of the illnesses. It won't be good. It won't, we as a doctor, remember that do no harm to the patients. So we know that even if we do that, we will only prolong the suffering of the patient. So what for? So we don't entertain such requests. It is within our capacity instead of their capacity. But make sure that we explain the whole situations to the family members so that they won't be misunderstood. Okay, because sometimes they might think that we abandon the whole treatment, but actually we do not so. Actually, we respect the patient's dignity by doing that. So afterwards, we transition into, bacaan doa, recitation of the doa, allowing family members to come in and then recite Yasin, ask the family members to teach the patient to mengucap 2 kalimah syahadah, when it's time, and reassure family members that patients seeking comfort. And if we usually at the end of life care, we do start morphine infusion, so to avoid gasping on the patients, so that patients will be comfortable. So second scenario is that a patient with stage 4 osteosarcoma requests for do not resuscitate disorder. If in case he become deteriorated, requiring admissions, so he requests for DNR. So will you follow the DNR order? So what is DNR? As mentioned before, do not resuscitate order is in order to say that we don't have to resuscitate if the patients become deteriorated. So it is valid when it is done by competent patient above 18 years old with a sound mind. They have the right to make the decisions on their own regarding their healthcare, regarding their medical treatment. So according to MMC guideline, consent for treatment of patients for registered medical practitioners, they have the right to refuse. Every individual is entitled to refuse medical treatment regardless of the reasons for the making of a choice, whether they are rational, irrational, unknown, or even non-existent. So they have this entitlement to actually refuse the treatment since they are above 18 years old and they have the sound mind. So in these patients, he said that he want a DNR, so we can actually follow his wish. It basically looks like advanced medical directive. He already mentioned earlier on that he don't want any restrictive measures on him, so we can actually follow his request. So since he has the decision-making capacity to do that. And for these patients, usually without any advanced medical directive, usually we will ask the next of kin about what do they want, what do they expect, do they want active research, and what do they expect of the whole thing. Okay, and in Islamic societies, merciful killing, also known as euthanasia, and also assisted suicides are forbidden. However, if the patients have a grave prognosis, poor prognosis, will die anytime soon because of the progression of the illnesses, but they wish that not to be resuscitated because you will only prolong their life artificially. So we can actually respect their wishes and follow their wishes. It is under the Advanced Medical Directive. Okay, and in the hadith, Nabi Muhammad SAW mentioned that none of you should wish for death because of a calamity befalling upon him. But if he has to wish for death, he should say, "Oh Allah, keep me alive as long as life is better for me, and let me die if death is better for me." Meaning to say that kalaulah aku hidup, jadikanlah kehidupan itu baik untuk aku, dan kalau aku mati, jadikanlah mati itu dan matikanlah aku, ada mati itu lebih baik untuk aku. From Sahih Al-Bukhari, hadith 5671. And with that, I thank you.
Thank you very much, Dr. Aina Nasiha. I can have Dr. Ibrahim to comment on the presentation or on the topic of end of life.
Just topic is very precise, and also it is very important related to the previous titles. So breaking the bad news, or telling or how you communicate your patient with results of checking up. Of course, this is has a specific etiquettes and a specific ways, especially in the serious cases. And I'm sure that not everybody is good to make this kind of communication, but every doctor need to follow the minimum requirements in the serious cases to communicate the patient with the bad news, as I mentioned here. Okay, from our point of view, of course, usually patients also different in sense that some of them, they accept qadar as being mentioned by doctor. Some of them may be very hard for them to receive. So therefore, what I mean here is case by case and also doctor by doctor. If the matter is a little bit serious, maybe the doctor can choose more experienced person to communicate with the patient. So the issues, the two cases presented are very well done, I believe, and the idea is very thorough and very good. From the Islamic perspective, only when you think need to convey, especially if the person is or the patient is a Muslim, then you bring the things which you make to establish the confidence, like the cited which our sisters mentioned about the Hadith Nabi, which she mentioned that make me die if you believe die is good for me, make me alive if the life is better for me, and so on. So this kind of citation usually bring the person to get ready to any decision come. In all cases, I think the presentation is well done, and of course the time is getting late afternoon. We are a little bit sleepy, you know. Listening is more harder than talking. Okay, so the sisters can talk long time, but we sleep. You know, I am fighting with the sleepy sometimes. Thank you very much.
Thank you very much, Dr. Ibrahim.
Yeah.
There is one question from the participant. What if in future admission, shortness of breath is related to pleural effusion, which we can help a bit by inserting draining tube to help them breathe better? Do we let the patient go? Okay, I can have Prof. Nazri.
Sorry, I see. For anesthetists, I'm sure, of course, everybody is going to die, but of course they want to die in a present manner, right? Not breathless. So if you can comfort them, it's good, because I think the important thing is you need to know that everybody will die. It's like somebody asks a question to a child, kan? How can I go to Jannah? So you have to die first before you go to Jannah. If you don't die, how can you go to the other world? So everybody must go through that period. And in elderly, because I'm old now, when I talk to friends in the masjid, also the party, they already prepared for death, because as you know, in life you have a lot of achievement. You have your son already graduate and then have cucu semua kan. So what is the next step? Naturally is to leave them kan. I mean, most of people at this age, they already have that stage in life, and they will know the next thing they will go is to the grave lah. So I think is maybe when I was young, I never thought of it. I afraid that I will talk to patients, old patients. I will afraid they will be, angry or not. But actually, in their mind, they already prepared for this event. So I think you can talk to them quite freely. Okay, thank you very much.
Thank you very much, Prof. Azri. Thank you to the group presenters. Let's move on to the second last group for this session. So the next group will discuss on medication requests. I would like to invite Dr. Yusuf, Dr. Nadira, Hafiz, and Dr. Ashraf.
Okay, Assalamualaikum and good afternoon, everyone. Thank you for the moderators, speakers, panels, and fellow participants. I'm Muhammad Hafiz Sasharani bin Muhammad Amin. I will be representing medication request topic. I think everyone can see my screen. Okay, so the content of my background will comprise of the question, background, and the list of issues involved, and suggested response and justification. We go on to the first question. A 22-year-old man comes to your ophthalmology clinic and requests a medication for his mother who had defaulted follow-up for 1 month of her glaucoma. His mother is unable to come for appointment due to logistic reason. Will you give the medication now? How will be your response? So the background of this situation is that a glaucoma is progressive optic neuropathy. In advance, it will lead to the tunnel vision. The patient needs lifelong medication, and one of the treatment or management involved is monitoring her intraocular pressure, IOP, and the visual function. So the issue arises here is that there is absence, patient have absent for intraocular pressure monitoring, almost 1 month follow-up, and whether we can give medication without prior certainty, whether we can give the patient or we just withhold the medication. And then if there is no medication to be discarded, there is risk of disease progression. So my suggested response will be, first we need to clarify the diagnosis, to look back at the old notes to confirm the indication to start, to restart the medication. And after that, to prescribe the medication and give the nearest new appointment for the patient. As the doctor, me as a doctor itself, needs to understand that there is a very valid logistical reason that the patient cannot come to the follow-up. The justification for it is that based on the principle of certainty or qa'idatul yaqeen, means that the medical decision for a treatment is made based on the certainty to justify based on the examination that been performed in timely manner. So means that the principle of certainty asserts that the uncertainty cannot abrogate an existing certainty. In this case, the certainty is that the clinical finding that have been found in the patient's note. What is uncertain is the current condition, the mother or the patient who has is uncertain about the current condition. So as we know that there's certain condition that patient needs the medication, we just prescribe the medication and give the newly or nearest new appointment. So for the second question, you are in ward when a patient who are terminally ill for her intraocular lymphoma requests a medication to end her life as she was unable to bear her pain anymore. How will be your response? So intraocular lymphoma is a rare occurrence. It is diagnostically challenged as it presents as masquerade. The diagnosis itself is often late, come in late stage of disease. The 5-year survival rate is less than 25%, and we need to identify the source of the pain, usually arise from the intraocular and extraocular. So the issues here is this patient is in terminally ill patient. Patient might have acute stress due to the pain. A patient requests euthanasia to end her life, and because she believes that this will make him to end the suffering, to end her suffering, because she's unable to tolerate her pain. So my response will be to address the patient's pain, where the pain, the source of the pain come from, what is the current treatment that we give to the patient. And I need to tell the patient that we need to decline the request for euthanasia. We need to consult the patient with the family members for the reason of rejection. And then I need to approach with multidisciplinary approach to manage the pain. For example, maybe we can refer to the palliative referral to address his pain and to manage clinically. So the justification for this based on the Maqasid Sharia, the preservation of life. In this case, that euthanasia violates the purpose of the law to preserve life, because it is it leads to the cheapening that human life, that making genocide more acceptable. It violates in our religion by assuming that Allah's prerogative of causing death. And based on the principle of law of Qawaidul Shariat, the principle of intention, there is no distinction between active and passive euthanasia, because the end result is the same. Means that we kill the patient. Active is we give this patient, we give, for example, injection to kill the patient. The passive means we let the patient die. But the principle of injury makes euthanasia illegal because it tries to resolve the pain by causing more or bigger injury, which is killing. So it's in conclusion, continuation of pain in terminal illness is a lesser evil than euthanasia. And based on the legal competency, based on the ahliyat, patients in terminal illness often lose the ahliyat because they cannot make decision on their treatment. A living will is a non-binding recommendation, and it can be reversed by the family. However, the family cannot make the decision for euthanasia. And based on the MMC guideline for the consent of treatment, it states in the item 7 that patient under high level of stress, in this case, severe pain due to terminal ill disease, cannot competent to give consent or valid consent. And in Malaysia, it's stated that based on Malaysian statutory legislation, euthanasia is illegal. They ban the active euthanasia. However, the passive euthanasia remains implicit. And lastly, I will recite Surah Baqarah verses 286. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ما اكتسبت, which is translated, Allah doesn't charge a soul except with that within its capacity. It will have the consequence of what good it has gained, and it will bear the consequence of whatever it has earned. So Allah doesn't burden a person with something more than he can bear. For the last question, a patient requests specifically for preservative-free eye drops at your ophthalmology clinic in the government hospital for her dry eyes. Upon your history taking and clinical examination, there is no obvious features suggestive of dry eyes. When you would like to prescribe usual eye drop, patient refused and insists on the preservative-free, as according to her, she was informed by her neighbor that she can get the medication here for free. How will be your response? So as with the background, dry eye is a common disease that managed by the ophthalmologist. One of the management is give the artificial tears, which available in preservative and preservative-free artificial tears. Usually the mild and moderate dry eyes can be treated with preservative eye drops, and preservative-free is generally more expensive than the artificial tears with preservative. So the arise issues in this situation is that the patient requests medication prior the confirmation of the disease itself. Secondly, to give medication without justification. And lastly, the misuse of hospital resources. So my suggested response would be to explain clinical findings that patient actually doesn't have the dry eye. Then there is no necessity for any medication. This justification based on the principle of injury, qa'idatul ad-darar, which means that medical intervention is justified if there is injury. However, in this patient, none is found. And based on the preservation of wealth of the Maqasid Sharia, it is injustice to use hospital resources as it's not in accordance with preservation of wealth. We waste our money or hospital resources just to prescribe for a normal patient. And lastly, based on the concept of Khalifatullah, we need to ensure just and balanced decision making, as it is a quality for the leadership. We know that we sympathize to patient of her condition, her worriness, but we need to balance with our akal. It means that we need a justified reason before we prescribe medication to the patient. And for that, thanks. This is for my presentation today.
Thank you very much.
Thank you.
If I can summarize it, there's 3 cases, which are talking about ethics. One is wanting to continue medication without further assessment. Another one is about euthanasia, asking to end one's life. And the last one is asking for medications that are not indicated for the alasan of as a free drugs, because we are providing that. So may I invite Dr. Ustaz Abdul Rahman to give your comments on the presentation on the scenarios. Is Ustaz Abdul Rahman around? If not, probably Dr. Hasbullah.
Yeah, regarding this case, in terms of related with AMD, for instance, okay, euthanasia and so on. What we have to bear in mind that since Allah subhanahu wa ta'ala gives life, and only Allah subhanahu wa ta'ala, okay, has right to take the life. Okay, so the duty of doctors is to assist, okay, to assist what is the best, okay, in terms of what there is hukum about that. And for instance, someone is considered death with brain death. Okay, so sometimes a family quite difficult to accept that. Okay, just to how to tell them, kan? So based on that, I think the truth we have to, okay, mention, okay, but how to reduce, okay, how to explain, okay, in the best way, like to twist conversation, like we connect, like happen in that we talk about something, okay, we talk about something to be patient, okay, like the story of Nabi Ayub alayhi salam, and relate after that with the real situation, okay. So and also the hadith of Bukhari, okay, about us the death, okay, like as mentioned in presentation, it is actually the best thing lah, what we have to do, okay, to face that situation, okay. So anak-anak sebut tadi lah, maknanya perkara itu perlu kita nyatakan, tetapi dalam keadaan yang bagaimana yang terbaik untuk kita nyatakan. So doctors knows the best lah, macam mana nak itu in that situation. Okay, wallahu a'lam.
Thank you, Dr. Hasbullah. Okay, thank you to the presenting group. Now let's listen to the final group presentation for this session. Prof Amin, nak tambah ke Prof Amin sebelum tu?
Oh, tak ada, nanti kita dengar the last group then kita conclude sekali lah.
Alright, sure. So I would like to invite the last group that will be discussing on termination of pregnancy. I would like to invite Dr. Nadia Tushima, Dr. Fatin, Dr. Inani, and Dr. Fatia.
Warahmatullahi wabarakatuh to our organizing committee, expert panels, and fellow participants. Can everyone hear me and see my slide?
Yes, Dr. Fatin.
All right, okay. So I am Fatin Shafika, representative of my group members, Dr. Shima, Dr. Inani, and Dr. Fatia. Will be presenting about termination of pregnancy. So we are from the psychiatry department, and supervisor is assistant professor Dr. Muhammad Faiz bin Muhammad Tahir. Okay, so this is briefly the outline of my presentation. So I would like to start with some definition of the terms related to our presentation. Unwanted pregnancy is defined as a pregnancy that was not planned or not desired by the couple or the mother at the time of conception. And while abortion is defined as the expulsion or removal of an embryo or fetus from the uterus at the stage of pregnancy when it is incapable of independent survival, which medically we describe it as estimated fetal weight of 500 grams or 22 weeks gestation. It may be spontaneous miscarriage, which is spontaneous, or induced for medical or social reasons. Termination of pregnancy is a procedure to remove an embryo or fetus where the pregnancy is less than 22 weeks of gestation, or if the gestation is unknown, where the fetus is estimated to be less than 500 grams. While unsafe abortion has been defined as a procedure for terminating an unwanted pregnancy either by persons lacking the necessary skills or in an environment lacking the minimal medical standards, or both. So why we talk about termination of pregnancy and unsafe abortion is because it is one of the main causes of maternal mortality and morbidity worldwide. Globally, it is estimated around 13% maternal mortality due to abortion. And in Malaysia, safe abortion service is legal if the pregnancy is a threat to the woman's life or when the pregnancy poses a threat to the woman's physical or mental health. So in Malaysia, we have a guideline on the termination of pregnancy for our government hospitals, which was developed to create awareness among government healthcare professionals of the complexity of the issues of induced abortion and to be mindful of the existing provisions given by the professional ethics, legislation, religion, and reproductive rights during consultation with the women client. And in the guidelines, it is mentioned about the existing legal provision, available health services and medical management in terms of the procedure of the termination of pregnancy and the complications involved. And also mention about the comprehensive perspectives from the 5 major religions in Malaysia, which include Islam, Buddhism, Hinduism, Christianity, and Sikh. But in the guideline, it is not included regarding the indications for termination of pregnancy. And also it was not discussed about the mental health perspective as well as the psychosocial management. It mentioned a bit about the pre-procedure counseling, but it is after being decided that the patient is for termination of pregnancy. So in Malaysian law, it is mentioned in the Penal Code Act 574, Section 312. So in summary lah, the termination of pregnancy is illegal except when it is done by a registered medical practitioner that in good faith done due to physical or mental health injury to the mother. So the indication for termination of pregnancy, when we allow for the termination to the abortion to be done, is we can divide it into maternal causes and fetal causes. But I would be mentioning more on the maternal causes, which includes medical, basically physical or psychiatric causes lah. So what is the challenges that we have in Malaysia lah, particularly? Our stigma to mental illnesses is still very high, and for the physical causes, we can see it physically, the medical causes, to reason why some mother justified to have the termination of pregnancy, but it is still it is much more subjective in terms of the mental causes, the psychiatric causes, to define and to decide if the mother have the mental condition that allows her to proceed with the termination of pregnancy. So it is we think it is important to develop a mental health perspective in terms of the guidelines for patient, for the medical practitioners to have a guideline to decide who is the patient can go through the termination of pregnancy lah. So the objective of this is to define the mental health injury based on the legal and other provisions to formulate a standard for the mental health screening and assessment, which is suitable and practical at the primary care and ONG clinics, because this is where the pregnant mother will come first, will be in contact first, and to strengthen counseling component at different phase of management, be it before decision or after the decision, or even after the abortion has been taken place, to develop an efficient system of referral between multiple levels of care, to establish a comprehensive support system to address women's needs, and also to coordinate psychosocial support and management when TOP is not indicated. And to do this, we have to do very vast literature review and expert opinion from the multidisciplinary members, and also to review the evidence of the assessment, the mental health assessment, like the screening tool, and also the discussion with the multidisciplinary team and management, which includes psychiatrists, ONG team, the FMS, public health, counselors, not to forget about the medical and social worker, legal advisor, and also religious representatives. So I would like to mention the possible indication, like mental indication for termination of pregnancy, which could include mostly is the current severe chronic mental illness with life-threatening condition or high risk of harming self or others, which include schizophrenia, bipolar disorder, and also severe intellectual disability, which defined as a IQ less than 80. This is from the formal assessment of the IQ of the patient lah. So the second indication, we can categorize it into acute suicidality. Disregard of any of the primary diagnosis, because many of the mental psychiatric patients have suicidality with different major psychiatric disorders. So this is by determining whether the patient has an immediate intent to harm herself and whether she has a specific plan in mind. Another indication would be the anticipated long-term severe mental illness based on the current clinical condition, based on the assessment by the expert, which is the professional, which is the psychiatrist, psychiatry team. Yeah, so this is to balance with the possible complications associated with termination of pregnancy. So as listed here, this is included in the guidelines of the termination of pregnancy lah. So we can use this to counsel patient that is indicated for TOP, but we have to mention these complications to the patient so that the decision made is beneficial to the patient. And a bit about the result of the Muzakara of the National Fatwa Committee in regards of termination of pregnancy. So for married couples, it is mentioned that it is makruh, which means that it is best to abort fetus between 1 to 40 days if there's no danger to the mother. And the abortion is harus if evidence of anomaly and can endanger the life of the mother, while more than 120 days is haram. Harus means that you can choose not or not. You can choose to opt for TOP or not for TOP, while haram means it is prohibited, as it is considered killing the fetus, as installment already occurred unless abortion is to save mother's life. That is for the married couple. And for rape victims, abortion for fetus more than 120 days is haram, as it is considered for the same reason, considered killing the fetus. And less than 120 days is harus if evidence of anomaly and can endanger the life of mother. While adultery or fornication, it is haram to abort in any condition unless mother's life is in danger. For OKU, orang kurang upaya, which is the those mothers with intellectual disability with IQ less than 80, it is harus to perform abortion for fetus less than 120 days, while it is haram to abort more than 120 days unless mother's life is in danger. So why is it 120 days? It is according to because in Islam we refer to Al-Quran and As-Sunnah. From the Quran we can see this is ayat Surah Al-Mu'minun, ayat 12 to 14, which translated as, we created man out of the extract of clay, then we made him into drop of life germ, then we placed it in a safe depository, then we made this drop into a clot, then we made the clot into a lump, then we made the lump into bones, then we clothed the bones with flesh, and then we cause it to grow into another creation. This most blessed is Allah, the best of all those that create. And to support with this ayah, as mentioned as recited by Sayyidina Abdullah bin Ibn Mas'ud, he narrates that Rasulullah SAW has said, each one of you is constituted into the womb of the mother for 40 days, and then he becomes clots of thick blood for a similar period, which is 40 days, and then a piece of flesh for a similar period, which is 40 days. Then Allah sends an angel who is ordered to write 4 things. He is ordered to write down his deeds, his livelihood, his death, and whether he will be blessed or wretched. Then the soul is breathed into him, which means is given life into him. So from this hadith, it can be said, it is concluded that it is inferred that the soul is breathed into the fetus after 120 days. So going on into the case discussion, the first case discussion, An 18-year-old woman primate at booking 12 weeks period of gestation, premarital conception, request for termination pregnancy as it has caused her to become stressed out. Upon your assessment, there are no features of major depressive disorder. Would you support the TOP for this women? And how would you approach this in this situation? So our group has agreed that for this patient, in general, we would not support for TOP, but with certain condition, which is we need a further assessment in terms of her physical health and also other mental health. It is mentioned that major depressive disorder has been ruled out, but it is not mentioned about other psychiatric condition. So we have to do further psychiatric assessment and also further physical assessment to the mother. We can also do counseling to her, attend to we conclude that she is having a normal psychological response to pregnancy. In terms of it is a premarital conception, which may due to rape. So we have to attend to her stress, provide greater support to the physical and emotional needs. I just mentioned about the opt-out period of 48 hours following the first counseling. This is if the patient deemed to be indicated to go on into TOP, and we will give her 48 hours to decide if want to go through the TOP or not. And if religious views are indicated, the women should be referred to the relevant authority for further counseling and support. So for the second case discussion, 40-year-old woman recently divorced 1 week ago, noted to have missed her period. The UPT is positive and she requests for termination of pregnancy due to emotional stress. She feels not ready and imagines a huge burden should she continue with the pregnancy. So similar for this case, we agreed that we are not opt for the termination of pregnancy for this patient as well, because of the lack of information on her mental and also her physical condition. But what we can do is to validate and appreciate her current situation and concerns at the current situation, and find out the status of pregnancy in terms of her days of gestation, her gravida, how many child that she has, to understand the relevant information given regarding reasons for the TOP. So for this case, it is a psychosocial problem. It is important in the management of this patient to address her stressors, her issues, and we have to refer her to ONG for booking an antenatal assessment since the comorbid that can complicate her pregnancy and situation. We refer her to psychiatrist for assessment to rule out any major psychiatric illness, the severity and the need needed for further treatment, if any. If the treating doctor's moral and religious values is not in favor, meaning that if we are not really sure of the decision, and it depends on the patient as well. If it's the same religious value with the doctors, we have to refer for second opinion with the religious, also for the different professionals as well. I think that's all from our group. So,
thank you very much, Dr. Fatin. So regarding termination of pregnancy, abortions, it is also a hot issue right now in the West, where they are fighting for abortion right. So can I have one of the expert panel to comment on termination of pregnancy?
Yeah, maybe I just struggle to give maybe this is very, very practical and also a well done topic. I think the presenters that did very detailed, but of course the topic itself is very big and at the same time includes so many details, either from medical perspective or even from a religious perspective. So the issue is very important. and practical to be discussed. As you indicated, I think the issue here need to be addressed today because it is a hot issue in the most important countries, especially in America. In last 2 weeks, the two parties which ruling America, they are fighting over this. The Republicans and also the Democrat, some of them pro and some of them anti. This is a time which we are able to produce our values as Muslim, you know. Yeah. So you are able to bring the idea of human karama insaniya. Karama, the human being is honored and dignified creature, which should not be left for the individual decision, except critical cases which may be infecting the father, mother, or the baby, you know. And therefore, I believe Quran put this totally in the hand of the community. And this is the most detailed idea discussed in the Holy Quran, not the termination, but the human creation and even the embryology as such. Therefore, as a medical doctor, grabs a chance to bring this in comparative study with the other communities, you know. And I am quite sure if you bring this through the communication which our brothers mentioned or sisters, the presenters mentioned, we are communicate the good values today and share them with the global communities through the other means. So focus point here is not to make a specific decision in a specific case, but you get the chance to distribute your values, how human being is dignified, how the details of the abortion is being made in our ulama and also in the hadith Nabi. So stage by stage, some of them haru, some of them maybe not alloy, some of them and so on. So these are the values which we need to convey with or share them with the global community today. Okay. So thank you very much. I think group well done. I believe because maybe this is a professional area for them. So they grab it from the fiqh, from the medical, and then bring so many things here. And I appreciate it and I benefit. Thank you very much.
Thank you very much, Dr. Ibrahim. We have a question, interesting question in the chat box. So the question is like this. A primary at 25 weeks of period of amenorrhea and on detailed scan noted to have the baby noted to have multiple anomalies and suspected to have Edwards syndrome, which is a congenital little malformation. But however, it is a suspected Edward, but not yet confirmed with amniocentesis. But the patient has been given option either to terminate the pregnancy or for conservative management. Following the fatwa shown by the presenter just now, it is haram for termination of pregnancy after 120 days unless it is endangering the mother's life. And in this case, the doctor has counseled the patient for termination of pregnancy. From the Islamic point of view, is this still permissible? And what is the implication if termination of pregnancy still took place? I can have the expert panel to comment on the scenario given by our participant. Ustaz Abdul Rahman is here. Dr. Ibrahim wants to add on this?
Yeah, just I already mentioned that the details of the cases, case by case, is usually you cannot give a specific answer to any scenario except you are practically live with the case in the Islamic. But we have principles. So this principle should be observed in the case. So abortion or the termination of the pregnancy generally not allowed except for specific cases. So this is a principle. So we try to find these specific cases, case by case. One of the major cases or reasons is the mother's life. Okay. So if mother life is endangered, then it is allowed, and so on. So the scenario which is being mentioned is the doctor or the religious person can say allowed due to certain factors, due to practical interview with a case, with a mother, with a family, the circumstances which are happening. So he can decide that it is should be done or it should not be done. Therefore, I believe that, or I advise that we should not try to find fixed rules in advance. We focus on the principles. Principle in Islam, abortion, termination of the fetus is not allowed because a human being is a dignified creature, okay? Except for certain cases. So when you say except, then this exception would be spelled out by the practical engagement with the case itself. Practical, I say that, not theoretical. Because if there is any factor which is not fulfilled, then the situation totally will be changed. So we just are focusing that we need to protect, protect the father, the mother, and the fetus in the proper way for the growth. One thing which I need to mention, actually, there's two things in these issues. This issue of the first one is legality or possibility of the terminating the what we call pregnancy. This is very important and to be discussed. Number two, this is one also very important, that is a safe one. If decided to be terminated, then in which way I terminate? So this is the most important part also in Islam, because sometimes you want to terminate the pregnancy and then you kill the mother. So these are the two things which I think need to be taken in consideration in general. So a specific case is not so much important as far as the principles are important.
Thank you very much, Dr. Ibrahim. I think with that, we conclude for this morning session. We still have two more groups to present.
Vanessa, sorry,
Yes.
I think Prof. Amin would like to conclude something just now.
Okay, sure. All right.
Sorry. I just want to add something just now. There are few things that maybe I just want to add on. It is true that the termination of pregnancy, and even the question that has been asked just now regarding the, if let's say there is something that the doctors making the decision to terminate, then somehow from the fatwa point of view, that shouldn't be terminated. So there is a happening actually. And then you know that for the doctors in terms of a medical legal, they are not covered well because they are not following certain rules, especially in the MOH guideline as well as the fatwa and guideline for termination. Okay, that is a case that actually is a need to be highlighted sebenarnya, because even we have the clear guideline, and then we have the good the fatwa in terms of this problem. There are still cases that outlier, out of the scope of the guidance given, and then they need a lot of discussion and everything. That's why we are actually in the process of having what we call the expert group as a Sharia advisory or Sharia committee that will help in terms of giving the consensus of the case or by case basis like this. This is a need for us right now, for us to have this group which is can give a good decision, something like macam as a council meeting, and then discuss the case by case basis to decide whether they want to do, because to avoid the something like the misjudgment ataupun this one, because we are human being kan, kalau macam even the doctors also may make the decision, we thought we are already have the consider most of the thing, but we still can come into the trap of doing something which is later on they'll find out they were going to be misjudged. That is something that our concern. that I think it's good that you all remind me that we need to highlight it for the Sharia Advisory Board for us to form some sort of committee, maybe something GVC can give from the expert of Sharia expert, from the Fiqh expert, from the lawyer, legal expert, and then the medical expert to come together and make a conclusion, which is the consensus that the best thing that for this one individually, not only just conclude in general. Okay, that is one for to respond the answer. I'm not the ulama to give the whether the thing is actually is haram for that particular person to do that. But that is a thing that we need to do. Another thing just I add because I forget to respond before is in terms of the end of life care, which is the practice of what we are doing. Most of the time when it comes to the end of life care for the patient, we try as much as possible to prime the patient regarding what they should do, what the family need to prepare, everything. But also we need to connect the patient to somebody who is trust most. For example, maybe he have the ustaz that he used to be together and then learn everything. So connect it to them, or so that they can have something like yang shooting or something to complement of what we are doing in the hospital. Something the ustaz or something who believe closely, not in particular for the Muslim patient, even for the non-Muslim patient as well. Okay, and then is most of the time the handling the family conference is they need to be done with somebody who actually is senior, and then they have experience as well as they know how to really talk to cover or to talk to all the family member, because that there is to come to make them actually is calm and then accept it is actually is a very big task actually. So that is my comment for the past few cases that we are listening just now. Hopefully they will help us in terms of improving our skills in the managing this situation, inshallah. Wallahu alam.
Thank you very much, Prof. Amin, for the comments. I strongly agree with the consensus that you mentioned just now, because we do need that to decide. I would like to congratulate all the groups that have presented. So with that, I would like to pass back the floor to Dr. Saiful.
Thank you very much, Dr. Nisa, and thank you very much to all the expert panels for the comments, input sharing, as well as for the great presentation by the participants. Inshallah, we're going to begin in afternoon session at 2 p.m. So we'll begin first with 2 group presentation on the topic of vaccine refusal and medical leave. And after that, we're going to have a forum, 2 forums, including 4 groups to discuss about the topics on gender dysphoria, as well as on the topic of breast milk bank. So inshallah, I'm hoping that everyone can join us back at 2 p.m., including the invited expert panel as well. Thank you very much for joining us. Assalamualaikum.
أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم وسلما ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي قمرون وجميل وجميل سيدنا النبي وجميل. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. يا نبي سلام عليك، يا رسول سلام عليك، يا حبيب سلام عليك، صلوات الله عليك. صل على النبي وتبسم، ده النبي تبسم. على حبيبك خير الخلق كلهم. يا نبي سلام عليك، يا رسول سلام عليك، يا حبيب سلام عليك، صلوات الله عليك. صل على النبي وتبسم، ده النبي تبسم وتبسم، ده النبي تبسم. اللهم صل عليه. قلبي المتيم كلما صلى عليك وسلم، ذاق السعادة مغرما يا سيدي يا محمد. صلوا عليه شافع الأمة، بذكر الرسول تشحذ الهمة. يا ربي بجاه النبي أزح الغمة، يا ربي بجاه النبي أزح الغمة. قمرون قمرون قمر سيدنا النبي قمرون وجميل وجميل سيدنا النبي وجميل. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. يا نبي سلام عليك، يا رسول سلام عليك، يا حبيب سلام عليك، صلوات الله عليك. صل على النبي وتبسم، ده النبي تبسم وتبسم، ده النبي تبسم. اللهم صل عليه. قلبي المتيم كلما صلى عليك وسلم، ذاق السعادة مغرما. يا سيدي يا محمد، صلوا عليه شافع الأمة، بذكر الرسول تشحذ الهمة. يا ربي بجاه النبي أزح الغمة، يا ربي بجاه النبي أزح الغمة. قمرون قمرون قمر سيدنا النبي، قمرون وجميل 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 سيدنا النبي وجميل. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم. يا نبي سلام عليك، يا رسول سلام عليك، يا حبيب سلام عليك، صلوات الله عليك. صل على النبي وتبسم، ده النبي تبسم وتبسم، ده النبي تبسم. اللهم صل عليه. قلبي المتيم كلما صلى عليك وسلم، ذاق السعادة مغرما. يا سيدي يا محمد، صلوا عليه شافع الأمة، بذكر الرسول تشحذ الهمة. يا ربي بجاه النبي أزح الغمة، يا ربي بجاه النبي أزح الغمة. قمرون قمرون قمر سيدنا النبي، قمرون وجميل 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 سيدنا النبي وجميل. مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم يا نبي سلام عليك يا رسول سلام عليك يا حبيب سلام عليك صلوات الله عليك صل على النبي وتبسم ده النبي تبسم وتبسم ده النبي تبسم اللهم صل عليه قلبي المتيم كلما صلى عليك وسلم ذاق السعادة مغرما يا سيدي يا محمد صلوا عليه شافع الأمة بذكر الرسول تشحذ الهمة يا ربي بجاه النبي أزح الغمة يا ربي بجاه النبي أزح الغمة قمرون قمرون قمر سيدنا النبي قمرون وجميل 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 سيدنا النبي وجميل
Assalamualaikum and a very good afternoon to all. Thank you very much for joining back for this current afternoon session. I would like to begin our session with Surah Al-Fatihah. Let us read Al-Fatihah first. Assalamualaikum and good day once again to our beloved invited speakers, Dr. Asbah Muhammad, and also to all committees, lecturers, and also participants, brothers and sisters. Thank you very much for staying with us until this afternoon session. Inshallah, this afternoon session will have another 2 group presentation on the topic of vaccine refusal and medical leave. And also after that, we're going to have a forum session whereby 2 groups will discussing about a topic, which is one is about gender dysphoria and the second one is about breast milk bank. So without further ado, to save our time so that we can have more time for discussion, may I invite the presenters for the topic on vaccine refusal. Dr. Siti Sahara, Dr. Firdaus, Dr. Christina, and Dr. Muhammad Hafizuddin. Are you ready?
Sorry, Doctor. I have problem with the laptop for a while.
It's okay. It's okay. Take your time. So I do believe that the topic on vaccine refusal is still going on since before. So nowadays, we know that there's a lot of pandemic and there is issue of vaccine refusal from our public, even from our medical colleagues regarding this vaccine. So sometimes we might encounter that our staff or even our patient refuse to take vaccine and they need to undergo a certain procedure or need to visit our clinic. So how you like to handle that situation? So I think that's one of the issue that we have been shared in the question given to the group. So I pass the session to the representative of the presenters of the group. Thank you very much.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Siti Sahara from Department of Radiology. I hope everyone can hear my voice and see my slide.
Yes, we can hear your voice and see your slide. Thank you.
Okay, thank you, Doctor. Okay, our task is to discuss regarding the vaccine refusal. This topic is basically a sensitive topic that broadly discussed among the media and also among our communities. So this is a bit hard task for us to describe. For the first task is to describe the common reason of vaccine refusal in Malaysia. First of all, as a healthcare practitioner, when we talk about vaccine, there is we need to have a firm knowledge regarding the vaccine itself, the necessity of the vaccine, and also the halal haram about the vaccine before we can talk about the vaccine to our clients and also to the community. So definition of the vaccine itself, the vaccine is originated from the Latin word and the cow, and the vaccinia is an antigenic material that is used to produce an active acquired immunity of certain disease that could prevent or decrease the infection of the natural or wild organism. A vaccine can be made from the weakened virus or bacteria, or can be made from that organism or purified form of protein, peptide, or particle, which similar to the virus or the bacteria. However, no matter the type of vaccine that we use, the function of the vaccine is the same, which is to stimulate the immune response. So we have several types of vaccine. We have live attenuated vaccine that's made from the weakened bacteria or virus, where the virulence is weakened through the repeated culture. We have inactivated vaccine, which made from killed bacteria or virus, where the bacteria or virus are killed using chemicals such as formaldehyde or subjecting to high temperature. It can be from complete bacteria or virus, or only a part of the virus, bacteria, or the toxoid. We have toxoid vaccine, which made from several types of bacteria, which causes a disease by injecting the weakened toxoid into the bloodstream. And the last type is acellular or subunit vaccine, which made from certain part in a virus or bacteria by cloning the gene of the virus through the recombinant DNA, vector virus vaccine, and anti-idiotype vaccine. Regarding the vaccine history in Malaysia, we started to give vaccination in 1868, started with a smallpox immunization, which given to the small population. In 1950, we successfully have mass immunization of smallpox to the whole country, and the diphtheria vaccine and tetanus were only introduced in 1990. In 1961, we have BCG immunization to prevent the tuberculosis, given as the country effort to control the tuberculosis infection during that time. And 1972, we have poliomyelitis immunization. Together, in the same year, we launched the National Children Immunization Program. So until today, there is 13 type of preventable disease. Vaccination is given freely in government medical clinic. So the ruling of using vaccine as preventive measures against disease in Islam encourages its followers to always seek treatment for any diseases we experience. According to Sahih Muslim, there is a remedy for every malady, and when the remedy is applied to the disease, it is cured. with the permission of Allah, the Exalted and Glorious. This seeking treatment is include in preventive measures against a disease before it's happened. In Sayyidina Umar al-Khattab done the same by avoiding area with a plague outbreak. In modern terminology, we call this as quarantine. In Sahih Bukhari, there is narrated that do not put a patient with a healthy person, means do not mix patient with sick patient with the healthy community. If you hear that this plague has broken out in a land, do not go to it. But if it is break out in the land where you present, do not go out escaping from it. This explains what we do during the PKP last time, where we do quarantine at home to prevent the disease. So, according to Al-Ibaadah 1987, the principle of prevention disease in Islam has several advantages. We are the pioneer in the principle of medicinal preventive measure. We have the principle of preventive measure against disease in Islam are in line with the current scientific discovery. And the principle of prevention of disease in Islam is an easy step to employ. It does not require huge financial budget, nor a long duration of time to be realized by the society. So, the ruling of usage of vaccine. If the vaccine is made using halal, clean and pure material, it is permissible. However, if it made from najis material, the usage is divided into two situations. If there is another alternative, then it is prohibited. A hadith of Prophet Muhammad from Abu Darda, indeed Allah has signed down illness with its cure, and he has made every illness its own cure. Then you must seek treatment and do not seek treatment from the prohibited. In second situation, if there is no other alternative, it is permissible. However, there is a maxim that is applicable in this situation where it's darurah or exigent circumstances permit that what is prohibited, but only take what is necessary. So in the ruling of that involve the concept of darurah, we need to meet several conditions. Darurah is really occurring. It's not our assumption. And the person in darurah situation does not have any other way permissible by Sharia to avoid great harm. The person in darurah situation must strive to not choose something that clearly contradicts the basic principle of Sharia and usul akidah of Islam. And then when facing a darurah situation, it must be done in accordance to the necessity of it. The person should not be comfortable committing the prohibited act. In the event a medication with haram product become a necessity for consumption to protect life, this medication or treatment can be taken after advice by trusted specialist doctor of whom his religious beliefs is firm, and it has been proven that there is no other halal medication. So here is our role as a healthcare professional to be firm in our knowledge and our religious belief before convincing our client to get vaccinated. So back to the common refusal reason in Malaysia. In childhood immunization, there is a study conducted in Klang Valley in February 2022. They concluded parents had multiple reasons for refusing childhood vaccination, but felt that communication and empathy from the healthcare professional were lacking. The finding of the study is categorized into two categories. They identified 6 personal health beliefs. One of it is lack of confidence in modern medicine and confidence of the healthcare professional. Number 2 is the pharmaceutical conspiracy to sell medications. Number 3 is preference to a natural approach to health, personal instinct, religious belief, and having a partner with similar belief. The other categories, they summarize as vaccine-related concern. They are concerned the negative effect and the content of the vaccine itself. They doubt regarding the necessity and the lack of information and knowledge regarding the vaccine. So parents are basically concerned and doubtful in giving vaccination or immunization to their babies due to news and rumors that state that vaccine contain haram component and are harmful to one's livelihood. So we came to the recently given COVID-19 vaccination. There is multiple study, everyone wants to do study regarding COVID vaccination. So in the first study is done in August 2021, it's basically a web-based survey that show majority of the respondents willing to get vaccinated. And this group is dominantly by lower age group, have higher education level, female, and those who not having chronic illness. In another study in July 2022, they found that East Malaysian population level of vulnerability in facing biohazard, especially the COVID-19 pandemic, whereas they conclude that unemployed, self-employed, student, men, single, low education, and Muslim are more vulnerable to the COVID-19 virus. And this group likely to experience vaccine hesitancy due to the factor of confidence, mainstream media, complacency, convenience, social media, and authority. So another study in May 2022, individuals who perceive their religious belief against vaccination are more likely to exhibit uncertainty towards it. So we can see here there is I can conclude here from the multiple studies, actually community is lacking of the knowledge regarding the vaccination itself. So basically the confidence of community to the vaccine is lacking, and as our healthcare professional, it's our manner to get firm with our knowledge to deal with this community of vaccine refusal. So we come to the case scenario one is happened in our department. Is one of your medical staff refused for COVID-19 vaccination. How would be your response? So first of all, we need to understand the staff medical concerns for refusal of vaccine 19 itself. Address the staff concern, explain regarding the vaccines. This is where the firm knowledge of vaccine is needed. In addition to traditional live and non-live vaccine, we have mRNA vaccine, several COVID vaccine that have been developed using these technologies. Apart from this active component, the main ingredient of the vaccine is typically water, and some including adjuvant, preservative, emulsifier, stabilizer are being added in very small quantities. The vaccine use several platforms with various active ingredient and excipient. Some are synthetically created in the lab and therefore do not require cell culture during production. So fatwa formulation for COVID-19, halal certification administrator use Holy Quran as guide for granting the halal certificate. The halal pharmaceutical must contain only ingredient permitted by Sharia law, be free of part or derivative of animal declared non-halal, not contain najis, and not be poisonous, intoxicating, or pose a health hazard to user. So the COVID-19 vaccine development process is consistent with the principle of avoidance of harm in Islamic jurisprudence. It reflects the Quran concept of prevention, which can refer to preventive action such as against hellfire, punishment, great bad deeds, and so on. So in Indonesia, where the largest Muslim population in the world, they have granted halal to Sinovac, haram permittable to AstraZeneca COVID-19 vaccine and haram permittable to Pfizer BioNTech vaccine as is used for emergency. Reconciling Sharia law with the contemporary need. Despite potential conflict with the Sharia law, several Muslim countries have accepted a vaccine that utilize impure substance such as porcine gelatin in their production of use. This gelatin undergone hydrolysis, which purifies it under an Islamic legal concept called istihalah. Istihalah means alteration of physical and chemical nature of the non-acceptable haram product to an acceptable halal form. This is the view of Hanafi school and agreed by scholar Sheikh Yusuf Al-Qaradawi and Sheikh Wahba Al-Zuhaili. In addition to istihalah, we have istihla, referred to mixing a substance with another until it dissolves, causing loss of properties, even though the substance is still exists. This unclean product can be mixed with more dominant clean product to vanquish the unclean characteristic. This concept is adapted from the hadith, which explain the characteristics of two colors of water. The Prophet was asked about the status of stagnant water by leak by reptiles and wild animals. Then the Prophet said, if the water exceeds 2 kolah, then it does not become unclean. Another hadith explained, if the water exceeds 2 kolah and is then mixed with the unclean, it does not become unclean as long as there is no change in its smell and taste. So although this istihala and istihlah concept are not universally accepted, all council agree that an effective and safe COVID vaccine is basic necessity or darura emergency. So the COVID-19 vaccine are recognized as necessary or critical for saving life and ensuring that societies can function. This equivalent is in status to other established basic human needs such as food and shelter, therefore is eligible to be classified as darurah. So in December 2020, a special Muzakarah Committee of National Council for Malaysian Islamic Affairs announced that COVID-19 vaccine are permissible and for some even obligatory under Islamic law. So as far as COVID-19 vaccine are concerned, existing information shows that none of them contain porcine or bovine ingredient. Hence, the issue of halal or not should not arise. In the meeting convened in 3rd December, the vaccine committee agreed that the use of the COVID-19 vaccine is compulsory for certain group identified by the government and is permissible for others. As conclusion for the first case scenario, if the medical staff agree for COVID-19 vaccination, then it can be given based on the clinical guideline of COVID-19 vaccination. However, if the medical staff decided against the COVID-19 vaccination, despite addressing their concern, their decision will be respected. I proceed to the case scenario 2. This is a procedure room. This happened in procedure room. You are in procedure room for hysterosalpingogram when your nurse inform you that the patient was unable to show COVID-19 vaccination status as she refused the vaccination previously. What would you be your action? Would you allow the patient to come into your room and proceed with the procedure? So first of all, the patient will be brought into a room, give a privacy with the patient. The patient condition, COVID-19 status should be again inquired. Is it really a patient that didn't take any vaccination previously? Prior to procedure, inquiring regarding patient refusal for COVID vaccination. If possible, allege patient consent. If possible, if patient is keen for the vaccination, and encourage patient to complete the vaccination prior to proceeding for hysterosalpingogram. Patient's new appointment will be given after completion of vaccination. However, if the patient is still not keen for vaccination, despite explanation, their decision will be respected. We need to inquire the risk factor for COVID-19, any symptom, any sign of COVID-19, any recent COVID-19 PCR or RTK test done. And when all are satisfactory, we need to inform the radiologist in charge first before proceed with the procedure with personal protective equipment. With that, I conclude my presentation for my groups. As a conclusions, Islam emphasizes the safety of human. When implementing or deciding on something, it must not contradict maslahah of the ummah and maqasid syariah, which is to protect the religion, life, intellect, lineage, and property. According to jurists, any disease should be prevented, treated, and medicated. With that, thank you.
Thank you very much to the presenters and the group members for presenting that topic just now. So I think your group have summarized and have highlighted among the issue why some of the population or our public patients refuse vaccine. That can be divided into medical causes as well as religious perspective causes. But it is quite clear that according to Islam and also fatwa, it is permissible and most of the vaccine are halal. And it can become even compulsory obligation, especially in the darurah situation, in order to protect the essential maqasid, especially our religion, life, and so on. And in the practical questions, yes, I agree with the suggestion by the presenters and group members that patient decision should be respected after a full explanation and advice had been given and opportunity and facility had been arranged in order for the vaccine to be taken accordingly to the time, and then it can be arranged later for the patient or staff to re-enter back the condition. And some technical issue need to be done, especially for example that staff who actually refuse for the vaccine, HOD need to be notified, regular screening need to be arranged, and if the patient, if the staff is symptomatic, it's a responsibility of the staff to inform the others and need to take precaution, isolation, and so on, so that the disease will not be spread to the other members of the hospital or ward or even in the clinic. All right. May I ask opinion from the expert panel? I think the one remaining here is actually Ustaz Hasbullah, Dr. Hasbullah Muhammad. We know that Ustaz, Dr. Hasbullah, that basically it is permissible and there is no issue in terms of religious perspective, Islamic perspective regarding the permissibility of vaccine. But nevertheless, sometimes we do encounter patients that still use religious reason to against or not to proceed with vaccine, and sometimes it might be difficult for us to convince them. So in other way, how actually we can approach this population who are still refused despite knowing the fact that it's halal or it's permissible in fatwa? Ustaz.
Okay, Alhamdulillah. Assalamualaikum warahmatullahi wabarakatuh. Okay, so in Islam it is very interesting. As we know, the maqasid syariah, objective of syariah is to obtain the maslahah, okay, the betterment of life. Okay, so based on the maslahah, there is something has been stated, okay, or pronounced in the Quran, okay, like liquor, okay, for instance, okay, and other case. And there is another thing is that Islam, okay, give to us to think about that. Okay, what is the best way? What is the maslahah behind that? Okay, so that's why we can say that Islam is relevant. Okay, the teaching of Islam is relevant all the time because of the concern about the maslahah. Okay, for instance, before that, the hukum of organ transplant. Okay, before that. At first, this is haram, okay, but later on, okay, by having technology, okay, and a lot of things, okay, and become permissible because before that we cannot keep, okay, the organ transplant okay, in there is no kemudahan, okay, to keep it, okay. But today we had due to technology, okay, and very advanced technology, we can do that. So the hukum, okay, it's not rigid on that, okay. Once that we obtain the maslah, so Islam allows that, okay. Islam recognizes that, okay. So in case of people that they use religion, they use religion, okay, religion as a reason. Actually, we have to look at the level of people, okay. Even though in Islam there are opinions, okay, a lot of opinions, but some of them maybe take opinions which is not a majority of Muslim scholars, or maybe they refer to the other one, since we have, okay, fatwa, new fatwa, contemporary issue, and so on. So this thing actually we have to kettle mindset, okay, mindset of people, especially Muslim. They have what we call that, they some of them are very difficult to accept, okay, the new thing which is discussed, okay, thoroughly by great scholars, great contemporary Muslim scholars. They still refer to the old one, or refer to the hukum actually change, okay, based on the time, based on the places, based on technology. So this thing we have to face, okay, this group of people that they want to change themselves. So for me, this mindset, okay, we have to okay, set mindset that, okay, what our ulama today, okay, come with a new fatwa, it's not actually based on their desires, but actually based on the maslahah, okay, as happened in the time of Umar radhiyallahu anhu, okay. Umar suggests to establish prison for those who commit crime. Okay, that not happened before. Okay, why? Because at that time there are a lot of people embrace Islam, and okay, some of them commit crime, so they have to be quarantined, they have to be isolated, okay, from others. So this is actually what we call as ijtihad, okay, by those who deserve ataupun who eligible to come with fatwa. Okay, so we have to look at the majority lah. Okay, this case actually some of them, okay, that they don't want to change their mindset. So we have to accept the majority of Muslim actually accept the contemporary of fatwa. So this is the best thing related with maslahah, because when we talk about waxing, for instance, it is actually about what we call rukhsah. Okay, sometimes there is something fall under the darurah, necessity. So there is clearly legal maxim about necessity. Al-darurah tubihul mahzurah. Okay, necessity dictates exception. So why we still refuse that again, as long it is follow the framework ataupun the principle of that. Okay, wallah.
All right, thank you very much, Ustaz Dr. Hasbullah. So I think it's clear that from Islamic perspective, it is permissible to get vaccine in terms of, especially in the daurah setting. But let's say that the patient still refuse after explanation. I think what we can do is actually continuous reminder and not be judgmental to that population. Inshallah, I think by giving time, probably by Allah's will, they will change their mind. And after they're observing the others and also looking at our good character and behavior as well, sometimes it can touch their heart and can change their mind at the end of the day. Yeah. Thank you very much, Ustaz, and also to the presenters for the topic just now for vaccine refusal. I think we can go to the next group for the presentation on the next topic on medical leave. So I invite the representative of the group members to present the slide and presentation. Thank you very much.
Testing, can you hear me?
Yes, we can hear you.
Yeah. Can you see my slides?
Yes, we can see your slide. You
All
can
right.
proceed, Doctor. Thank you.
Okay, thank you. A very good afternoon to Professor, Assistant Professor, lecturers, and also my fellow colleagues. Thank you for giving me, my name is Dr. Liu. I'm actually a PG surgical general surgery. So we actually given a topic on medical leave. I'm going to represent the group of surgical department as well, actually. Dr. Nurul Shajwani, Dr. Ellison, and also Dr. Shaza Putri. My supervisor is Assistant Prof. Dr. Khairul Anwar bin Ibrahim. So the outline of my presentation is included the introduction, the right and the indication of issuing the medical leave, or so-called the medical certificate, MC, Malaysian law on medical leave, and also 2 case scenario we are given. So the introduction. So what we know about medical leave. So as we know, medical leave is a paid leave from work that employees can use to stay at home to address their health needs without losing any earning. It's also a document issued by a physician to ascertain that a person has reduced work ability because of disease or injury. So the right and the indication of issuing medical leaves or the medical certificate is when the patient is certified unable to work due to various health issues, patient unable to work at a full capacity or at his best due to medical condition, or patient feel uncomfortable to go to work physically or mentally. So as I would like to touch about the Malaysian law on the medical leave. According to the Employment Act 1955 EA, a worker who is covered by an EA are entitled to have a paid sick leave in accordance to their length of service in their company. So for example, an employee who worked less than 2 years of service in the company is only 14 days of paid sick leave that given. Those that employee that over 2 years but less than 5 years is only 18 days of paid sick leave. Whereas employee who works more, which is 5 years above, will be 22 days of paid sick leave. This is according to the Employment Act of 1955. An employee who is under a EA must first be examined by a registered medical practitioner or a dental surgeon. Then they must be certified being ill enough to need the sick leave. So employees who claim to be on sick leave but do not have the medical certificate or do not inform or attempt to notify their employer within 48 hours from the start of the sick leave, actually they will be considered absence from the work without the employer's permission, absentees without permission, without just cause is misconduct, which can possibly justify a dismissal from the company. So I was given a 2 case scenario. Case scenario 1 is a 40 years old man required a medical leave for the abdominal pain, but upon your assessment, you noted he is completely well. How would be your response? So firstly, actually, I will address his concern. What exactly he complained of or is uncomfortable with. After a thorough examination or investigation, he was actually found well. I will explain the result to him and ensure that he understands he is medically fit to the work. If he insists for a medical certificate, I will explore why he needs a medical certificate. Is the work requiring a strenuous activity or physical demanding that he is unable to do? Or does he have any other issue that he needs the medical certificate? If there is none, I will explain nicely that working is amanah, that we are accounted to. We are paid for work, and if we are cheated, taking unnecessary medical certificate, of course, is wrong. Consider it as a sin. Even though the employer might not know, but Allah knows everything. what we have done. As a medical practitioner, we can't simply give any medical certificate just because the patient asks for it. Sometimes maybe the patient throw tantrum, but as a professional, we must examine and investigate, and the judgment of the patient is sick or not is actually by us, not by the patient. If the doctor issue a MC even though the patient is not justified for it, he or she can be counted as a conspiring with the patient, which is called bersubahat. Case scenario 2 is a 28 years old woman required a medical leave for taking care of the husband who recently admitted due to acute appendicitis and undergone surgery. Would you give? What would be your response? So, a medical certificate, as I mentioned initially, is a formal document issued to prove that the person is unable to work to his best capacity due to disease or injury. So in this case scenario, the wife is not the patient. I would like to emphasize, the wife is not the patient. In this case, we actually should determine the severity of the husband's illness. How was the husband pre-operative condition? Is it very sepsis? Is it in shock? Is it require intubation prior the surgery? Intraoperative findings, how was it? Is it very complicated? Any complication post-operatively? Or the post-operative condition, is it require a intensive care unit admission? Any other caretakers available except for the wife who is not working, maybe the parents of the patient or the children of the patient, and the family situation and the supports as well as we have to explore. Medical certificates shouldn't be given in this situation because she is not the patient. She is technically, physically, and mentally well. So we actually can provide other options for her situation. Either we can give her a verification letter, a formal document regarding the patient's husband admission, provided the patient give his permission, because due to confidentiality. Time slip might also can be considered, provided she actually came to the husband and we actually can provide her a time slips. So there is other option other than medical certificate, which is she's actually not fit together. So the discussion. From an Islamic viewpoint, it is forbidden to obtain a fake sick leave without actually being sick. The evidence on this is that Allah exalted Mahibi, saying, fear God's to be those which are true in the word and deed. Moreover, Abdullah reported Allah Messenger saying that it is obligatory for you to tell the truth. For truth leads to visual, and visual leads to paradise. And the man who continued to speak the truth and the wills to tell the truth is eventually recorded as truthful with Allah. And beware of telling of a lie. Telling a lie leads to obscenity, and obscenity leads to hellfire. And the person who keeps telling lies and wills to tell a lie is recorded as a liar with Allah. Related by Bukhari and the Muslim. As far as a doctor who gives the employee a sick note that allows him more time off than he deserves, or without actually being sick, he is a liar as well. A deceiver to Muslim Ummah is attested to its hadith where the Messenger of Allah, he who deceives is not of me, is not my follower. In conclusion, it isn't permissible for an employee to get a sick leave without a lawful excuse, or else he's incurring a sin. And the same ruling applies to the doctor who issuing the leave without any justification. In addition, what the letter does reflect the medical establishment where he works on the lying and the deception. Moreover, the wage of the employee is paid during the forced leave is unlawful as well. Thank you.
Thank you very much, Dr. Liu, for that explanation. So I do agree that basically MC is not the right of patients per se, and that patient need to notify the employer, and also we as the doctors have the responsibility, amanah I mentioned just now, to do our job properly, to assess the patient properly, and use MC as indicated as by law, also by our medical and spiritual religious ethic, in order to give according to the needs. I agree with your suggestion for the scenarios whereby whenever that a patient asking for medical leave, if we think that it's not because of medical illness reason. So again, not to be judgmental, we try to understand what is the idea and concern of the patient. That patient come to us on that day. Probably there's some underlying psychosocial impact of certain issue that is not resolved. So the patient probably do not want to go to the work because of some other reason, but we need to explain to them that it's not the right way to solve that solution. And about the second practical scenario, yes, someone, the patient's family members is not a patient, so it's not indicated, and we also have other alternatives in order to resolve the issue. For example, that writing a letter or explanation or giving some solution, for example, that communication with the employer of the patient so that the burden of the family members can be reduced. I would like to open for further explanation or discussion by our expert panel. Probably Dr. Asbullah is here, probably Rahim also here. Because it's quite common issue, Dr. Asbullah. I think regardless of the setting, either in outpatient, even in surgical base, we do encounter patient that probably require or even request prolong of the MC.
Okay, Alhamdulillah. I totally agree with with that presentation. That because actually everything is amanah. Okay, so when we talk amanah in Islam related with reward and sin, as mentioned by Dr. Sud again, Dr. Liu. Okay, related with reward. Okay, sin related with the Paradah Jannah and the Hellfire. This is actually the best controller, the best reminder for Muslim. Okay, if you want to do something, okay, this is related with reward, okay, to Jannah, or it is related to sin, the Hellfire. It's not only related with salary. Okay, so for Muslim, they have to have this reminder in their mindset. Okay, so inshallah it will be automatically will remind, okay, alert him or her to do anything. Okay, in Islam, this is not only worldly thing, salary, but also okay hereafter. So we will get two, okay, in one time. Okay, in this word salary, okay, in hereafter is reward. Okay, the Jannah. So for Muslim doctor has to make their work as a ibadah. Ibadah meaning that it is not only the betterment of this work, but also the betterment of hereafter. So inshallah we'll always remind him or her. It is not only for a certain amount, but it is actually the blessing from God. Okay, in his life, in this work, as well as hereafter. Okay,
thank you, Ustaz Dr. Asbullah. Any other further comments or suggestion from the other panels or participants?
I add,
yes, Paul Ibrahim.
Yeah, besides what Dr. Hasbullah mentioned, Dr. Hasbullah, of course, he is a religious person focusing on ethical part. So sin get in the akhirah or reward get in the akhirah. Of course, it's very important to address the people who are religious and also to remind those who are coming. But besides this, some minimum measures should be taken by the medical doctor to confirm that allegation given by the person or the requester is true. And I think that is what a doctor presented to us, like investigating the case of the husband or just asking the question about it. Because I believe that actually giving the certificate for the sick leave, it's just many cases is taken very easy. Of course, taking easy may be based on trust, you know. Nobody claim that he is sick to leave except he has some basis. But maybe not all people 100% they are in that way. So what I mean is, beside the religious dimension, the ethical motivation for the people not to request something which is false, also the medical doctor need to take at least principal measures to confirm reconfirm that these allegations are true, or he is giving the certificate based on some basis. Okay, so that will be more safer for the person. Implications of giving such certification, of course, not so serious, except maybe ethical in terms of the income to the country, and also in terms of work ethics. But it's still, to be honest, is a part of the requirement of the work wherever you are taking the position. So we should be emphasized on that. I think well done. Presentation is good. The two scenario given also address it well. Thank you very much.
Thank you very much, Prof. Ibrahim. So thank you to the presenters. Alhamdulillah, we have completed the series of presentation by the group presenters. I know that the topic is quite a lot, the scenario is quite a lot, and hopefully that everyone can get some message and importance point from each scenarios. So now we're going to enter and to come to the session of forum. So I would like to explain about the flow of this forum. So most of the time during forum, there will be panelists, but here, because we would like to involve the group members, so there will be two groups. So as if like there will be two panelists, but for each panelist, the group members can present, can talk based on a cycle of question that will be given. So one similar question will be given in each cycle to both group, for them to give their input and also to give their opinions about the answer for that question. So it's up to the group members, either you would like to appoint the same person for each question, or you would like to assign different person for different question, because you will present that panel A for your group and another group for panel B. So the first forum will be on gender dysphoria. So I would like to invite the two group members to be ready. So they are for group 1, for the topic forum gender dysphoria, so Dr. Yuhin, Dr. Nur Hafizah, Dr. Yashtif, and Dr. Muhammad Akram. For the second group, Dr. Nur Izzati, Dr. Fatil Fazil, Dr. Hadid Singh Chal, and Dr. Said Muhammad Esmat Husaini, and Dr. Adibah Ayub. So are you guys ready?
Yes, we are ready.
All right, okay. So I begin with the first forum. After that, the second forum will be led by Dr. Azhar from Department of ONG. All right. So the topic is about gender dysphoria. So let me introduce a bit. So we know that there's a numerous controversies and debates have taken place throughout the history, as well as in our health setting and medical settings, even our religious setting, with regards to sexual orientation and gender identity. And it's noted that there's an increasing trend of our public person, either male or female, complain of dissatisfaction with their anatomical sex, and therefore they might become transgender. They might need to change themselves, because if we can define gender dysphoria, it's a term that describes a sense of unease, feeling not happy of a person because of a mismatch between their biological sex and their gender identity. Many people with gender dysphoria have a strong, lasting desire to live a life that matches or expresses their gender identity, and they might do this by changing the way they look and behave. Some people with gender dysphoria, but not all, may want to use hormones and sometimes surgery to express their gender identity and might therefore become transgender. So my first question to the panels or to the group is that what do you think about the implication of gender dysphoria towards the patient's health, biologically, socially, and psychosocially? So we start with the group 1. Group 1 from Dr. Yuhin's team.
Assalamualaikum, Dr. Saiful. Can everyone hear me?
Waalaikumsalam. Yes.
Okay, I'm Aina. So our point of view from the implication of people with gender dysphoria towards biologically, socially, and psychosocially. So from biologically, Initially, what I can say, sorry, doctor. Sorry, doctor. Do we need to use a presentation or?
No need. No need. You can use a presentation. Also, you can talk to us because it's like a forum, right? So you may use presentation or without presentation, but it's good
So I
that
can
you may.
share. Oh, so I can share my presentation. So I think I prefer to share the presentation.
Yeah,
Is that
sure.
okay? Right.
Yes.
Okay. Thank you, doctor. Can everyone see my slide? Right.
Yes, can.
So we will start with Dr. Akram first.
Assalamualaikum. Okay, before we discuss further regarding the implication on biology and the social effect on the patient with gender dysphoria, so let us first see the definitions of the gender dysphoria. Like Dr. Shaiful said just now, in a layman term, is a mismatch between one's assigned birth or biological gender with the one experienced or experienced gender. So according to latest DSM-5, gender dysphoria is further divided into children and adults. So in children, there are 8 criteria here, as you can see, and at least this patient have to have 6 out of 8. First one is a strong desire to be the other gender or insistence that one is the other gender. So and the second is the boys have the strong preference for cross-dressing or simulating female attire, or a girl have a strong preference for wearing masculine clothing or strong resistance for wearing feminine clothing. And then for the third one is a strong preference for cross-gender roles, like let's say the boy like to be a girl or a girl like to become a girl roles when they play. And then a strong preference for the toys, games, or activities engaged in other gender. For example, boys like to play with dogs. And then the fifth one is a strong preference for playmates of the other gender. And the sixth one, in the boys, they have a strong rejection of typically masculine toys, games, or activity. Or in the girls, a strong rejection with typically feminine boys game or activities. The seventh one is a strong dislike of one's sexual anatomy, and the last one is a strong desire for primary or secondary sex characteristic. This one is for the children, but for in adults, there are 6 criteria here. So at least this patient have to have 2 criteria. So the first criteria is the strong desire to get rid of one primary or secondary sex characteristics. And then the second one is a strong desire for the primary or secondary sex characteristic of the other gender. For example, the man don't like the Adam's apples, or the female don't like the breast. And then the fourth one is a strong desire to be the other gender, and then strong desire to be treated as the other gender. And then the last one is a strong conviction of one having the typical feeling or reaction of the other gender. So these criteria in children and adults can cause clinically significant distress and impairment in social, school, or other social functioning. We have to take note here that gender dysphoria can be associated with disorder of sex development. For example, like congenital adrenal hyperplasia, which I will further explain after this. Next slide. So according to ICD-10, the International Classification of Disorders, so like previously we have discussed regarding the DSM, so now is the ICD-10. It's a bit different for the gender dysphoria is they use the term as transsexualism, which is we have the similar meaning like we have discussed before. And then for pediatric patient or child is named as gender identity disorder of childhood. Next slide. So these are the differences between the gender dysphoria in DSM-5 and ICD-10. So as I mentioned earlier, the term use is a bit different. For DSM, they use gender dysphoria. For ICD-10, they use gender identity disorders. And then, as you can see, in ICD-10, there is no association with overlapping diagnosis like disorders of set development. However, in DSM-5, there is association with disorder of set development like congenital adrenal hyperplasia. And then for ICD-10, the duration to establish the diagnosis is 2 years. For DSM-5 is for 6 months. So these are the main differences between ICD-10 and this DSM-5. Next slide. So we know that gender dysphoria is a mismatch between someone's experience sex and the birth sex. So the other term that can come under this topic is intersex or kunsa. In intersex or kunsa is based on our fatwa from Mufti Wilayah Ketuan. Is defined as someone who has two genitalia, which is male genitalia and female genitalia, or someone that does not have either genitalia but only have one hole to urinate. Mind here that we have two types of two types of kunsa or intersex, which is the ambiguous intersex, of which this person have two genitalia. And then the next one is non-ambiguous, of which this patient is clear that this patient is a male or a female, but this person have extra body part that can mimic other gender. Next slide. So according to DSM-5, people who have intersex condition, like I mentioned earlier, have an anatomy that not consider whether male or female. So this patient, like I mentioned earlier, is in congenital adrenal hyperplasia, have ambiguous genitalia, and then most people with intersex condition come to medical attention because doctors or parents notice something unusual of their body. Usually, this is detected during birth when they are small. In contrast, people who have gender dysphoria have incongruence, experience gender than a sign of birth gender. So I want to highlight here that in gender dysphoria, it can be associated with intersex. So it can be associated or not can be associated with intersex. So I do want. And then the next one, there's other term that come across when we read about gender dysphoria, which is mukhannas or effeminate man, which is defined as a man appears as a woman. So this is according to Nabi SAW, he cursed the man who dress or look like a female. So I proceed to Aina.
So coming back to the question, what is the implication of gender dysphoria towards health? Can be divided into 3 criteria. Biologically, when we look at the from this gender dysphoria biologically, a lot of studies have showed that from childhood prepubertal to adolescence prepubertal, the mean age is 10 to 13 years old. This is where the child experiences physical puberty, first romantic feelings, and changes in gendered social relationship. So the feelings are either persisting or desisting in their gender incongruence. In adulthood or late onset gender dysphoria, sexual orientation typological scheme whereby male or female are sexually attracted to males versus those who are sexually attracted to females, both male and female, or neither male or female. So the females predominantly of early onset gender dysphoria. However, males have late onset gender dysphoria, which emerges at puberty, but it actually emerges at puberty. However, it is late onset because predominantly due to fear. So in Malaysia, the population tends to trial untested, unapproved, unsafe methods towards sexual reassignment, such as hormonal or surgically. Next. So gender dysphoria can be the treatment or the way to change the gender may be divided into two. So the first is hormonal treatments. Some patients may be eligible for puberty suppressions by means of gonadotropin releasing hormone analogs. So roughly in general is puberty blocking treatment, which is started early at stage 2 to 3, and this is when the physical changes are still reversible. So GnRHA can also be used to suspend puberty in adolescents whose gender and adolescents with gender dysphoria, and thus prevent further unwanted development of natal secondary sexual characteristics. However, there are side effects such as hot flushes. There are also a percentage who will develop hypertension and also increase intracranial pressure. Next. The second way is surgery. So there are two main surgeries. One is masculinizing surgeries, which may include mastectomy or top surgery if they did not receive early puberty suppression and have significant breast development, hysterectomy or oophorectomy, colpectomy or vaginectomy, and operations of the external genitalia. Feminizing procedures are as partial penectomy with vaginoplasty and breast augmentation. So trans male who begin early puberty begin at an early age, taking hormone treatments for puberty suppressions, often have insufficient penile skin for classical vaginoplasty and need an adjusted surgical procedure, such as a technique using the colon tissue. So in both scenarios, there are always adverse outcomes. So there is difficulty in finding a partner. There are undesirable results of surgery. Infertility is very commonly associated with treatment before the gonads are fully developed, such as when we start the GnRHA suppression early, so it will impact them infertility. So the impact of long-term pubertal suppression on bone, cardiovascular risk factor due to prolonged hormonal therapy, and also the risk of prostatic disease and prostate cancer in transgender females on estrogen therapy. Okay. Also, we have to understand that there are also increase of high-risk sexual behavior. So I will quote a study done in the United States showing the total incidence of STIs are 4.8%, with 2.8% of those positive for human immunodeficiency virus or HIV. The study also noted that trans men were more likely to have a primary sex partner, and trans women are more likely to have casual sexual partners, and more likely to have unprotected sex. Thanks.
Okay, I will proceed moving on from the point of view from the social and psychosocial. So from social point of view, transgender, as we know, as I mentioned earlier, as known as mukannas, are profusely abused, maltreated, disrespected, stigmatized overtly and covertly, virtually in all societies, whereby the discrimination towards these transgender people is exhibited everywhere, whether it is in educational institution, healthcare center, employment sector, as well as a place of worship. For as example, we know that mukannas people have a difficulty in choosing toilets. Like in Western country nowadays, they can say that they are more lenient, they are more freedom towards this transgender, whereby they can use the women toilet. However, from the Islamic point of view, washroom is a private area, even if it's from the public use. In the toilet washroom, normally a woman will uncover her aura, showing some part of her body. So hence, when the mukannas people see this situation, surely they will cause a great problem and difficulty, since they are from the opposite gender. So to avoid aura and chastity of women being spread to the ajnabi, so this situation is actually prohibited. But there are also studies shown that 90% transgender people were harassed and 25% will experience physical assault because of their gender expression. So following this, from the Western societies, they are more recognizing this, are more tolerant towards this transgender issue by implementing the trans-friendly civil and legal policies, passing a non-discrimination law to provide protection and transgender people in employment, as well as education and healthcare. So from the social point of view, the biggest contribution towards people with gender dysphoria socially is a stigma, whereby it is divided into three parts, which is structural stigma, interpersonal stigma, as well as individual stigma, whereby individual stigma, which is develop an internal stressor, internal trigger, which is if it occur continuously will consequence to the psychosocially, which is patient will later develop some form of mental illness. So from the other part of stigma, such as structural stigma, interpersonal stigma, is more occur towards the environment, which is the society, the community itself, the work environment. So as we can see from the individual stigma is patient have identity concealment, were afraid to express the gender, will anticipate some form of stress, will self-stigmatize, whereby in interpersonal stigma, patient will have some rejection, maybe in the healthcare, in the workplace, worship, difficulty in the worship area, as well as school and family, and will have some harassment or abuse in the form of physical and sexual abuse, whereby in structural, there are more broader form, which is the stigma is more towards the healthcare barrier, economic and gender inequality, lacking of provider in training education, as well as stigmatizing policies. So from the transgender people in Muslim country, from what I read, the literature review said that transgender people are more deplorable in Malaysia, Indonesia and Pakistan, and it is markedly due to the poverty, marginalization, abundant stigmatization, hatred, violence, neglect and lack of education, healthcare, as well as employment opportunities. As an example, these transgender people may having a difficulty in finding job. They may end up working as a sex worker. So therefore, the higher prevalence of HIV and other sexual transmitted disease among these local transgender are developing, and it will become a major public health issue, as mentioned earlier by Dr. Yas just now. But unfortunately, they are still limited data, whereby they only study in a very few countries. So to date, there are only 3 countries that recognize gender dysphoria as a medical condition, which is Turkey, Iran, and Egypt, whereby in Pakistan, they also recently granted that transgender citizen has the right to change the gender in the national identity as a transgender, as a third gender. So from the psychosocial point of view, in view of the internal and external stressor, maybe from the community, from the society, stigma may lead to multiple psychiatric illness for this gender dysphoric patient, such as major depressive disorder, anxiety, self-harm, loneliness, suicidal attempt, as well as eating disorder and substance abuse. So from this part, this numerous report that demonstrate that transgender population is a 2 to 3 times higher of psychiatric illness, such as I mentioned earlier, anxiety, depression, social phobia, as well as adjustment disorder, compared to the cisgender peers, mean a normal people. So these transgender people have a higher prevalence of substance abuse and suicidal behavior, and with 41% has actually attempted suicide in their lifetime. So there are also a multi-center study that found that adolescents with a gender dysphoria had a weak peer relation predicted to have a behavioral and emotional problem, whereby in a patient with people with a high social support environment, which is associated with low level of depression, anxiety, and suicidal behavior, is much lower. Okay, this is from the implication, maksudnya this is the opinion from the biologically, socially, and psychosocially from our group.
All right, thank you very much for that input and also opinion from your group. So I realized that your group have highlighted about the definition of the gender dysphoria from DSM and ICD-10. And I think you guys concentrating towards those with those who actually having congenital anomalies, sexual development disorder, and also muhannas, because they are ambiguous genitalia and so on. So you did guys mention about the options about surgical intervention and also treatment, and also about the implications that mainly about the muhannas and those with sexual abnormality disorders having to face in terms of socially, biologically, and also some mental illness as well in general. So I think that's the opinion from the first group. So let us listen to the opinion from the second group regarding the implications of gender dysphoria, either biologically, socially, and psychologically. I invite the presenters. Thank you.
Assalamualaikum warahmatullahi wabarakatuh. I'm Syed Muhammad Ismat from the second group. Thank you for the invitation. In regard for the first question, I think the first group has covered it pretty comprehensively. And a lot of our data or our information is overlapping each other. But I would like to rather summarize what are certain stressors of issues that might be faced by the patients, especially the gender dysphoric patients. So in terms of religious, there might be a religious controversy, an internal conflict within the patients. Patients might always question whether am I a sinner, or does God not want me to change my sex? Is it wrong to feel that I want to be female? These kind of questions may sometimes bring additional emotional stress to the patients. Next, we move on towards emotional. There are certain internal stressors. For example, a patient might feel emotional stress, a feeling of shame, guilt, depression or anxiety, and even in worst case, they might have a suicidal thoughts or attempts. Moving on, not only to the patients, but we must remember that patients also have to interact with the communities. So this in turn will provide some platform for social injustice, especially nowadays. Probably when we compared 2-3 decades ago, we don't have internet. But nowadays we have internet, and we are spending about 4 or 5 hours every day on the internet, scouring on the social media. With the advent of this technology right now, it opens a lot of doors towards discrimination, rejection, all this stigma. You can, or rather, what we call as a cyberbullying. So this may even push the patient further into depression. Next, we're talking about ethical dilemma. This is not only pertaining to patient, but to us clinicians as well who are treating this patient. Some of the questions that need to be asked is when to start treatment, how the patient will deal with the new altered body, the questions of infertility, or if there's when we are doing a surgery, there's probably the result is irreversible. And lastly, in regards to treatment complexities, the treatment for gender dysphoria is not straightforward. We must consider the side effects, the complications, the surgical complications, what the pain of the surgery, and how long is the follow-up, how about the hormonal replacement, or these are certain challenges that must be faced, not only for the patient, but also as us, as the clinicians. I think that's it from group 2, because most of our presentation is the same with group 1.
Right, thank you very much, Dr. Syed Esmat, for representing the group 2. So I think both of the groups, both of the panelists group actually agree on the definition of gender dysphoria, and they focus on those with sexual developmental disorder and those with muhannas, and that requires some treatment, and what would be the implication of this patient if there's a stigma, and also we avoid, or we not give justice to this group of population. Now we come to the second question that is quite related to your point just now about the treatment of this patient and also the approach. So let's say that you are dealing with this patient. This patient come to you for any reason. Based on your opinion, what is the best way for you to approach this group with gender dysphoria, and how you as a medical practitioner can help this group? Start with the group 1.
So, Assalamualaikum, I'm Yuhin from Group 1. So, the second question is based on your opinion, on our opinion. What is the best way to approach this group and help this group? Okay, next slide. So, based on our discussion and from our view, as a clinician, the most important thing in approaching this gender dysphoric group is to build a good rapport and maintain good doctor-patient relationship, like the previous presentation by our fellow participants for this course. They already touched about building a good rapport and maintaining a good doctor-patient relationship. And to build the trust, a clinician must be open-minded, non-judgmental, especially with this issue, and not imposing our own value and opinion onto the patient. And then we need to address patient's concern on why he or she seeks medical attention, why they come to us, and acknowledge and validate their concern with some empathy. And next is to explain medically the possible explanations of why the patient might be experiencing this feeling. And those are the things that is important, especially if the encounter is the first visit by the patient to seek medical help. This group of people usually live in their own community, in their own, like a small isolated community, and they usually have a big barrier in approaching help outside their community because of their stigmatization explained earlier by my group members. And the fact that they seek help means they put their trust on us, the medical practitioner, and thus the first encounter is the most important to build the trust between us and the gender dysphoric group. And from what the patient disclosed after building the trust and relationship, doctor-patient relationship, if the patient able to disclose their issues, and from what the patient disclosed, we need to provide and suggest relevant solutions, not only medical solutions, but also in terms of their life, in terms of their lifestyle, we can provide solutions. And how to get to this is to discuss with the patient what is their goal, and achieve a consensus regarding the next step of management. Next slide. In a clinical setting, like in a primary care setting, we need to take a thorough history, including their developmental history, if there is any issues during the childhood, like during the newborn period, any issues, any previous hospitalization, any underlying medical condition. And then we also need to look at the family dynamic. Is there any issues, who's taking care of them during their childhood? And is there any family issues, any divorce or any things that can precipitate the issue that they are having right now? And also we need to explore their psychological issues. Apart from that, we need to explore their social, especially their school. Is there any previous experience of being bullied at school? And for female patients that him with gender dysphoria, we need to get a gynecological history from the patient, their menstrual cycle, their maybe their previous relationship, previous is there especially with gender dysphoric patients that isolate themselves and only mingle with their own community. We need to ask regarding high risk sexual behavior, using protection or not, and things like that. And the next thing to do is to do a complete physical examination, including the examination of the primary sexual organ. For male, we need to examine their penis and testis to see if there is any abnormality. This is also true with a female patient. We need to examine their vagina. And then look specifically for secondary sexual characteristics, such as facial and body hair distribution, the stature, and muscular build, and deepening of the voice in males, and breast enlargement, rounded hips, and relative lack of body hair in females. All these examination and history are important to rule out any underlying medical condition that can explain why they are having the gender dysphoria. As explained by my fellow group member, Dr. Akram, all the gender dysphoria is a psychiatric diagnosis. If in primary care setting, we need to suggest or offer the patient to refer him or her to the psychiatry to establish the diagnosis properly and to manage the psychological issues related to this condition, such as depression and anxiety. And then we can also, if we are suspecting there's any other underlying biological, hormonal, developmental, or chromosomal abnormalities, to refer this patient to internal medicine specialist or pediatrics to further investigate and confirm the diagnosis. And if patient is a Muslim and if patient agreeable, we suggest to them to refer them to the local Islamic department for Islamic counseling regarding the issue. Next. And certain investigations should be initiated in the primary care, such as routine blood panels, such as FBC, RP, and LFT, and in follicle stimulating hormones, sexual hormones like FSH, LH, and for male, serum testosterone and serum estrogen progesterone for female. And if indicated, we could also arrange radiological imaging, such as ultrasound testis or gynecological ultrasound, to look for the presence of primary sex organs, because patients with gender dysphoria could also presenting with sexual development disorder. That's all from me.
All right, thank you very much, Dr. Yuhin, and also his group members. So I think they focus on the approach of patient by assessing the idea and concern of expectation of the patient, not be judgmental to the patient, and try to get a real history taking and physical examination to identify what actually the disorder that the patient have, and find out any abnormalities and focus on the solution for the patient. So let us listen to the second group opinion. What do you think the best way for you to approach this patient, and how would you help this group of patient?
Okay, in approaching a gender dysphoria patient, number one, I think the most important aspect is to accurately diagnose whether the patients have gender identity disorder or not. Because sometimes the patient may come obviously to you saying that I'm a transgender and I would like gender assessment. Sometimes they come with that, and sometimes they can come less obviously with mental disorders, for example, depression, mood disorders, and so on. So I think it's very important not only to diagnose the gender identity disorder, but as well as the comorbid psychiatric conditions, because oftentimes they come together. Next, go on with the first line of treatment after we have accurately diagnosed them as a gender dysphoric is by providing psychotherapy. So I think this is our first line, especially in Malaysia, when most of us, this is a Muslim populated country where we are against surgical sex replacement procedures. And apart from that, we need to advise the patient what type of treatment, what type of therapy are available, and we must evaluate the patient eligibility and suitability for any of these procedures. And this condition requires a multidiscipline management. So it is wise to make a formal referrals to colleagues, including psychiatrists, physicians, endocrinologists, or surgeons. Apart from that, while referring this case, relevant history, detailed, comprehensive must be included. Apart from that, lastly, educate. I think education is very important, not only for the patient, but also to the relative, employers and institutions about the gender identity issue. And lastly, always make yourself available for the patient for the follow-up afterwards. Thank you.
All right, thank you, Dr. Said. Yes, I agree with you that there is an important role for us to assess the psychological issue and impact of the patient, and also to involve our expert panel. So multidisciplinary approach to involve in other physician and also those expert in the other specialty, because we cannot treat this group alone, and sometimes we need other opinion as well from other medical field. Yes, so we have finished with the second cycle of the forum. So we come to the last question. So it's a practical questions for the both panel groups. So the question is, let's say a male patient comes to you and requests prescription of hormonal tablets in order to enlarge his breast. How would you respond? Would you allow? So we start with the first group.
Okay, next slide. Okay, so similar to previous question, the most important thing is to build and maintain rapport and to explore reasons behind such requests. Patient might come and asking for the tablet, but they might have a hidden agenda. And explain regarding the pathway and channel before such treatment can be conducted, especially in Malaysia, where we cannot do this kind of treatment like freely. And it must be approved by two authorities. One is KKM, and the next one is patient if Muslim need to be approved by the National Sharia Council, like maybe JAKIM or such authority. And explore the factors that driving or discourage patients from seeking sex reassignment therapy before. Ask them why they are seeking it now. And if patient is underage, we need to involve their parents. But if the patient is an adult, we need to explore the factors. For example, if patient before have ever seek any other treatment before, if the patient have done any surgical procedure related to the sex reassignment therapy, is this the first time that they seek this kind of treatment? And then if the patient haven't done anything, we need also to explore. And if they stated that religion factor, Islamic factor is one of the reasons that why they did not pursue this kind of treatment before. So it is a good opportunity for us to refer this case to the local Islamic department for Islamic counseling. Next, and then like I said before, we need to explain to the patient that in Malaysia, such treatment must be approved by the Ministry of Health, and if the patient is a Muslim, approved by the National Sharia Council also. And sex reassignment therapy could only be performed for medical reasons. That's the consensus in Malaysia based on the previous cases that we will include in the later slides. And after thorough medical examination and review, if the case has been approved by Ministry of Health and National Sharia Council for Muslim, Only then necessary treatment for sex reassignment therapy can be carried out. Next slide. So there's a fatwa from Malaysia actually. There have been several fatwas produced by the Fatwa Committee of the National Council of Islamic Religious Affairs Malaysia regarding the permissibility of genital reconstruction surgery and also hormonal therapy in patients with disorder of sex development. That's why earlier in this presentation, in this forum, Dr. Akram already explained that gender dysphoria can come with underlying disorder of the sex development, such as congenital adrenal hyperplasia and also androgen insensitivity syndrome. So these are two examples of cases that have been approved by the Malaysian Religious Authority for sex reassignment surgery. And next. However, if the patient does not have any other underlying issues, the fatwa issued by the National Fatwa in 1982, they prohibit sex reassignment surgery. As stated in the Fourth Muzakarah Conference, sexual change from male to female or vice versa through operation is prohibited by Islamic law. A person who is born male remains a male even after he has successfully changed to female through operation. This was explained by Dr. Aina just now, that even though they already underwent the sex reassignment therapy, they are still considered male or female based on their original gender. And a person who is born female remains a female even though she has successfully changed to male through operation. However, for a person who was born a khunsa mushkil, ambiguous intersex, who has two private parts of male and female, it is permitted to undergo operation to retain the most functional private part according to the suitability. The khunsa mushkil also include patient who has congenital adrenal hyperplasia and also androgen insensitivity syndrome. That's all from us.
Right, thank you very much, Dr. Yuhin, for the response. So may I know the response from Dr. Said group? How will you approach that request by the patient to enlarge his breast? Will you allow, Dr. Said?
Assalamualaikum warahmatullah. Again, I think I agree with our colleagues from Group 1. Just to share, there is protocols that has been suggested by the World Professional Association for Transgender Health that are widely used in the Western world. So they have given a stepwise approach based on 3 stages. The first stage is the diagnostic stage, in which the psychiatric evaluation by at least 2 mental health specialists. This is to ascertain the diagnosis of gender dysphoria as well as to rule out other psychiatric or medical comorbidities. And as well to ensure that the patient understand the protocols and short as well as long-term consequences of sex change therapy. Moving forward from that, after the diagnosis is confirmed, the stage 2 is by hormone therapy. Here, they usually start the hormone therapy at age of 14 to 16 years, and they aim to suppress the secondary sexual characteristic and to initiate the desirable sexual features by cross hormone administrations. And lastly, stage 3 is the surgical stage. Usually at the age of 18, once the patient has been able to give him or his or her own consent, and after the patient have been on cross hormone or socially transitioning after at least 1 year, medically fit. And this patient needs lifelong monitoring and cross hormone administration. So this is what the stepwise approach that has been suggested in the Western world. However, I think it presents a few ethical questions for us in Malaysia. I think I would like to share one of a decision by the Islamic Fiqh Council of the Muslim World League. Basically, they have looked into the matter of surgically changing a male into a female and vice versa. Basically, it is not permissible for either a man whose male organs are fully formed or a woman whose female organs are fully formed to change into the other gender. The attempt to do so is a crime, and which deserves to be punished for changing the creation of Allah. So this is based on the Surah An-Nisa, the verse 119, and indeed I will order them to change the nature created by Allah. Secondly, in case of Khunsa, like the previous group has mentioned before, if the patient has the organs, we have a combination characteristic of women and men, which the predominant nature of his situation have not been considered, they are allowed to go on for treatment, whether by hormonal or surgical. Because the reason and the aim of the treatment right now is not to change, but rather to cure the condition. Apart from that, I think most of the decision making and all the same with group 1.
All right, thank you very much, Dr. Said, for the input. So I think based on the opinions from both panels group is that the first approach basically when the patient requests is to identify actually what actually the reason or underlying pathology that the patient have for that request. Is this patient truly indicated or not? So are we dealing with a patient that truly have some anatomical disorders, sexual development disorders that causing them to have that desire to change, or we need to cure that abnormality? Or the second one is the one that have well-formed a male or female, however their request to transform into another gender, that's totally prohibited as clearly stated just now by our colleagues from the second group. So I think it's still a hot issue, and I would like to get input from our expert panels, Prof. Ibrahim, Dr. Hasbullah, regarding this issue. So I think it's nowadays it's quite increasing in trend for us to see and to hear about the issue of this gender dysphoria. And from our medical point of view, we would like to identify that if this patient is medically indicated or not for such requests. But I would like to have further opinion from Dr. Hasbullah and also from Prof. Ibrahim. Dr. Hasbullah?
Okay, just to add that little bit about the problem of gender dysphoria, okay, which are known today famously with the name LGBTQ. This actually movement, they are using a name of human right. Okay, human right. Actually, if we can see to the big picture, it is actually come from worldview, the problem of worldview. As you know that there is worldview named what we call as a postmodernism. Okay, postmodernism, which is this era, millennium era, that they put desire as a medium to measure something. Okay, when we talk about modernism is based on logic. Okay, based on what logically, okay, we accept or we reject. But today, postmodernism is something to measure something is desire. Okay, what our desire need. Okay, hedonism. Okay, luxury life and everything. Okay, so from that, desire as a panel to measure something good or bad. Okay, so it's come from this movement. Okay, this worldview, and that's why we can see that they are very vocal about human rights and human right, actually human individual rights. Okay, that based on individual. Okay, if we look something good, Okay, so for me it's good, not for others. Okay, maybe there are other views. Okay, so from that movement, actually we can see that this movement of LGBTQ take a place, even in film. Okay, they insist some of the country to accept this. Okay, and okay, so this is what we call a global problem today. But if we come to Islamic point of view, we can see that this is totally different from fitrah itself, actually. Okay, so for me, for gender dysphoria, few things that happen, okay, other than this is movement, okay, global movement, okay, especially in the West. First, okay, beside that, first is education. Okay, so how the way, and in Islam, okay, there is different way to educate male and female children. Yeah. Second is according to some, wallahu alam lah, but I heard one of speakers mention this what we call kecelaruan benda ni, some of that, okay, because of what we consume in terms of halal and haram food. Okay, jadi sedikit sebanyak dia memberi kesan kepada kita punya pembinaan jati diri lah. Okay, and third is influenced by social media and others. Okay, so itu akan merancakkan lagi, okay, sesuai dengan apa dia punya postmodernism era today, maka dia menjadikan dia akan satu perkembangan yang agak besar lah. Okay, and apa influence kepada globally lah pada hari ini. Okay, so anda tengok from that view lah, berkenaan dengan apa gender dysphoria. Okay, mungkin Dr. Ibrahim Shogar can.
Yeah. Thank you, Dr. Asmullah. Prof. Ibrahim, any comments and
Yeah.
opinion? Yeah.
Yeah, first comment is actually this topic, I believe it is need total separate what we call forum to be discussed in more detail, because it is became a phenomenon across the global and also even in Malaysia and Indonesia. This issue is coming. So the issue is beside what being mentioned by Dr. Hasbullah, also has very grave social implications. So if we imagine one community, half of the community became this gender dysphoria, then that is the end of the nation. And the Holy Quran describes a lot about how the nation is going to end. And explain to us also some cases, but that cases is different from this. For example, Qawmi Lut, those who are desiring the male instead of the female. This is a process of the action itself. Action, that means usually the male desire female and female desire male. But if it is became opposite, that means the end also, because going to male cannot produce offspring, which is the end of the desire itself. So the conclusion, desire is a continuity of the human being. Therefore, I believe the whole process is put in wrong place, even though today became very dominant. And last 2 weeks, I was listening to TV. Then US president not interview, it is introduced, I think Ministry of Communication. And during when he was introduced himself, and then she mentioned that I thank my husband. See, he's a man and have necktie, and then he bring a man again and sitting behind him, and then indicate to him, this is my husband, I sang him. So I immediately thinking that this kind of nation is going to end, regardless of the ethical viewpoint. So maybe if we want to just, I reflect a little bit about what Dr. Hasbullah mentioned. This issue is actually based on philosophy. It is a philosophy which is totally different from our philosophy. Philosophy of the fulfillment of the personal desire is dominant here. So if person has something, he can do it. Either it is ethical or unethical. And this one is even in the Western communities is being rejected. But due to the political situation, they try to enforce and promote through the media. In Islam, no. In Islam, as being our ulama mentioned and mentioned in the Holy Quran, the Sharia is to rescue the people from their own desires. So Sharia, I desire to steal the money of somebody, Sharia say no. I desire to make what we call fornication with any lady, then Sharia say no, and so on. So this desire is not place for the determining of the what should be the gender. Maybe the second point which I need to mention here, in Islam, actually the gender is only two. So many ayat. I'm starting to collecting in last few days the concept of gender in the Islam, and then do there is third gender or not in Islam? I found that not. Of course, in biology, yes. Biology, some people come between male and female due to many maybe factors. Okay, but these people need to be what we call treated to get their identity, and that is what I think the last presenter, he mentioned very important statement, and that is reflecting the role of the medicals. He said that medical are or the doctors treat, not change. Treat, not to change, to treat. Okay, if we take this in a very focused point, so to see what the role of the doctor. Okay, so the role of the doctor has two roles. Number one, right now we have so many diasporas there. So doctor deal with these people, and that is actually the presenters explain very well. They check them medically and see them what happening to them. And this is your medical doctor. You never concern he is male or female. This is first. Okay, you treat him as human. Deal with him as human. That is one thing. But the more important role of the doctor is not this. And I believe this, the grown people who are already involved and they make a community, this will deal with them as a matter of fact, de facto, the matter of fact. That means like slavery, when Islam come, there was slavery. So Islam take it as a matter of fact and then slowly get rid of. So medical doctor also should be the same. Should be the same. That means you deal with the case as a factor, but there should be a strategy for get rid of. But this should not come from the medical doctors, no, from the community. So how this done? I believe actually this those who are being genders diaspora, actually there are two, as you mentioned. Real one is those who are being ambiguous, those who are being born, the identity is not clear. So the medical doctor play a role to find the identity. One get the identity, then officially or socially that identity must continue, because in Islam, to identify the person, male or female, has very implications even in the mawarith, in the economics. So there is no ambiguous area. In fact, there is area, but the identity, the person should be identified by medical doctors. He is male or he is female. But of course, he has no ability maybe to function, for example. Okay, or there is identity according to the medical checkup. Second, which medical doctors to play is those who has desire, as I think presented by the first group. the different categories of the children, those who have strong desire to be male, strong desire to female. Desire never became a basis to change the identity, never. So what the doctor do is to deal with them, to rehabilitate them. And this, of course, the family should involve it. So the child who is a male, but he start to be acting like female. So this should be rehabilitated, okay? Rehabilitated in terms that he should follow his natural gender. Of course, if he rejected, then there is laws from the country or from the community, which is actually the government. Strictly, there is no change. And that is what our brother mentioned. No, the doctor treat, no change. And this, I think, what Malaysia following right now. So if I want to change my gender, no, freedom here is counseling. Okay, so I will be the same. Nobody will search for you. Okay, so that is a situation, because this person, if you follow his desires, desire has no end. So when you change his gender, what is going to be? To be like what you are now suffering, medical doctors suffering now, to what you call rehabilitate the grown people. Some of them, they will full genital actually. They are full male, just dressing their clothes, the clothes of the female, I mean. And Alhamdulillah, here I am in the OCD under Prof. Samsul, who is a specialist in this area, and I believe he has very good programs, including Muhammad Ibrahim from CAS. They play a role to deal with this group of people. So this group of people, as you are medical doctor, you care them, of course. Be kind with them, because this is what's happening. This is a result of the community. But as a community member, no, you must reject. And that is why the example which you give last, that is, if one of them come and ask for the hormone to grow his chest, how I deal with that situation? Of course, as medical doctor, I mean, may you give. But as a community member, no. Community member, you must ask him to bring the permission. Okay, and so on. So what I mean is this kind of dealing is very important. And I believe that what Dr. Hasbullah mentioned should be the basis. That means to create awareness that this issue is not new, okay, in the history of the mankind, but Islam come to fight against it, and the philosophy is totally imported. So we cannot take whatever come from the West. Even the standard, which our brother mentioned, to deal with these gender changed people. Do we take this? No. Okay. Anything related to the marriage and reproductivity, we should not take from the other communities. No, we have our own values, which is established by Islam. And you are unable to take it. Actually, any government takes this, tomorrow will be taken away from the power. I'm sure the community do so. Our Prophet said that this Ummah is protected by the majority. Okay. In Sudan, last time, this is my country, last few months, actually this kind of things come, but now clean it by the community. Government close the mouth, say nothing, but now actually no, this kind of things there. People now start to fight against them. Community fight against them. So what I want to say here, as you are medical doctor, your role here is two levels. Level of the treating them when they are young, to identify what are the gender of this person due to the medical checkup. So the government officially gives identity. This is male, even though he has no genitals, but it's still the medical checkup show that he is male. So as such, then his mawaris and his community relationship go like that. Forget about his desires. Okay. Yeah. I worry maybe I took so long time, but this is the most important. The second role for the medical doctor is to rehabilitate those who have tendency. Either they are very young or either they are grown people. Like today, I think last program conducted by Kulliyyah of Medicine, were able to rehabilitate some of them. I remember maybe Dr. Muhammad Ibrahim tell me that they are able to make even someone come back to the malehood. So they are being sent to Umrah. They did Umrah. So this is very great job, I believe. So you are medical doctors, that is your role. But as a community member, no, you fight against the system, against this kind of things. And I'm sure sooner or later it's slowly going to finish. The community who takes this for life, just make sure that they need to import the people after maybe 2 or 4 or 5 decades. That means 50 years later, many countries need to open what they call immigration. Immigration is import the people. Why? Because these people are going to die, going to end. Let them marry male for male, female, no problem for them. Ethic is not there. So we see, inshallah, as far as many of you right now, you are young, I am sure after maybe 30 or 40 years, you see what is the consequences of this kind of behavior in all communities we should follow. Either even Muslim who want to follow this kind of things, you see them, what is going to happen to them. Don't say ethically Allah destroyed them. No, not that's the issue. But naturally they are going to end. So I am sorry, Dr. For this long speech.
Thank you very much,
so
Prof.
Thank you
Thank you for that great explanation. We really need that. So I think the message by Prof. Ibrahim is really crystal clear that we need to treat but not to change the gender of the patient. So I would like to get opinion from Ustad Abdul Rahman. I think Ustad is here. Ustad Abdul Rahman?
Yeah, yeah.
Yes, Ustad. Alhamdulillah, still here. Thank you for joining us, Ustad. So any further comment from Ustad?
I think all the discussion should be covered by Sugar and Dr. Fullah. I think, but for the I just joined maybe 5 minutes before. Is this GD is clear? This we know that the gender is unclear.
Oh, okay, Ustad. So in this condition, when the patient come to us, we need to make sure that is this related with unclear because of a sexual developmental disorder, or just because of that the patient desire, as mentioned just now. So we as a medical doctor, we need to verify that first. So is there any medical disorders need to be treated? So we need to treat. If it's purely because of the patient desire, as mentioned just now by some of the speakers and invited panel, so we need to educate them, and we need to verify that this is not indicated for now. Yeah.
Yeah, as we know, as from a Fiqh discussion on the topic, we have we can call it khunsa mushkil and khunsa mushkil. But based on my limited research, I think our technology we can identify right now is very hard to say this khunsa mushkil. I think never dah tak ada dah kan sebenarnya. So the problem, like Dr. Ben Sugar said, not to change the gender, to treat them. Okay.
Yes.
That's all from me.
Ustad Rahman, maybe Ustad can respond to the question from the chat box. Someone asking, Assalamualaikum, I'd like to get input. How are those with gender dysphoria being segregated for prayers, clothing and place? Second, in the event that they want to perform Umrah or Hajj, how about their type of ihram? Maybe Ustad Abdul Rahman or Ustad Azullah.
Okay, thank you. Okay, for the salah, if the gender is not clear yet, it's gender khunsa mushkil. So the places of the for the saf, yeah, is between the man. The first is man, and then a boy, and then the khunsa mushkil and woman, and for the girls. So in between man, boy and woman. So it's for the arrangement in the soft salah. Okay, for the clothing, we need to be safe. So she or he need to cover like woman, because woman is more pakaian lebih menutupi lah. Okay, same goes to for the ihram. For the ihram, for the safest untuk selamat, he or she need like woman, because the woman cover lebih banyak lah. Okay, but as I mentioned before, this thing I think hard, susah jumpa dah khunsa mushkil, because our technology, our test, we can identify, we can decide whether male or female.
Right, thank you very much. The response, Ustad Abdul Rahman. Dr. Hairi, are you asking question? Dr. Hairi, you raise hand. You would like to ask a question or would like to give a comment, Dr. Hairi?
I will just do a little bit. The most important thing is to make it clear the status. Okay, man or women. Okay, or in both. According to Fuqaha, he has to, she or he has to decide lah. Okay, ataupun which one is apa predominant, yang lebih kuat lagi. So make it clear status first lah for me. Okay. Wallahu a'lam.
Thank you very much, Ustaz, Dr. Asbullah, for that input and also for us to remember. I think I'm more than happy to pass the second forum to my colleague, Dr. Azhar from the Department of ONG. Dr. Azhar, you may proceed with the forum on breast milk bank. Thank you very much.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Dr. Shaiful Ihsan. So for the next session, which is the final session for the day, is on breast milk bank, and we have two groups panelists for the forum today. One is from the family medicine department and the other is from psychiatry department. So both of them have worked for the last 1 month or so to prepare for the topic, inshallah. And so just like the forum earlier, we will do the forum today based on the question number. So question number 1, and then we'll ask the group family medicine for their opinion, and then psychiatry group, and that's how we go. Okay, for all the three. And then we will ask for expert opinion from our panelists, expert panels, and inshallah. So without further ado, I would like to start with the first question. So regarding breast milk bank, based on your opinion, what's the importance of having breast milk bank in a hospital? I will invite the group 1 first for your presentation. Group 1 family medicine.
Assalamualaikum and a very good afternoon to all the lecturers and fellow colleagues. We will be presenting regarding the breast milk bank. So Shira, tolong present ni slide.
Is the slide visible?
Yes, it's visible.
Can you make it full screen?
Yeah.
Present. Okay.
Okay.
Yeah, good. Excellent.
Thank you, Dr. Azhar, for the questions regarding the importance of having a breast milk bank in hospital. So as we all know, human milk has been well studied, and the benefits has been very much established. So it has a biological component where there is immune properties, enzymes, and as well as growth factors that can protect our little babies against infection. And also it is crucial for the growth and development of the baby. Because of the nature of the breast milk, it is much easier to digest, and in the infant's kidneys are also more capable to process the breast milk as compared to formula milk. A meta-analysis which collecting 22 years of data showed 58% reduction of necrotizing enterocolitis (NEC) when infants were fed with human milk. So as for your information, formula milk has been associated with 3 to 10 times increased risk of premature babies developing NEC. Other complications such as sepsis proven significantly reduced in preterm babies fed with human milk. Feeding intolerance as well reported to be lower. Therefore, breast milk bank can protect our compromised babies as well to provide breast milk for their own child, for their own babies because of various reasons. For example, HIV mother. So the other word is, we can say that breast milk bank is the lifeline for many preterms and also low birth weight babies. Next slide. So the development of Usulul Fiqh is to ensure that maqasid syariah is achieved. So the most important reason why the development of breast milk bank is important, because it is for protection of life. As I mentioned before, many studies have proven that breast milk can reduce the risk of necrotizing enterocolitis, the incidence and the mortality. And the next in line is for protection of lineage. If breast milk on Shafi'i, so male kinship is established and marriage is prohibited among the baby and the donor's children. And the next is protection of the benefits discussed. There is no doubt that it is crucial for the development of breast milk bank. However, there are certain barriers in developing a breast milk bank in Muslim countries regarding the milking issues and whatnot. So it will be discussed after this by my friend. And so the development of breast milk bank in Muslim countries need to be designed and carefully planned. That's all.
Okay, I invite the secretary group or your opinions.
All right, so I would actually like to divide the importance of having a breast milk bank in a hospital by the 3 factors, which are from the infant factor, mother donor factor, and also from the hospital factor. So it's first and foremost, it's actually important to understand that the human milk banks are not meant to supply milk for normal term babies, but they are intended to save the lives of the most vulnerable babies in our society, such as the very premature, low birth weight babies and unwell infants in the neonatal intensive care unit. So we already know about the importance of breastfeeding, but breast milk in preterm baby is actually life-saving due to its protective factor, decreases infection, and is easily digestible. So this is where the human milk bank steps in to fill in the void by providing the donor milk to these babies for the first few days of life until the mother starts lactating and starts providing her own milk. But what about mothers who cannot breastfeed their own child? So they are, for some reason, maybe the mother is infected with HIV virus, they have untreated active TB, or is taking prescribed cancer chemotherapy. This is where the pasteurized donor breast milk is widely used. However, we do know that the pasteurized donor breast milk is not the same as the fresh breast milk because it loses the certain bioactive and immunological properties. The ingredients, as mentioned before, of the human breast milk includes the immunoglobulins and other active constituents that can reduce infection, necrotizing enterocolitis, cardiovascular risk, and metabolic diseases. So if a mother's own breast milk is not available, the second choice should be the donor breast milk. And that's where the donor breast milk, that's defined as the breast milk expressed by the mother, which is then processed by the human milk bank for use by a recipient that is not the mother's own baby. So that's for the infant factor. From the donor factor, we know that the human milk bank is essentially a service that collects, screens, processes, and dispenses the human milk from mothers who are not biologically related to the receivers or infants. So having a human milk bank in a health facility increases awareness about breastfeeding among families and community. According to the NICE guidelines in 2010, the promotion of donation of breast milk should be aimed to reach as many potential donors as possible through different channels, including providing written information or direct referrals. So we already know that new mothers, they would come to the healthcare facility for their postnatal checkup, and we can easily recruit these mothers into the program. At the same time, the donor screenings can be done straightforwardly in the hospital itself. Potential donors can immediately undergo an interview process. We can refer to the medical sources if necessary. We can also do the serological testing immediately at the time of enrollment. Other than that, by locating a human milk bank in a hospital, the mother donor can also be provided with appropriate training and support throughout the donation process. So the training should cover about hand washing, milk collection and expression, storage of the donated milk, labeling of the donated milk, and documenting the storage conditions, as well as transportation of the donated milk. Lastly, from the hospital factor, it's important to have a human milk bank
in hospital setting to ensure the safe operation of the human milk bank. This is mainly to ensure the quality assurance of the donated breast milk, whereby we should think about the equipment used that needs to be validated, calibrated, and maintained well for the human milk bank. Other than that, we should also take note about the milk's expiry date, whether the milk is raw or processed. Training from an experienced member of the staff should also be done. As well as the most important thing is the record of all the donors that should be kept, including the volume of the milk. Other than that, we should also think about the expression of the breast milk, because the donor should collect the express milk rather than just the drip milk, and as well as the importance of the milk screening. So basically, I think the importance of having the breast milk bank is according to where to the infants, mother donor, and also the hospital factor. Thank you.
Thank you very much. So as a summary from both of you, it's obvious we all know that breast milk is superior in so many ways. And from the other point of view is the need for the breast milk bank is for those who are in need, particularly those babies who are premature in NICU, who might be there for a long time, and while the mother are not there, unable to provide the milk, those babies will still have the benefit of getting the breast milk, even though it's not from their own mother. So, okay, move on to the next issue. Based on your opinion, is there any issues related with breast milk bank, ethically and from religious point of view? I would invite group 1 first from family medicine.
Thank you, Dr. Azhar. Assalamualaikum and good evening. I'm Nadira, year 2 family medicine. So breast milk bank has been established in the Western country, but there are some issues related to breast milk bank ethically and religiously. First of all, whenever a breast milk bank practice giving rewards, this may lead to secondary gain. Paying donors, be it money or other rewards, could result in significant risk for infants. For example, the mother or donor may neglect breastfeeding their own child, instead giving all the breast milk to breast milk bank for the sake of the rewards they get afterwards. As a result, the mother is denying her child vital immunological benefits and nutrition. In addition to that, due to the secondary gain, the donors might give false information or hide their illnesses or high-risk behavior during the screening process itself, just for the sake of getting rewards. Milk donors should be safe donors. The donors are to be screened prior to donating the breast milk to breast milk bank. However, for example, mother with high risk of HIV might lie about their health status and plan to donate their breast milk to gain rewards. This might jeopardize the safety of the breast milk donated. Other risks could include the intention to increase income or rewards by increasing the milk volume through adding water to the breast milk, or even mixing the breast milk with formula milk, while some might change the date and time of the expressed breast milk, hence endangering the infants by jeopardizing the quality, nutrition, and safety of the breast milk. I think Dr. Najee have some other points to add on.
Okay, Assalamualaikum. So as Nadia has mentioned regarding the first two ethical issue related to breast milk bank, the third issue, ethical issue related to breast milk bank establishment is in terms of exploitation. So what I mean by exploitation is that when a healthy mother, any illness or issue, will take advantage of the breast milk bank to feed their children breast milk instead of breastfeeding them. So some mother actually have no reason at all not to breastfeed their children, but they just wanted a hassle-free life, and they also wanted the best nutrient for their children. So they opted for breast milk from the breast milk bank to feed their children. So this is actually, if there is only one mother who did this, it's actually well, not I would say acceptable. But let's say there are 10 or thousands of mothers who wanted a hassle-free lifestyle and then opted to apply to the breast milk banking just in order to get the breast milk to feed their children with the breast milk. So can you imagine what about the premature babies that is actually in need of the breast milk more than their babies actually. So this is what I meant by exploitation. And then for the religious related issue, this is actually the most important points that everyone needs to know. For non-Muslim especially, one of the reason why breast milk bank is being pushed back to be established in Muslim countries for quite so many years, because the first breast milk bank is actually established in 1907 in Vienna, but the Muslim countries only recently started the so-called breast milk bank. And for Malaysia itself, UIA just launched the Halmatus Sa'diyah breast milk bank recently. The reason is because of this kinship issue. So it's actually a major setback that prevent us from doing the breast milk bank sooner. So when I said about a kinship issue, it's actually a kinship issue. So the 97th Conference of Fatwa Committee National Council for Islamic Religious Affairs of Malaysia, which was held on 2011, prohibited the breast milk bank establishment due to preservation of lineage issue, which is in conjunction with our Maqasid Syariah. So for your information, the breast milk bank is actually being run by multiple mothers who donate their breast milk, and then so they are actually poolings of breast milk by multiple mothers, and the donor is actually anonymous. So they will just take any of the breast milk to be given to any infant. So this is actually something that is not Sharia compliant. So for in terms of milk kinship issue, it's actually an issue related to our Maqasid Syariah, which I mentioned just now, preservation of lineage issue. So imagine, let's say Nadira, let's say my friend just now, Nadira is a premature baby who is in need of breast milk. So let's say my mother give her breast milk to Nadira. Basically, Nadira become part of my family. So we are actually related. So we are actually siblings. So as we all know, once the person become a sibling, they cannot marry one another. So let's say in the future, if Nadira marry one of my siblings, then it's actually not permissible. Or in other way, it's also known as haram. So this is actually simple things, because Nadira know that my mother is her witness mother. So my siblings, Nadira can identify that my siblings is someone that she cannot marry. What if Nadira is an NICU premature baby who receive breast milk from these donors? Can she actually identify each of her siblings related to this so-called milk issue? So it's almost impossible to be traced back. So when Nadira grew up and suddenly met someone that she loves, and then they get married and have children, this becomes a problem, because she's not supposed to marry that particular man if, let's say, that man is actually her siblings. So it's actually the marriage is actually haram. So if we later affect the preservations of religion, other than lineage, it also affects our religion. So this is actually the thing that the main point that is related to religious issue for establishment of breast milk bank. That's all.
I would invite group 2. Do you have any other issues you'd like to discuss with regard to this question, ethically and religious point of view? Any extra issues?
Thank you, Dr. Azhar. Assalamualaikum and very good evening to all the event committee and expert panelists and also the audience. So actually, our group almost have the same recent issues regarding this, but maybe we will emphasize more related of mahramiyah lah, the kinship or relations that bar marriage. So for the first one, we will talk about the amount and number of feeding using breast milk. So amount and the rate of feeding the milk, even though the hospital can identify the donor, the source of milk supply given to the baby will not be limited to the one donor for each baby. The hospital will in fact give the milk from one donor to a few babies in the ward until the supply is finished. So for example, a particular donor's milk that has been processed will be kept in a bottle with a 50 ml capacity. So this will be split into the days feed for the babies. This means that even the baby is on full feeding, he or she will probably only get 2 to 3 full feeds from the same donor. This means that the baby will receive milk from different donors throughout the time in the NICU without knowing the total amount of milk consumed from each individual donor. The second issue is of uncertainty or jahalah, the status of dog that exists in the identity of the milk donor as well as in the amount and rate of milk being donated and cause the non-establishment of mahramiyah relationship between the donor and the baby. So according to Imam Shafi'i, if a man is in doubt whether or not the woman has breastfed him on 5 occasions, then he is not a mahram, not mahram to her. Likewise, if he is confident that breastfeeding has occurred over 5 times, but the woman doubt if those instances occur when he was 2 years old, then mahramiyah does not occur as well. So according to Mazhab Hanbali, when there is doubt whether breastfeeding took place or not, the number of breastfeeding occasion mahramiyah is not still not established. So mahramiyah will exist only if there is no doubt on the status of the donor and if the milk is also not mixed with other substances or with other donors' milk. So the third issue is a method of feeding. As we know, the babies are fed through a tube inserted via oral or nasogastro tube, and the trial of oral feeding will start only after 32 weeks, and milk is given in small amount. This is an issue that has been debated among scholars. Although the majority of scholars, such as Shafi'i and Hanafi, has established that all methods of breastfeeding can lead to mahramiyah, there are some differing opinion by several scholars who examine the meaning of Surah An-Nisa wa ummahatukum allati arda'anakum, which means and your mother are those who have suckled you. So according to several scholars, only the act of suckling directly from the breast of the woman would cause mahramiyah to establish. This is because the ummahatukum in that verse refers to the concept of motherhood as a whole, which include breastfeeding and also the bond of love between the mother and baby as a result from direct latching. So if there is no bond of love, no direct latching, so they consider that there is no breastfeeding bond. And he said that if a baby drinks the milk from bottle pumped from the breast and poured into his mouth, the sibling bonds is not created and the marriage is not forbidden. So that means female milk bank or donation is tolerated as long as the milk is coming to the baby by other means than sucking. So that's all.
Okay, thank you. And we move on to the third questions. What is the best way to prepare and run the services without ignoring the ethical and religious concern? So I'll invite group 1 first. What do you think is the best way?
According to Imam Shafi'i, milk kinship established when recipient receive breast milk from a female donor, which fulfill these 3 conditions, which number 1 is the wetness or donor must reach pubertal age. Number 2, the recipient must be less than 2 years old. And number 3 is the quantity of feeding, which is 5 feedings that satiate the recipients. The main reason for other Muslim or the Muslim majority countries unable to establish human milk bank is because of the as my friend mentioned earlier, pooling of milk from multiple lactating mothers, and also the anonymity of donors and recipients, which does not conform to the our Islamic laws. So to establish a breast milk bank, it needs to be Sharia compliance, which is no anonymity, which means that both parties, which is the donor and the recipients, must get to know to each other, must introduce to each other, and it must be consented, which by the donor and also the husband must consent to donate the breast milk. And the breast milk only given to save life, and the donor also can decide if they not desire for milk kinship, the feeding must not satiate the child, which is less than 5 full feeding, and the collection of milk must be verified by Muslim healthcare professional, and there must be a strict SOP to prevent the overlapping of mahram relationship when there is one donor with multiple recipient or multiple donor with one recipient. So regarding Islamic milk kinship, okay, as the husband and wife consent to donate the breast milk, they can decide whether they want to establish the milk kinship or not. If they decide to establish the milk kinship, they also can decide on how many babies they wish to have. So we can give more than 5 full feeds to the baby, and both parties, the donor and the recipients, are introduced to each other, and then they will sign a declaration form that saying that they are mahram, and both family will receive validation from Malaysian Ministry of Health or Religious Council. But if the husband and wife, the donor, do not desire for milk kinship establishment, so we need to record properly the quantity of feeding that must not exceed 5 full feeding.
Thank you, Dr. Shana. I will invite the second group for your opinion.
Assalamualaikum and good evening. I'm Amelina from second group. So I think the first group gave a very comprehensive opinion and answer regarding the third question, which is regarding what is the best way to prepare and run the services. So as we discussed before, there are a few issues regarding ethics and religious concerns. So in our opinion, the first group give a very comprehensive answer lah. But what I can add is that I think we need to provide proper guidelines that can be applied in our Malaysian community. So there are a few points that need to be considered in order to provide the guidelines, such as regulatory issues, the quality criteria and management, the data registries, and also the most important thing is the ethical issue and religious concerns. So first of all, regarding the regulatory issues, I think as a start, the current and future human meat banks should be registered with an appropriate national regulatory authority. For example, a hospital may need to be a certified mother and baby friendly hospital, or any independent milk bank may need to be integrated into the healthcare system. And also there's also need a policy recommendation so that we can facilitate the appropriate use of the donor human milk so that there is no exploitation of the human milk. And also for another important issue, which is a quality criteria of the human milk itself. So we need a proper guidance. So what we recommend is that we need to provide a very good guidance document to attain certain standards of quality. So the quality and safety criteria should cover how the milk bank is operated. We need, for example, it must be operated by trained staff, and also the recruitment of the donors. We need to properly screen them for any infectious disease, or is there if she currently smokes or use any illicit drugs. So this is one of the important points that we need to be considered. And then regarding data registry, I think this is very important so that we can understand and improve our technical and medical practice. For example, the data registries should consider to include the data of the donor and the recipient babies, and the data should include the demographic, the age, the number of pregnancy, the antenatal history, and also maybe in the future, we can use a very unique product coding system specified to human milk, just like blood. Maybe we need to a unique product coding system for human meat also, so that we can trace back the donor later in the future. And regarding ethical issues and religious concern, I think we need to properly the government itself need to monitor any potential of exploitation of human meat donor. For example, poorer women may be motivated to provide milk at the expense of their own health, placing themselves and their infant at risk. So our government need to properly monitor this kind of issue. Okay. And then in addition of that, informed consent should be obtained from the donors, from the fathers, and as well as the recipients of the human milk. So in conclusion, I think breast milk bank is a very good idea, because we can help the infants, but there are few aspects that need to be considered to provide this service. So I think that's all from our group. Yeah.
Okay, thank you, Doctor. So Alhamdulillah, we've listened to all the panelists' opinions, and I'm very happy to hear all your sharing just now. And I was involved partly in the creation of the Halimatul Sa'diyah Milk Center, and just I was involved with the data registry, like you said earlier, regarding the calculation, regarding the database of the donor and the baby recipient, as well as the to make sure that this donor, how many times has donated to this particular recipient. So, and in Halimatul Sa'diyah, we set it, we don't reach the maximum number of 5, and if there's not enough supply, we will ask the recipient, the baby's mother, as well as the donor mother, whether they consent to become the milk kinship. And both of them will have to sign a formal consent form, and they will be counseled properly with regard to the milk kinship, who is involved in the family, and they will know each other. They will be introduced to each other so that they can build their ukhuwah. And the other thing is, in our service, we don't pay money for the donated milk, and they also don't pay anything for the service. So the service is at the moment being run by the operational of the hospital, and sorry. So this is to avoid being, the exploitation for monetary gain, like said earlier. Inshallah, hopefully this model can be sustained as long as there are donors available, and the service is being promoted properly. And being a pioneer in this field is not an easy task, and everybody is looking at us, how we start it, and other hospitals are trying to replicate it, and it's a start of something new in this era, in this field. Okay, I would like to invite some opinion from our expert panel with regard to this issue. Ustaz Abdul Rahman, inshallah. Ustaz Abdul Rahman is our Sharia compliant in Islamic. So he has been actively involved in the creation of Halimatul Sa'diyah as well. Tafadhal Ustaz Abdul Rahman.
Assalamualaikum warahmatullahi wabarakatuh. Thank you, Dr. Azhar. I think Dr. Azhar is the true expert panel because they're really involved with the Halimatul Sa'diyah. I think the presentation is thorough. Just why we say that the fatwa kebangsaan and fatwa other bodies, Saudi Arabia and so on, say it's haram because first this see that the milk bank is not fall under level of daruriyat until now. Maybe hajat and tahsiniyat, because they are other way to provide the milk and so on. But as a medical, I think we need to come with data why we should give the milk, the human milk to the premature baby and so on, because we have enough data, and why we must give the baby. So the ulama and scholars will change their fatwa. So I think it's what we have done with the fatwa Pahang. We present the data and so on, and then they change their fatwa. But I think at the moment fatwa kebangsaan still said it's haram. So we need to another step to go to the fatwa kebangsaan. The second is, I think the important is education. First about the kinship, because kinship is very important. We need to know what's the implication of kinship. After this, what is kinship? Then because we have a taboo, the people out of there, they think that kinship is nothing, but it's very, very important. Very important is kinship. So we need to educate them, educate the others, the community, in order they understand why we have milk bank, and apa yang kita akan jaga on milk bank, this milk bank. Okay, that's all from me. Thank you very much.
Thank you, Ustaz. I would like to invite Ustaz Hasbullah and for your opinion regard to this matter.
Okay, I think it is sufficient enough. Okay, well, Abdul Rahman talk about that. Okay, just to repeat what has been mentioned by Ustaz Abdul Rahman. I think this is very good effort lah. Okay, but be careful not to misuse this facility, because it is involved the hukum of ar-radha' and hukum of milk kinship, and also as mentioned in presentation lah. So by proper control, inshallah, okay, we hope this effort will be useful lah, especially for education, inshallah. Jazakumullah khair.
Shukran, Ustaz Hasbullah. I would like to invite Prof. Ibrahim for your 2 cents.
Yeah, I think comment given by because the issue itself is not so established, newly coming out. So let us see what should be the future direction of this. Reasons given by the presenters may be reasonable, but also there is some concerns, ethical and also Islamic. So as far as those concerns are being addressed, then it should be continued until we see in the future. But one thing which you mentioned, I think, by presenter or maybe by or Ustaz Abdurrahman, is maybe Malaysia changed the fatwa. I'm not sure what are the grounds for that one, but maybe in the future or in the coming days, if there is any chance for this topic again, maybe our Ustaz can tell us more about the case of changing the fatwa. Fatwa goes with what you call with a case. Imam Shafi'i has two madhab, Mazhab Iraqi and Mazhab Masri. When he was in Egypt, when he was in Baghdad, in Iraq, he gave fatwa in one way. Then when he go to Egypt, he found that the case is different. The community is different. Many things are different. So he changed his fatwa. There is two madhab because of that. But in all cases, changing fatwa itself is something which is acceptable in Islam, as far as there is firm foundation or basis, strong basis for that. Thank you very much.
Thank you, Prof. Ibrahim. So back to our milk bank in Sussex, IUM. This milk bank has been a culmination of all the efforts from multiple parties for the last 3 years or so, including the pediatric department, ONG, breastfeeding counselors, the Sharia compliant unit, the microbiology, all sorts of departments work together, and we were in good discussion with the Mufti of Pahang as well, so that we want to make sure that this is a Sharia compliant from the beginning until the end, from the donor part down to the recipient part and to the milk kinship formation. So the SOP were so detailed that it satisfies the Mufti Pahang's with regard to the Sharia compliance. So inshallah, the formation of our milk bank center as a pioneer will open up the eyes of the people in Malaysia, particularly that this is possible. As long as we follow all these guidelines, it is still possible. I know being a pioneer is not an easy task, but it is possible, and it opens for discussion, for education, for clarification, and inshallah it's a new era, and it's something to be embraced. Even Prophet Muhammad was witnessed by two women in his infanthood. So it's not something haram, it's not something that is to avoid. It's actually something that can be emulated as long as we follow the Sharia, inshallah. So with that statement, I would like to end this session, and thank you very much everyone for contributing. I'll pass back to Dr. Saiful Ihsan for final remarks.
Right, thank you very much, Dr. Azhar, and thank you very much to all the participants and expert panels for their comments. Alhamdulillah, we have come to the end of our 2 days workshop event. I would like to thank to all, especially our expert panels, for staying with us until today, until this time. I know that this is quite packed to the panels as well as for the participants, but this is the only options that we have in order to compile the important part, which is the Tawheed, rules Al-Ibaadah, communication, medical ethics, and also common issues in medical practice. because we do not want to disturb the postgraduate clinical students' attachment to the hospital, also all the medical routines. So this is the best that we can do so far. So we hope that we're going to get feedback from the participant as well in the Google form in order for us to improve. And I really hope that this is not the only options or the only opportunity for all of us to learn about Islamic input medical practice. I hope it's an stimulation, and you can use this as part of on an initial part for you guys to embark and also to apply the things that we have learned to your patient, also your cases individually. So this is the concept. So you can learn and you can apply the individualized approach to your patient. I'm really happy to see the progress and also the presentation of all the participants. I think 100% of us will agree that the participants have able to present remarkably extraordinarily quality, and I think the quality of the presentation is superb. And I'm really happy with their knowledge and also the way that they present. Before I end, may I have 1 or 2 comments or opinions from the expert panels regarding our program for us to improve? Probably anyone, Prof. Ibrahim, Dr. Asbullah, Dr. Rahman.
Yeah, first of all, thank you very much for inviting us. And most important is to organize this kind of activities, because the efforts made to organize this kind of event is not easy. And I think Dr. Shiful and your team must be appreciated and thanked from the Kulliyyah and also from the community of your students for this kind of event, because I believe that it is not easy to come up with this kind of programs, planning and practicing as well. So may Allah reward you. And second point is to be continued. You know, this is maybe beginning. You should create series of this kind of events with different topics, which is accumulative. Accumulative, that means you try to carefully choose the next session should be what is addressed with maybe consultation with some experienced people to find out the more suitable title to address. And this is a continuous mission, I believe, and the best mission. Okay, to do something is good, but to do it in best way is even more better. So medical professional is already very important, but sometimes being not used in the proper way. So this mission or this kind of activities will bring back the situation in the proper place. One thing which I admire it is presentation done by maybe even by our doctors who are maybe not Muslim. That is what I guess. Yeah, that is actually most integrated step which need to be encouraged. That means they get very great knowledge, and they are even explaining Quranic ayat and explaining very well even. Okay, remind me when I was teaching in 2003, I have one student who is a non-Muslim, but he gets the highest mark in Islamic course, which we call the Islamic worldview. So this is the best of the UIA, I believe. So I encourage them and thank them also for their knowledge. Thank you very much again. Wassalamu alaikum.
Thank you very much, Prof. Ustaz, one last comment, last feedback to Ustaz Asbullah.
Okay, Alhamdulillah. I think this is the right channel to explore the integration between Islam and medical practice, and we sit together as Islam provide proper framework, okay, in terms of conceptual knowledge about medical practice, and people in medicine with their clinical way. So when we meet together, we can fix one another, okay, in order to understand the concept or to understand the problem and to understand the procedure, okay, the process. So we can find, okay, what is the best the best way from Islamic perspective and from medical perspective. I think this is a very good channel, okay, to us to do integration, okay, between Islam and medicine, inshallah. Okay, and congratulate to all participants and also yang menganjurkan program lah. Okay, wallah.
Thank you very much, Ustaz. Thank you. Ustaz Abdul Rahman, any last feedback? Ustaz Abdul Rahman, for us to improve.
Thank you very much for inviting me to contribute in this workshop. It's very beneficial. I hope this workshop will continue for the next time, inshallah. Thank you very much.
Thank you. Thank you very much, Ustaz. Thank you everyone to all the participants and my beloved community members. Thank you for being patient with me, and thank you for all of you guys that have made this program successful. Now you guys can scan the MMA QR code on the screen, and you will get 12 CPD points for medical doctors 4+8. I wish and I pray that all of you guys have benefit this session, and also pray that all of you guys will pass your part 1, part 2, and part 3 clinical examination with one attempt. Inshallah. Amin ya Rabbal Alamin. With that, let us end our session with a tasbih kifar to us. Inshallah, we will share the recorded version video of this session via email as well in WhatsApp group. And I would like to also announce that tomorrow we will conduct ICPC title Advanced Medical Advice from Islamic perspective will be presented by Department of Finance, IIMP, Kulliyyah of Medicine, and I will share the details in the WhatsApp group as well. Thank you very much. Take care. Assalamualaikum. Have a great safe journey back to home for those who are traveling. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.